Check, check, 1, 2. Check, check. Check, check, 1, 2. Check, check.
So, New Mexico has three different Medicaid managed care organizations.
Yeah, I'm still going back to Zoom. Zoom's still going out. There you go. Check. 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 1, 2, 3. Yeah, that should be getting there. Yeah. Yeah, that should be getting not to that, to the Zoom. Is it hitting your Zoom input? According to this, it is. Yeah. 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 Zoom input. Yeah. Okay. So that's good.
morning. There we go. All right. How's everybody doing this morning? Okay. Those that are here, you're champions in my heart and in my soul. I'm proud of you. Okay. We appreciate everybody being here. We're going to kick things off with an amazing speaker this morning. Amy Riegel, Senior Director of Housing at CareSource, is going to come up and speak with us. She's going to talk about the topic, developing partnerships with community-based organizations to engage vulnerable populations, reduce social barriers, and improve health literacy. So something very important to what we're talking about this week. Amy Riegel, as the Director of Housing at CareSource, plays an integral role in building a new division of CareSource that will transition current Medicaid members off of government subsidies and into a high-quality life. Prior to joining CareSource, Amy was with the City of Dayton for 10 years, serving as Manager of Community Development and Grant Administration. Amy provided policy leadership to the city in areas of housing development, asset-based community development, education, and homeless reduction. During her tenure, she oversaw the administration of over $200 million of HUD funding and used forward-thinking strategies to provide a 3-to-1 leverage with private, local, and state dollars. Amy is a native of Ohio, Springfield, a graduate of Wright State University, has her housing development finance professional certification from the National Development Council, and she is proud to live in Dayton with her husband and 3 young daughters. So please please join me in welcoming Amy to the stage.
Good morning. So I guess I am your wake-up call this morning. I am what goes with your coffee today. So thank you for joining us bright and early. And so, yes, today I'm here to talk about CareSource and our work with community-based organizations. So CareSource is a nonprofit health plan that serves 6 states and about 2.2 million members. All of our members are on government-sponsored health care, so Medicaid, Marketplace, and Medicare Advantage. But even in all of our products, we mainly focus on individuals who are low income or who are kind of bouncing back and forth between low to middle income. So we have been very focused from the very beginning on social determinants of health. Our founder actually was a social worker who came out of the world of jobs and family services. So it is truly in our DNA that healthcare can never happen without the social determinant. So before this was even cool, we have had this as part of our backbone since the beginning. And so I think it's I remember I've been presenting at some of these conferences for 4 or 5 years now, and I remember when I used to put up this slide and I would get people afterwards who would really fight me on this slide. I think we're now to the point where it's pretty accepted that the social determinants of health are what make up the greatest impact on a person's overall health and well-being. And it's everything that's happening outside of the doctor's office, and that your zip code is a stronger predictor of your health outcomes than your genetic code. So this is really where we focus, and then integrating that into all of the other parts of our business. And so we focus on 4 pillars within our social determinants of health: food, workforce development, social isolation, health equity, housing, which is my space and where I really love to geek out. So if anyone wants to talk about housing policy or housing interventions, set aside, half a day or so, and I'd be happy to talk to you. And in the room today are my colleagues, Tony Jones and Terry Hoddle. They also work in this space and do a lot of great work with CBOs, community-based organizations, and doing an integration. And I'm going to mainly talk today about housing, but if you want to talk about food, Tony can talk to you all about working with food banks and Head Starts and different organizations, and Terry really works with the workforce development and can talk about working with employers as a community-based organization to help us take our efforts out into the community. And so as we think about housing and how we can work with CBOs and do our intersections at a housing location or with housing partners. So as I was thinking about this, I I thought back to how important our housing is and how we root so many things in housing. And my best friend and I, we've grown up together since we were 5 years old. And a few years ago, this was actually, I'm getting too old, this was actually now, probably like 15 years ago, she came to me, she had just bought a new house, and she and her husband were just getting settled in. We were in our, late 20s. She was getting started in her career, like, doing okay, had just bought a house, but, not a lot of extra money laying around. And we go out to dinner, and she says, I bought the best purchase of my life. And I was like, okay, tell me what this is. She said, I bought a vacuum. All right. I stole mine from my parents, but tell me more about your vacuum. She goes on and on and on and tells me about this vacuum. And it ends up that someone had come to her house, door to door, selling vacuums. They brought the vacuum inside, they did demonstrations, and she was so blown away by this. On the spot, she buys the vacuum, the $1,000 vacuum. $1,000 for it, and right, we're adults now. I can now understand. But when I was in my late 20s, I was like, "You spent $1,000 on what?" And I was like, "I would never do this." And she goes, "But the guy, he came to my house. He was at my door. He had the vacuum with him. He vacuumed my carpet." And I was like, "You are a crazy person. I can't believe you bought this vacuum." My family would have never done this. But then I remembered we had this set of encyclopedias in my house growing up. And this, on today, I'm from Ohio, it's a snow day. I would have been sitting there reading these encyclopedias that my parents bought from a person who was going door to door with encyclopedias and selling them, convincing parents of the 1970s and 80s that if they did not have this set of books in their house, that somehow their children would have a great deficit, would not be prepared for the world. And there were 27 volumes of this that the door-to-door salesman was taking around. And I did sit there and think, well, I'm glad we have grown out of this, right? We've gone beyond this stage. This is no longer something that we would think about. Just because you bring it to our door doesn't mean we will buy it. Or will we? These cute little girls will probably be coming to your house soon. They will have those little green boxes. You can't eat less than a sleeve at a time of those Thin Mints. And you will shell over $5 a box for 27 cookies because they came to your door and they were so cute, and it's for a good cause. It is so wonderful, right? We're supporting the future of America. And that's why we do it, right? When people come to our house and they sell something that's for a good cause, that's why we do it. We would never just buy things, right? If it came to our door. Although this might be your front porch too. This is not my front porch. Mine, I would be a little more discreet now that I work from home and running downstairs when I hear the Amazon truck and pulling them inside before my husband sees how many packages arrive in one day. And I'm pretty sure my kids have no idea. They're 6, 8, and 12. I'm pretty sure they have no idea what an ice cream truck is, but they know the Amazon truck. And they come running "Is it for us?" I'm like, "No, it's for the neighbor today." And they're like, "Oh." But this is all of us, right? They said, "We'll deliver it to your door. We'll deliver it to your door in 2 days." For some who live in a big city, they could deliver it to your door in an hour, right? Especially in the pandemic, we live by this. This is how our Chipotle comes to us now. This is how everything happens now, is it comes right to our door. So as CareSource was building out our outreach around social determinants of health, especially when the pandemic hit, so back in April of 2020, we thought to ourselves, how are we going to reach people? How are we going to help those that we serve? And my true advocacy was, at any point in time, but now even more in the pandemic, we need to go where people are. We say we want to meet them where they're at. Where they're at is at home. And so how do we partner with housers to be able to take this work and meet them at home? But as we start reaching out to housers, housers aren't necessarily in this space. Some are. Some of the big groups, some of the bigger public housing authorities, they might be thinking about this. I think that if you were to talk to food banks or if you were to talk to community action agencies, they might be a little bit further along in this process. But when you start talking with housers, you're really starting oftentimes from ground zero with them. Or you might be starting in a bad place because someone's approached them before but never delivered or made promises or did things, and now they're really protective over whether or not this is a good idea. So as we started these partnerships, we really wanted to stay focused on what our main objectives were. And we wanted to make sure that we really were enhancing a community-based organization when we approach them. So these are just kind of some basic tools that you can use when you think about approaching those community-based organizations, and especially, in my case, I'll talk about housers. And the first one is seek to understand, not to solve. And this is when you meet with someone, talk to them. Find out what they're doing. Find out what type of housing they provide. What services do they provide? How are they funded? What do they do? Is there a bingo room? Is there not any space for community activities? Just really get to know. Spend time, meet them on site. I know in the world of COVID, this can be hard, but meeting them on site, asking them maybe even to tour a unit. These are all really helpful to understand what the true needs are for the residents who are living in these communities. You can use data. I know there are a lot of data folks out there. You can use data to do this, but there really is something that comes from being on site and really digging in and feeling the environment of these housing units. There, oftentimes, if you're in a rural community, a housing complex might be just 20, 25 units, but in a big city, this could be a 300, 400, 500 unit complex. So you really are getting bang for your buck in reaching out, but it also means that there's a lot of diversity and thought that goes in to working with them. Start strong but small. I work with a lot of organizations that kind of want to solve world peace before they try anything. And so it is good to get to the point of data use agreements. It's good to get to the point of being able to integrate things and track it and all that. That is the goal. But I encourage you to start small. Do something little. Do something very meaningful but small to start building that relationship together. CBOs are often very underfunded, very short-staffed, and very overworked. So if you take that and you ask them for 7 one-hour meetings and nothing comes out of it, they're not going to be happy. So make sure that you start building little things to get that moving. And focus on today, but build to the future. Same thing right there. Do what you can today with a vision of what you want that to look like in the end. Utilize your capabilities to the fullest. As health plans, I think this is often hard because we have so many capabilities, and sometimes we might not understand what we have. Or if you're a corporation, you might not understand what you have. Whether it be influence with government officials, being able to help push legislation, helping them fill a table at a fundraiser, but it also could be sharing data. If you have the data, are you willing to share aggregate level, not PHI, aggregate level data? Or are you willing to have a community health worker come out and do some training with the staff there. There could be a million ways, but how are you helping to help that organization succeed? And to that, you need to give more than you receive. We're actually really bad at this, right? Sometimes these are so set up for ROI, and they're so set up for outcomes and optimization that we forget that these CBOs are underfunded, understaffed, and overworked. And we're not giving them as much as we're getting back. So when we talk about wrong pocket or that, you know, it's the wrong, the benefit isn't going to the right place, we really need to say, are we that benefit? And are we not sharing equally with our partners? Tell the story. You probably have a way better PR team. You might actually have a PR team where the CBO may not have a PR team. Help them tell that story. Help them get it into the newspaper. You know, a news crew to come out. Perhaps it's a national publication. Sometimes it's just getting it on your social media that means so much to these organizations. Help bring them to a conference like this and have them present and talk about the success. And then stay at the table. So back in August of 2020, CareSource made a $50 million commitment to invest in affordable housing. And the first thing that I said, because sometimes they thought of it as well, we're going to get this done, and then what's next? And I said, we're investing $50 million for 10 years. We need to stay at the table for 10 years. These aren't airdrops of money. You need to stay at the table and continue working with those partners, because that is just the entry point. I know that sounds like a crazy entry point, right? $50 million. Only at a health plan would that be the entry point. But that's just the entry point. All the good stuff is when you stay at the table. It's kind of like going to dinner after you have the coffee. Those who stay at the table, that's when the best stories are told, right? Stay at the table and see what's going to happen next. So as we think about this, I want to give a few examples of things that we have done in working with housers to really integrate and work towards health equity, health literacy, and improving access to health care. So one effort that we did was at the beginning of the pandemic, it was very clear that there was a gap in digital equity. And so what we were seeing was that there were many people who did not have access to Wi-Fi or the devices that you need to be able to access the internet efficiently. I'll put it that efficiently. Lots of people have smartphones, but they really weren't able to have consistency in that access. And so I think also at the beginning of the pandemic, there was an assumption that this was a rural problem, that it was for those counties that were very underpopulated, and, you know, it was a problem in less densely populated areas. What we actually found was that in urban areas, there were actually telecommunication deserts. So just as you would think about grocery deserts or transportation deserts or whatever it is, there was telecommunication. Most cities are very segregated, where the low-income individuals live in kind of one section of town. We have very much cut up our communities in that way. And so in those areas, what we see is that there was no 5G, there was no fiber that was lit up in those areas, and it was a huge dead spot. But then when we talked to the cities and the counties, they would say, there's fiber laid underground in all these areas. We did it during the 2010, 2011, 2012 funding, and no one ever lit it up. So we went to the telecom companies and we said, we need to light this up. And we really focused it on a couple public housing assets. And so we worked with the Public Housing Authority in Dayton. We picked 5 housing complexes, which totaled 1,000 units of housing. For us, it represented about 800 of our CareSource members. And we helped them light up so that they received free Wi-Fi in their units, and every household received a Chromebook. When we launched, COVID time, right? This was launched at the end of 2020. We actually had our IT staff, they agreed to come on site and help us distribute the laptops, the Chromebooks, and help the people set it up. And our IT folks, I don't know about your guys' IT folks, right? They're usually not the ones who are like, can I volunteer at an event? Oh, I'd love to stand out and talk to lots of people. They were so excited. They were falling over each other to go out and do this. And so they sat and they worked with the residents. What we found though was there were many residents who had never had an email. And the Chromebook required that you had an email to log on. They had no idea how to turn on a computer. They had no idea how to get onto a Wi-Fi system, what to do, how to use, it had the touchpad mouse and everything like that. So they literally were going very much a very step-by-step process with the residents. We realized that it was so intense to the need that we then set up clinics at the housing complexes with different IT staff where there was kind of office hours, and people could come down at their own leisure and bring their Chromebook and tell them what was the most important thing for them to log on to, and that the IT staff would help them log on and figure out how to utilize it. It might have been Skype or something like that so they could talk to their grandkids, or it may have been telehealth or playing, a game or something like that. It didn't matter what it was. We were there to help them learn and become more comfortable. What we have found is that it is used significantly within the housing complexes. We do still see that a lot of people rely more on their smartphone than they do on the Chromebook, but they do have those Chromebooks now. And when you log onto it, it's like a hotel. There's a captive portal where you have a landing page where you have to go and sign in when you access the internet. And on that page, there are click buttons for different resources within the community. We started with lots of click buttons. There's a CareSource click button where they can learn more about CareSource. But we did put up a click button about COVID-19, and from there they could get videos, they could talk to a nurse directly about, at that time, getting their vaccinations, about symptoms, all of that. That was the most popular button by far. That was just clicked on constantly, and what we saw was people kept going back and doing more and more when they clicked on that button. And as we think about hesitancy or resistance, what we saw was that people kind of that motivational interviewing, stages of change, they could move through that on their own. Which led us to the next effort, which was we started reaching out to those housing complexes and say, do you want to have a vaccination event on site? And many of the housing complexes had where the residents could come down and get vaccinated, but we said, let's make this a little bit more interesting. And what we would do is have actual events where if it was a family housing complex, we'd have bounce houses and popcorn and balloon animals and all kinds of stuff like that. All of the plans in Ohio went together, and we were all working as one to be able to do these vaccination events at the different locations. At one location, we were able to have 79 individuals vaccinated in 2 hours at a public housing authority complex where when we look at the gaps in care in that these are individuals who never had an immunization, and they were coming down. But what we saw is that people would come down, they'd talk to the local pharmacist, ask lots of questions, they'd go back to their apartment. They come back, ask the pharmacist more questions, go back to their apartment. Come back, ask the pharmacist more questions, and we let this happen, right? They could go back and forth, and finally they say, okay, I'm ready. We were at one complex, and a woman kept coming down, and she was a recovering heroin addict. And she said, the needle really worries me. Is there a way you can give me this vaccine without the needle? And the pharmacist explained to her, it's not possible. Like, we have to use the needle. So she got a support person, she got a friend and others who were in her circle. She wrote down a plan of how this wasn't going to be a trigger for her in being a event that might destabilize her sobriety. And so she made a plan to go to a peer support meeting. She had lots of different options to make sure that this wasn't something, because she had a lot of anxiety about the vaccination. We then took this to a housing complex that serves transition age youth and homeless youth. And there we were spending hours with members because they didn't have their member card. They didn't know their social security number, right? They had so many pieces of missing information, but we just had a team of people who had cell phones, and they were calling all around and saying, okay, do you have their social security number? Okay, call all the health plans and figure out which one that they're on. Okay, now we have their member number. Now we can put this in. And making sure then that they got there in Ohio, they received gift cards for getting the vaccination, making sure they got their gift card, and that they knew where to come back and get their second dose if they chose to get one of the 2-dose vaccinations. We have done over 200 vaccinations this way of going on site, but the thing is, it is about the vaccinations. We're really glad we reached almost 250 people with these vaccinations, but it's really about the relationship we built with the housers, because now they're saying, well, what could you guys bring next month? Hey, spring's coming. Do you think you could have a clinic where you're looking at diabetes? We have a lot of people with diabetes. What could you come and do around that? And we're like, okay, the door is opening. We're staying at the table. We're telling the story. We're helping them promote these activities, and we're really helping shine about the work and the health and equity that they're bringing to their residents. And that's what keeps it moving forward and what makes it successful. So these are just a couple examples. I encourage you, if you don't have housers on your list back at your office of people to reach out to and people to integrate with, I think it's a key way to be able to get things out into the community and really help improve the overall health and well-being of those that we serve. So thank you, and if there are any questions, I think I have like 2 minutes.
Questions for Amy? Oh. Hi, Amy. I'm Cam Teams from Cordata in Cincinnati. My question is, I heard you talk about the Chromebooks in every household. Fantastic. What about phones? You mentioned you found about the technology deserts. Have you offered phones?
So what we've, well, hold on first. I have to say, I am not a Cincinnati fan, but everyone in Ohio now is Who Dey. Like, sorry, any LA Rams fans out there? No. So what we found, and we've done a lot of outreach, is that most of our members do have smartphones. They might not be using the smart aspects of the phone, but they have the technology. So we actually found, what we did also find was that the schools were giving out Chromebooks, but when the parents or the guardians got the Chromebook, they actually had to sign a contract that said only the student would use it, and if it was used outside of school hours, that they could actually be expelled. The student could. And there were these crazy contracts, and so this was one that it does not stream, you can't do like Netflix, but they could use it for whatever or whoever they needed to, and so it gave more flexibility. But we see pretty good uptake with the phones, and we do help connect people to national resources if they don't have a phone.
Okay. Thank you so much, Amy.
Thank you.
Thank you, Amy. That was a great way to lead out the morning. See, we've had some more people trickle in, so outstanding, gang. We're going to keep right on rolling here on this Friday, February 4th, with our next session entitled Building Program Value in Hard-to-Reach Medicaid Populations. And so I think we're going to have one in-person and one virtual speaker. Is that right? Yes. Awesome. Okay, so we've got Greg Gold joining us who's an engagement specialist with Impulse Mobile. And we have Amir Wadajo, Director of Medical Management, Western Sky Community Care, who is our virtual speaker. Amir is currently the Director of Medical Management at Western Sky Community Care, a Centene health plan serving Medicaid, Medicare, and Marketplace members in the state of New Mexico. Certified case manager, she lives in Albuquerque with her husband and 3-year-old daughter and has almost 20 years of experience managing government-funded programs for TANF, SNAP, Medicaid, and Medicare. She enjoys gardening and going for long runs with family and friends. So outstanding. So Amir is virtual, and we have Greg with us. So take us away, guys.
Hello, good morning all. Thanks for joining us today. Excited to talk to you about the outcomes we were able to drive for Western Sky in New Mexico. My name is Greg Gould. I'm an engagement strategist with Impulse Mobile. My role there at the company is to help design communications products, evaluate the performance, and help improve them to drive the best health outcomes possible for our clients and partners. As we mentioned, Amir is over in New Mexico. It's 6:20 right now, so she is not presenting live. We're just going to play this video, and we will get it going for you, and then we'll take some questions at the end of the session.
So New Mexico has 3 different Medicaid managed care organizations, and Western Sky Community Care is fortunate to be one of the 3. And so we are a health plan that started in January of 2019. And so we serve an array of members from Medicaid to Medicare to Marketplace. And we are just shy of about 95,000 members total, with, of course, Medicaid being our largest product, around 85,000 right now. And so as we, approach our membership, we are always member-centered. We want to look at how we can best serve our population, making a difference one member at a time. In terms of New Mexico and our statistics overall, we are the 5th largest state in the union. However, we are incredibly rural. We do have, I think, more cows than we do people in the state of New Mexico. And so our population is about 2 million residents as of 2021. However, about half of our residents in the state of New Mexico are receiving Medicaid benefits, as well as other forms of benefits like TANF and SNAP benefits. So looking further into how Western Sky has partnered with Impulse, we started in 2021, looking at different campaigns and different types of member outreach that we wanted to see an increase in engagement. One of those campaigns was our electronic visit verification. And this, of course, is targeting our members who are receiving LTSS benefits, just to ensure that they are receiving the caregiver support based upon the schedule and frequency in which they need. So this method of communication will have the member confirm whether or not their caregiver showed up on time, whether or not they're safe, and how we can further support them with their caregiver services. The next campaign that we've partnered with is through our well child visits. And this, yes, is a performance measure. However, it's a great opportunity for us to improve for the state of New Mexico. We did just receive feedback from the 2021 Kids Count data, and it does show that overall well-being for our well child population, New Mexico is ranked 49th. And so that's on the not good end of that ranking scale. And so looking certainly at how we can, especially through a pandemic, engage our members, engaging parents to remind them of the importance to take their children to those important well child visits. The next campaign here is through ED deflection. And this is reminding our members who are our most frequent emergency department users of other options that are available for them to seek. So establishing with a provider, seeking an urgent care in their area, looking at different methods in which they can engage with a provider versus going to the emergency department when it is not necessarily in a true emergency. And so sending out this regular communication to those members who are targeted as our frequent utilizers has helped to just overall increase that communication and awareness. And then we have two campaigns who are strongly focused on our maternal and child health initiatives, and that's postpartum as well as prenatal notification of pregnancy. And we'll spend some time going over the prenatal and notification of pregnancy piece. But in terms of postpartum, not only was this identified based on our performance measure performance, but it's also just to, encourage our moms also during a pandemic that, hey, it's important to take care of yourself after you've delivered a baby. In addition to, of course, having your child and your newborn attend those important pediatric appointments, but ensuring that you're able to meet that appointment with your provider between 7 and 84 days postpartum is incredibly important as well. And so through our implementation process, we've looked really at how can we streamline this process. And our Impulse partners make this process incredibly seamless for us. Number one, we looked at bundling our materials for our regulator to review. Being that the materials are member facing, we are required to have our regulator review and support the program implementation. And so by bundling it, it also decreased the amount of time that it took for our regulator to review these materials. In New Mexico, and I'm sure in other states, we do see pretty significant amounts of time for our regulators to review and support the initiative, understanding that it is, of course, initiatives that are going to help increase engagement and help support our members. And so once we were able to receive that approval from a regulator, then we had the great opportunity of actually testing it. And so as a business owner, it was great to test the actual workflow to see what our members would experience, to learn, what does the workflow look like for them in terms of receiving text messages, is this going to be from like an unidentified user? What is the experience from the member's perspective? And so being able to test it out really helped us to navigate through that process. And then we went live. And so during the go live process, it was super exciting to be able to, get feedback from our members almost instantly. Our staff were telling us that members were calling in and saying that they were receiving these notifications, as well as providers and other, agencies just, notifying us that, yes, we're live. This is a form of communication that we are utilizing to reach our members, and also receiving that feedback. So now let's talk a little bit more about our prenatal and our notification of pregnancy campaign and why this is so important. So our Start Smart for Your Baby program is a clinical program. It originates back to 2008. And doctors Mary Mason, Amy Polyager, Brad Lucas, they all created the groundwork for the interventions for Start Smart for Your Baby. And this program has really just set the standard in terms of maternal health and child programs. So research illustrates that pregnant members who have early and regular care during pregnancy are more likely to have better outcomes with a healthy baby. And at Western Sky, we want to encourage our members to see their doctor as early as possible in the pregnancy. Early visits, we know, allow the member to get an accurate due date, establish the health of mom and baby, and then also to allow the doctor the opportunity to do additional screenings if they're necessary to prevent or to just better manage any significant health risks that may affect the baby or mom during pregnancy and potentially after. And so looking at our key outcomes for Start Smart for Your Baby, the first one, of course, is to decrease preterm delivery rates. We know that preterm birth is the leading cause of U.S. infant morbidity and mortality. And preterm labor is labor, as we know, that begins before 37 weeks of pregnancy. Premature babies can have serious health problems at birth or even later in life. And so again, it's important to intervene early and to provide that support as much as we possibly can at an early stage. Another goal of our Start Smart program is to decrease C-section rates, also to decrease low birth weight rates. And low birth weight is, when a baby is weighing less than 5 pounds, 8 ounces when they're born. And some babies with low birth weight are perfectly healthy. There's no issue, even though they are small. But being of low birth weight can cause some serious health problems for some babies, whether it's short-term or it's long-term. And a baby with low birth weight, they may have problems eating, they may have problems gaining weight, fighting off infections. And about 1 in 12 babies currently in the United States are born with low birth weight. And you can see here as well, 1 in 8 babies that are covered by Medicaid are born prematurely. And so this is really just a call to attention. What can we do? As a call to action, how can we help to support our moms? How can we help to support our babies to prevent premature births, to prevent low birth weight, and also those complications? And our Start Smart for Your Baby care coordinators are nurses, and they work with our pregnant members to provide prevention, education, resources, incorporating various concepts of care management, care coordination, disease management, health education, overall to improve the health of pregnant birthing parents and, of course, their newborns. And a key piece of our program, the key piece of the Start Smart program, is really member identification. And that has to start through the notification of pregnancy. We are able to identify members that require outreach for a notification of pregnancy through claims data, our state eligibility files, and various referrals we may receive from members, from providers in the community, or even health plan staff. And so the NOP is really that entry into the program. It identifies members that may have previous risk factors as early as possible. Perhaps they've had previous preterm deliveries. Perhaps they have maybe substance use that's been an issue they've been struggling with during the pregnancy. It also assists with establishing a relationship between the member, their provider, and the health plan team member. So going through this questionnaire has been helpful to build rapport and build trust. And without that, it makes it very challenging for us to really make a difference in our members' lives. And as I mentioned before, completing that NOP, it will automatically enroll a member into the Start Smart program. But it also, by completing the NOP, we're able to get the information we need to better stratify their risk level. Are they high risk? Are they moderate risk? Are they low risk? Do they even need our assistance from a Start Smart care coordinator, as well as what is the frequency of the outreach that we need to do in order to help them along their pregnancy journey? There are some areas, of course, in which claims data really is just not as effective, right? So through the NOP, we are able to identify important data like the member's due date. When are they due, so that we can then prioritize our interventions to the appropriate stage of pregnancy and support our members at the best stage based on their gestation age. Updated contact information, as we know, being able to find an updated phone number for our members, as well as a mailing address, can be a challenge. And that NOP does significantly help us to increase that successful engagement with our members. And we are finding that about 25% of the time, the address that the member reports on the notification of pregnancy is different than what comes through the eligibility file. Looking at social determinants of health, as I mentioned before, claims they're not going to tell us whether, a member is experiencing homelessness, domestic violence even, or food insecurity, but the notification of pregnancy will do that. And then lastly, looking at the NOP can help us to better establish what are some of the current and previous behavioral health and physical health conditions or needs that the member may have. Now we're going into some of our strategies. So of course, we've discussed that obtaining that NOP is key, right? And so how do we go about increasing our rates of NOP completion in order to more effectively help our pregnant population, therefore being able to better help our newborns? And so interventions, looking at our NOP completion rates, members can, of course, complete them. They can send them in via mail. They can, somehow they can get faxed in if they have access to doing so. They can also call our health plan at any time and complete the NOP with one of our team members. We do provide incentives. So we do provide a $25 Visa gift card for completion of the NOP. And then once they graduate from Start Smart and attend that 8-week postpartum appointment, then they're also eligible for another $25 Visa gift card. So financial incentives are certainly helping to increase engagement. But if our members are not aware that we offer that service, then it's a moot point, right? The next piece here is looking at providers. So we offer up to $75 per NOP completed per member by the provider if it is done within the first trimester. And so really incentivizing those larger provider groups to complete those NOPs because they have that information. And the good thing is that once we get the NOP from the provider, we know then that the member has already attended that prenatal appointment and they've confirmed their pregnancy and they're getting the help they need from their provider. Telephonic outreach is something that we've done since day one, and we still do outreach telephonically just not, the engagement that we would like to receive. We do palm outreach campaigns where we target about 500 members at a time through an auto dialer to try to, attempt to engage members to complete the NOPs that way. And then we look at incentives outside of the standard gift card, right? So we have virtual baby showers that have been a great pandemic pivot for us. We want our moms to still feel celebrated, and we want them to be able to network with other expecting moms as well. And our virtual baby showers have been just the platform for this. We experience anywhere from 50 to 100 moms at a time on a call where we're able to explain resources that are available. We explain, different educational materials and tips and tricks on how to navigate through their pregnancy, things to look for as well. And after the baby shower, we do send them a baby shower in a box where they get a car seat. They get, Western Sky branded passies, blankets. They also receive a diaper bag, diapers, you name it, a bunch of goodies to help them celebrate welcoming their newborn. We also offer different services like a holistic care grant, which is a $250 Visa gift card, wellness materials, including safe sleep information. We have a puff-free pregnancy program, which is smoking cessation for our members. We have Moms Meals, which is a really cool opportunity for us to support our moms who've just delivered and they're at home. We know that, once you're at home, trying to cook for yourself and your family with a newborn can be a challenge. So we do offer meals, deliveries service to moms once they've gotten home from the hospital. GED prep, helping them with breast pumps, and various different home visiting programs that they may be eligible for. So overall, just looking at some of the challenges we were experiencing with the method in which we were outreaching to our members is just getting the member to answer the phone. Right. And whether that's, you've got busy life schedules, you're working maybe, 8 to 5. I know for me, as a first time mom, my daughter was in the NICU, and the case manager from my health plan kept calling during, the times where I was in the NICU. I'm certainly not going to break from spending time cuddling my daughter to answer the phone. So looking at other methods in which we can engage was key. And maintaining a valid phone number, of course, is a challenge. And it's just, doing the research we can to find the right phone number. At any given point in time, we would experience about 500 members that did not have a completed NOP. And so that was our call to action as a health plan. We had to do something to see an increase in overall member engagement. And so here's what our notification of pregnancy campaign so far looks like as we've partnered with Impulse. So we had the opportunity to take our standard 2-page notification of pregnancy. We reduced that down to about 7 total questions. And those are the key questions that are going to help us to better understand the state of mom and her health and where the trajectory of the pregnancy may go. And so the first question is, can you confirm if you're pregnant? Next, can you confirm your due date for the pregnancy? And then also questions about, have you experienced any preterm labor in the past, any previous preterm deliveries or complications? Looking at, do they have diabetes, hypertension, things of that sort from a physical health perspective that might lead to more complications during the pregnancy. Also asking if they're safe. Do they have the resources they need? Any issues or concerns around substance use, things of that nature. And being able to test this process from my own personal cell phone, completing the survey, it took less than 1 minute. And so this is something that is certainly quick and easy for our members to do, and also opens up the bridge for additional resources that they can receive, such as Pacify. Now, Pacify is a lactation consultant app that we've partnered with since we went live as a health plan. And essentially, it's called the 24/7 lactation consultant, like the Uber of lactation consulting apps. So you can FaceTime with a certified lactation consultant. And they can also walk you through things like maybe baby's not latching appropriately, or maybe there are some concerns or issues with, milk supply, and transitioning over to solids. So they can use Pacify until baby turns 2 years old to ensure that baby is on the right trajectory towards nutritional health and wellness. Through Impulse, they're also able to receive pregnancy tips, So important tips on how to stay healthy, how to have great nutrition while you're pregnant, exercise recommendations if that's something that mom wants to do or is able to do. And then also looking at just, taking care of themselves while they're pregnant, providing those regular tips, encouraging prenatal care with their provider as well. And so just some preliminary data that we have since our NOP campaign went live in September of last year to January here in 2022, we had 2,277 members targeted for engagement through Impulse. Now, the great opportunity is that our members had the opportunity to confirm whether or not they were pregnant. So all along, we had been reaching out to members through claims, and perhaps something has changed in their pregnancy. Perhaps there was a miscarriage or the pregnancy wasn't viable. Unfortunately, that does happen from time to time. And so we were able through Impulse to confirm their pregnancy status. 252 members did confirm that they were no longer pregnant or expecting. So we were able to then take action and do additional outreach to provide support, refer them to a local agency, and then ultimately to remove them from our outreach so we're not constantly asking them about their pregnancy if they're not pregnant. And then next, we had 544 NOPs completed. Now, every NOP completed has the opportunity to save a life or to help enrich our moms' lives or our baby's life, and just wrap around support to our moms. And so that's a 24% completion rate, which is just amazing for the amount of outreach that we had been previously doing telephonically and not quite getting to that percent of engagement. And overall, our engagement thus far has been at 39.3%. So looking at about 896 members who have responded through our NOP campaign through Impulse. So we just look forward towards continuing to partner with Impulse to meet our members really where they are and how they want to be engaged. It's really important that if we want to continue to see positive outcomes and to be able to do the work that we want to do by making a difference one member at a time, we have to do so in a method in which our members are agreeable to, and it's also convenient for them to do so as well. So we just look forward to continued partnership, growing and pivoting our campaigns where we can, because our member voice is just incredibly important, and it's evidenced here by our engagement rates and our statistics with completion rates here. So at this time, I will turn it back over to Greg. Thank you so much.
Great. Thank you, Digital Amir.
And Greg, we do have Amir in a waiting room. So when you're ready, give us the signal and we'll bring her in.
Sure, sounds great. I'm just going to speak very briefly about some of the design principles that we use to influence this program and how we put it together. We use a lot of behavioral science and the principles of driving behavior change to influence how we create communication products. And we follow one of the key mottos from behavioral science, which is make it easy. If you want people to do something, make it as easy as possible for them to do it. So in the case of this notification of pregnancy program, I believe the original survey had about 23 items on it. So we worked with Amir to reduce that survey down to 7 items and to try to keep that engagement experience, as Amir mentioned, under a minute, right? We're asking people to do work for us. It's ultimately for their benefit, but in that moment when they're having to do that, distracted from taking care of their kids, focusing at work, whatever it happens to be, they're doing labor for us. So we want to make sure it's always as easy as possible for them to do that. So that's one of the key elements that we use to design the program. Also making sure that we're leading in to further follow-up, providing them with prenatal tips, making sure they're getting their appointments after we figure out that they're pregnant. Also trying to take a beat on how they're feeling about their pregnancy, identify any further needs that we can help them with. And as part of our technology, we also have what we call natural language understanding. So as we're texting back and forth with these members, we send them text messages, they send us responses. We're listening for the natural progression of that conversation. Are you pregnant? Yes or no. But we're also listening for other non-structured responses like, I lost my baby, or things like that have an emotional content so that we can understand that intent and have as positive an experience for that member, as empathetic of an experience for that member as possible. So those are just a couple of the key elements that contributed to making this program one that resulted in very high yield I mean, if you calculate these numbers together, we had 896 people interact with this program, and we had a final resolution for 796 of those members. So, about 80%, 85% of the people who started an interaction with us completed it all the way through to the end. All right, and I think it would be a great time to bring Amir in, please.
Hello, good morning, Greg. Good morning, everyone.
Good morning, Amir.
Good morning. How are you?
I'm doing well. We are enjoying a couple of inches of snow here in Albuquerque, so trying to stay warm. I hope you all are doing great as well.
We are. Thank you for being here. So we're going to just take a look and see if we have any questions from the audience. Any questions out there? Okay, I see one. Give me a moment.
Good morning. It would be great to hear how you got through some of the concerns or issues around getting consent for the text messages and what those success rates were.
Sure. Amir, I was not as involved with the process of gaining consent, so could you field that one?
Absolutely. That's a great question. And so our state, New Mexico, is an opt-in state. And so through Impulse, we are allowed to text or initiate contact with our members via text message. It just requires that we essentially have that first question, can you confirm, that we're speaking to the right person? And they have a chance at any time during the workflow, during text messaging, to opt out. So being that we receive our members' contact information through our enrollment file with our state regulator, that is how we are able to just immediately initiate conversation via text message. But of course, through that trail, through the workflow, our members have to have the ability to say, stop text messaging me. I'm opting out of any additional delivery of messages, and I'm no longer interested in engaging in your program. So that's how we were able to continue to outreach via text message.
Yes, and following up on that, as far as gathering what could be considered sensitive information directly about the member, when we have them complete the NOP assessment, we take them out of the text message interaction and put them into a short, secure survey online that protects their identity and makes sure that information is protected. So it's a combination of what we call our double opt-in, where we say, hi, can we text you, after we texted them. And as long as they say yes back, we'll then continue on with the conversation. If we want to talk about information we know about their health status first, we have a few different ways to verify their identification. Typically, we'll use a date of birth verification combined with a zip code verification to make sure we're talking to the right person.
Amir and Greg, Cam Teams from Cordata again. I just wonder, as you thought about texting, did you also explore, since you're on the engagement side, did you also explore social media? And do you have any thoughts about that, about Facebook, et cetera, and connecting with members that way?
That's a really good question. I don't believe that. Go ahead, Amir.
Mm-hmm. Oh, I'm sorry, Greg. So actually, we are not allowed to directly contact our members via Facebook or other social media platforms to confirm information about their specific health condition. But we are able to post information on our social media platforms for the health plan to advertise events or, just let our members know what's going on and what are the happenings in their community. For example, whenever we do have a virtual baby shower scheduled, we do post the details and direct them to contact our, member services line or one of their case managers to further, see if it's appropriate for them. During winter months, we do distribute lumber or bottled water, resources, things of that sort in communities. So whenever we're doing that, we're just saying, hey, everyone, here's where we are. Come meet us if you can. If this is a good event for you, you can certainly reach us, that way. So that's where we've been able to leverage our social media platforms. It's more from the perspective of just keeping our community in the know of what we're doing in the state of New Mexico with Western Sky Community Care.
I do have one more question.
Good morning. Thanks for the great presentation. I'm Allison Ryan from Quantified Ventures. I was just wondering if you could loop back to where you all are with respect to tracking the performance measurement outcomes. So you talked about C-section reduction and low birth weight. And so now that you've got this great retention in the program, what's the time horizon for looking at some of those clinical outcomes?
Yes, thank you, Allison. And that is a key piece, right? We want to ensure that we are encouraging our members to get that minimum quality of care by attending those important appointments, by getting the help that they need from the services they need from their providers. So one of the partnerships that we have and the campaigns that we have is around postpartum outreach, and so that's ensuring, excuse me, that we are outreaching to our members via Impulse to, remind them of not just taking care of their newborn, but also the importance of taking care of themselves just after they've delivered. So we've actually seen quite an increase significantly of our engagement with our members who are actually getting to that postpartum appointment between that 8-week and 62-week period, just to ensure that they are actually getting to that provider postpartum after they delivered. It's still a little early to see, quantifiable data, and we're still in that chart chase period for postpartum, but we have seen just the preliminary data has shown that it's certainly had a positive influence. There's other factors, right? We're in a pandemic, making sure that our members get the essential care, that preventative care has been somewhat of a backseat service, just ensuring that they remember that it's important still, that whether you see your provider via telehealth or telemedicine, or you go in person, it's still important to get that preventative care in. So great question. We want to make sure that our performance measures are performing, and our partnerships are supporting that. And I think it's evidence so far that we will see, significant improvement, especially in the postpartum measure, through our partnership with Impulse. And Greg, I don't know if you want to add anything to that?
Sure. I would just say that as far as the Impulse side goes, we don't have access to claims data usually unless a plan provides us with that. So we try to look at the engagement data where we're tracking how they move through the text messaging program, because we know if we send X text message that's triggered by Y response, then they must have sent us Y response. So we're able to follow them through, get some indicators for how they're feeling about the program, and we're also able to track the amount of people who complete the survey, if they drop off, that other information, which we can provide back to Amir in the plan to try to give them leading indicators of what they may be able to expect, and also identify particular individuals that they may want to follow up with because they failed to complete a service, they gave us a particularly odd response back via text, whatever it happens to be.
Oh, and one more thing, if I could add, Allison, what's been key about the flow through Impulse is that when our members are reminded about that postpartum visit, we also ask them, if they are not going to attend or if they respond, I haven't scheduled it yet, or I'm not sure if I'm going to, they can then respond, well, I need help identifying a provider, I need help with transportation, childcare, or I'm just not sure. So they have a chance to provide that feedback to us, so then we can target our outreach and connect them to that resource.
Absolutely. Good
Wonderful.
Point, Amir. Thank you.
Well, thank you so much for calling in, Amir. We appreciate it. Thank you, Greg.
Thank you all.
Special round of applause for Amir getting up at a really early hour and battling the snow. So I think a lot of people are going through that in their homelands nowadays. Not here in Florida. It's nice out. So next session, we're going to have our friends from Healthcare Service Corporation come up and speak with us. As I think most of you know, those are the Blue Cross Blue Shield plans of Illinois, Montana, New Mexico, Oklahoma, and Texas. And with us today, during the next session, we have Tiffany Davis, who is Tiffany Davis, Esquire, DVP of Medicaid Performance and Delivery, who is working as an advocate and an attorney and a servant leader focused on improving outcomes for high-risk populations and underserved communities across a variety of avenues, some number of years, and various roles and responsibilities within the organization. We have, I hope I get this right,
They call you V, don't they?
V, I'm going to go with that. Nakomo, who is the Government Programs Clinical Operations Division Vice President at HCSC, and her experience includes more than 15 years of managed care experience in clinical program development, medical management, clinical operations, and programs and strategy, as well as clinical systems implementation. And we also have, and last but not least, Sherry Turk, who is our lead IT business consultant, joining us from HCSC as well, who collaborates with the business teams. If you've ever done work with HCSC, that's a super important role to have, to develop and drive technical solutions that enable effective execution of business initiatives, and has had a variety of experience in product development, marketing, and business planning throughout her years at HCSC. So thank you, ladies, for joining us. I'm going to get out of your way.
All right, thank you.
You got it.
Good morning.
Morning.
Good morning. So my name's Tiffany Davis. I'm here with V and Sherry. And just a bit about myself, I lead our Medicaid performance and delivery team, which is responsible for operational performance, financial performance, and compliant performance for our Medicaid plans. HCSC has about 17 million members across the 5 states. And specifically for our Medicaid members, we are working in Illinois, New Mexico, and Texas, and we have about 1 million members. We are very excited to be here with you today and really looking forward to sharing a few things. So first, some things that we'd like you all to take away from the presentation is just understanding how we think about violence as a public health issue and how we think about violence from a health equity and SDOH framework. We also want to share some of the interventions that we've done that have had a macro impact on particularly our Illinois market. Want to share some information from V's team on our care management approach and how we do that from an SDOH and health equity standpoint. And then also Sherry is going to talk through how we've leveraged innovation, technology, and really our employee feedback to think about health equity. I also want to share a quote before we get started. Reading recently a book by David Satcher, his Quest for Health Equity, and one of the things that he says is that in order to eliminate disparities in health and achieve health equity, we need leaders who care enough, who know enough, have the courage to do enough, and who persevere until the job is done. And that's certainly how I feel about my colleagues and also how I feel about the folks that are in the room today. It's an honor to be here with you all and to really be committed to doing work in Medicaid. So starting with our why, our Medicaid members, and we'll focus our time today specifically on the city of Chicago because they face significant health disparities. And we have a deep commitment to really address those disparities because these are the neighborhoods where we live, work, learn, and play. These are where our members are. And we know that violence is usually an indicator of something else, right? And that something else could be economic instability, it could be concentrated poverty, it could be limited housing. And in the presentation that we'll send out afterwards, I linked a recent Chicago Sun-Times article because I'm sure that you all have seen the violence that is happening in Chicago. It is an issue of national concern. Just in the last year, as the Sun-Times reported, we had 836 homicides in the city of Chicago. That is the highest that the Chicago Police Department has seen in 25 years. Specifically, of the 77 neighborhoods that are in the city of Chicago, 10 neighborhoods are driving most of the violence in the community. And so the area that you see highlighted there, it may be hard to see, but it's the Auburn Gresham community. And the reason that I highlighted that community specifically, they had 39 homicides last year. That's the community where my grandmother was a mental health worker. It's the community, my great-grandmother was a mental health worker, my grandmother was a minister, and where my mother has worked for 25 years in healthcare. And so I'm always thoughtful about when I'm going into work, what happens when a little girl is shot or when her father is sitting in a car and protecting her from violence, or there's a bullet. What happens when that life is stopped short? Because I know what that community is capable of producing. So it's very personal, and I deeply am committed to it. I'm very thoughtful about it when we come to work, and so are our colleagues, and we're really excited to be here today and share some of our thoughts there. So from a public health perspective, we have an emerging and increasing emphasis and expectation from both our public health department, but specifically from our regulator to think about violence as a public health emergency. And some of the things that our public health department has said is that, one, as a trusted business partner, Blue Cross, you have to think about reducing violence. You have to expand community partnerships and really address the root cause, right? Economic development, housing security. More importantly, our regulator is getting very prescriptive about this, right? So in our recent contract amendment in Illinois, You have specific contractual requirements around how are you going to develop quality improvements that reduce health disparities? How are you going to use disproportionately impacted areas? Those are zip codes in the city of Chicago, mostly, and then some areas outside of the city, but are on the south and west sides of the city, and saying, these are disproportionately impacted areas. What does success look like for the members in that community? What does success look like for the individuals that are in those communities? How are you going to develop interventions that have real life and tangible impact for those areas? And so that's how our interventions have to be focused. Also, they are asking us to incorporate lessons learned. And so the beauty of our role is that all of us are sitting at an enterprise level where we can take lessons learned or interventions from other markets and bring those to bear in Chicago, and that is certainly an expectation from our regulator. The other thing I wanted to talk through on this slide is also to share some of our historical data. So we looked at our violence data from 2015 to 2017, and in that, the information is not here, but I just have a few notes I want to share and why it's a public health issue. 52,000 of our members between 2015 and 2017 experienced episodes of violence from our claims data. Our claims data also showed that in that 2-year period, we spent over $140 million on gun violence claims. More than likely, our cost for gun violence and dealing with those from a hospital standpoint was higher than the next category, which was unarmed human force. When we looked at our claims data, we can unequivocally see that African Americans are disproportionately impacted by gun violence and that our males are disproportionately affected by gun violence. And so when we're thinking about this as a public health issue, it's not just our external Chicago Department of Public Health or our regulators. Our own claims data is indicating the exact same things that we're seeing play out. So from a health equity, next slide. From a health equity standpoint, our pillars, we think about member engagement, community engagement, provider engagement, strategic partnerships, data driving our direction, and then policy. So when we're developing solutions, this is the framework that we're thinking from. So specifically, some of our interventions, the one that, I think the underlying question, and I also linked some of the evidence-based interventions that the CDC has put out for violence intervention and how our strategies are aligned to that. But most importantly, the overarching question is, how do we use our resources? How do we pull every single lever in our organization to combat this issue? So the first that we're super proud of is our Blue Door Neighborhood Centers. We have 3 centers that are across the south and west side of Chicago. And what we're so proud about is that those are interventions that the CDC has recommended, but they are providing protective community environments. They're also strengthening economic supports. And the way that they're doing that is they host 70 events per month. Those events serve as open to not just Blue Cross members, but also to members in our community. They are specifically, of those 70 events, we're doing things like health education, we're doing wellness events. The last time I was at Blue Door, we had our Blue Door Morgan Park and our Blue Door Pullman, and they were on Zoom doing Zumba classes together. So it was so cool because even though we were COVID, they were able to interact with each other. So we're doing fitness classes, we're doing mentoring of high schools that are in that area. People in the community can use any of our 3 Blue Door centers as a way to host community meetings or events. But most importantly, and what we're most proud of, at least I'm most proud of because I know how economic stability contributes as a violence intervention measure, is our Blue Door Morgan Park is also a neighborhood center, but right next door to it, we took an abandoned Target and turned it into a 500-job solution center. So it's 500 jobs that are on the south side of Chicago, and specifically 65% of those people are within 10 miles of that Blue Door Neighborhood Center. So it's an awesome intervention where we're creating and empowering economic stability, but also changing the way that that community looks and feels. Our second intervention is community investments. And this is important because, we know that as, a health plan and as an insurer, we're not gonna know A to Z how to do violence intervention, right? We have to talk through and work with community partners that are trusted in the community. And so we fund community-based organizations that are working to interrupt violence both before it happens and then after it happens with behavioral and community health interventions. So in 2021, we invested close to $1 million in anti-violence interventions. And the one that I'm so proud of. One of the members from our team, Pam, is here today, and she brought and recommended Project Swish. Project Swish is a nonprofit organization. It's the city of Chicago, founded by McKinley Nelson. And what he's done with that organization, he was a college student. He was looking at, crime data, and he shares this when he talks about Project Swish. He had been at the age of in mid-20s to more funerals, more celebrations of life than he had been to his friends at that age graduating from college, being able to go to and attend a baby shower or marriage ceremony. So he looked at the crime data that was, happening in the city of Chicago, and at the same time he does basketball events. And at those events, when he's bringing kids in, he's teaching them things like yoga, art therapy, meditation. And so really sharing interventions that can help to disrupt that pattern of violence. So we're really, really happy to fund him this year and really happy to partner with him throughout the year. Our next intervention is really collaborating with providers. We know that providers are a huge part of this, and so we've done that in a couple ways. With our ER intervention program, we looked at our claims data where we have high instances of violence and where we have high instances of trauma, and worked to look at the hospital census reports and our ADT data, and then used our CHW team to conduct outreach to members after they've experienced an intervention. And we don't just focus on violence there, we focus on members that are coming into the ER at those high volume facilities and how we can do SDOH, following their ER visit. We've also have, lessons learned from that. We know we need to, help link members to preventive care. And so one of the providers that we've partnered with is an urgent care provider on the south side of Chicago. He's a Black-owned physician, and he's a former ER doctor. And what he's been able to do is to use his partnership as a community stakeholder to now form an urgent care facility. And so we've been working with him to build his panel and really talk about value-based care from both an SDOH and a health equity partnership perspective. And so very excited about that. Our last intervention is really looking at our supplier diversity program. One of my pleasures is leading our supplier diversity program and integrating businesses in our pipeline that are owned by minorities, owned by women, or persons with disabilities. And so as a part of our program, we last year funded $1.2 million specifically to organizations that are focused on SDOH and health equity. The two that I want to highlight here, one was our T. Castro Produce, and so we connected our Blue Door and our supplier diversity program, so working across that framework, and we were able to do pop-up food markets. And so in those pop-up food markets, we were able to administer boxes of healthy produce, kale, tomatoes, greens. We were able to feed over 86,000 of our members in that partnership. And then also by bringing them in with the healthy food, we can do programming on the Blue Door. We can let them know about our facility. This is a community resource. And so really, really proud of that partnership. Also, we're working on developing a solution that offers and curates, looks at the crime data and the statistics that are going on in our DIA neighborhoods, and then how can we better offer our members our community-based resources to increase utilization. So we're working on that pilot right now of being able to curate both our crime data, our community-based organizations, and then offering that to our members closer and after the event of violence. And so really excited as that program develops. So these are just some of our macro level examples. I'm going to turn it over to V to talk through our care management approach.
Thank you, ma'am. So good morning, everyone. My name is Velisawini Komama. I go by V, so please feel free if you bump into me to call me that. So Tiffany's a hard act to follow. I will slow down and talk a little about what we are doing in care management or in the care coordination space. So I lead a team of about 800 across 3 states, and this is a team of care social workers, behavioral health, physical health, nurses, community health workers. We'll talk a little about the work that they do across the different states. However, speaking specifically maybe to Illinois and Chicago, and I'll show you an example of some of the work we've done there. So as far as care coordination and our SDOH approach, the one thing that is very clear, and I think I've heard a couple of people say this, there is no one-size-fits-all solution when we work with our members. And so I think it took us several years to realize that. We can't just say, okay, great, everybody diabetes, here's your solution, go. It doesn't work that way. We are really having to be critical about segmentation, ensuring that we are looking at specific populations and how we engage with those populations. So the way we are doing this now, we are utilizing several member insights. We're getting assessment data. We're looking at specifically some zip code, public data. Don't know if some of you are familiar with Metopio. We really started using that software quite a bit. What it does do, outside of the state of Illinois telling us, hey, you've got members who are in these zip codes that are disproportionately impacted, it tells us specifically within those zip codes where the food desert is, where the gaps are, where's the gun violence, and things of that nature. And so you also have to remember in that when we are in the field, and currently my team is not, but when we are in the field, there were some of these zip codes where my care managers would go out with security. However, also have some very dedicated folks that do know the importance of the work that they do here. And so that's another critical aspect to our work is the people that are actually very committed to supporting our members in this initiative. So we're also using claims, obviously, to look at impact. Tiffany's talked a little about claims. We're also starting to get more Z codes that are coming in. We are segmenting those zip codes, Z codes, to be able to now actually structure specific initiatives to support our members. Again, we are pushing a lot more data as far as age, race, income and social status. I did want to highlight something that's probably a little edgy now, right? We talk in a lot of our programs currently about minority women and how they're impacted, whether in maternal infant health, or we've just talked about Black males in Illinois and how they're impacted in gun violence. But a lot of our models have not got to that point where they say, you're working with a Black man, maybe this is a critical risk you need to look at. Or you're working with a Black woman, how do you treat this interaction different compared to maybe a Caucasian female? It's a little uncomfortable, folks. It's not something we've typically done, but we are having to get there because it's reality, right? We know the numbers, the data does show it. And so that's something that we're starting to do now. What we don't want to do is get in the process of discriminating, so to say, against all other races. But we do want to do is ensure that we are providing that equity as we are seeing the data for those different populations. All right, so this is probably one the vendors cross eyes at whenever they meet with me and my team. At this point, I don't care who you are, if you're going to be partnering with us, you are going to have a way to assess for SDOH. And you're going to have to get that data back to us. Because we do know that having an HRS or health risk screening once in a year and somebody says, oh yeah, I don't get food, and you take care of that food need one time, it doesn't go away, right? It's going to be a continuous process. So what we want to ensure is at every point in time where our members are touched, we are able to identify any opportunities to support them with their SDOH needs. I'll also say, and maybe as I go into the actual program design here, when we talk health equity, I think our first step is to align that directly to social determinants of health. And what you'll find is a lot of our solutions in SDOH we'll have to look at sustainability, and I'll talk about that here in a little bit. So let's jump into just the broader program design and how we are actually impacting health equity here in our space. So in my team, we have a dedicated community social services team. They, at this point, are focused on sustainable interventions for housing, food, employment, and I did highlight education. And when I say sustainable, I mean we can't look at a one-time, here's a gift card, you're done. We're having to push further upstream and think, what caused this individual to be here, and how do we potentially support them, not just with this one-time fix. It's never going to be a one-time fix. So that's definitely something my team has had to take on. I highlighted education because in a lot of scenarios, we're quick to try and fix that individual one time with here's a food box, here's this, here's that. But there is always that component or opportunity to educate on how this member could access different resources, how this member may potentially even qualify for SNAP, and we have not, they may not know how to do that or have the documents to be able to do that. So it's taking more time to go through that process with our members, and that's what our social services team is focused on. I won't go into every single bullet on community health workers. I think you guys know in this space it is definitely better for our members to work with folks within their communities. These are a great team of folks who are collaborating with our caregivers or care coordinators. They're really assisting our members in understanding their disease states. And in some cases, obviously, we've got care coordinators that set up care plans and so forth. But at the end of the day, it's 2-3 visits later, it still hasn't clicked. This is where community health workers are like, hey, maybe that mac and cheese isn't the greatest, right? If the first time in the care plan didn't make sense, here's where we could potentially go a different route. So I want to jump to the next slide here before Pam starts jumping from back there. Just to talk a little about our social determinants of health program, I do remember several years ago when SDOH started becoming a thing, right? It was one of those, we know it's an issue, but who's really going to pay for it? Who's doing anything? And I'm glad to say, in my time at HCSC, I've seen HCSC put the money where the mouth is. And it's really come down to the point where my team now has a fund, we've got dollars, that we can use specific to any member's needs. It's not just, it could be anything, so I'll tell you a little more about that. But basically what this program does, we started out in 2020, had a little funding, I'd say $50,000, and started to look at, okay, so we've got individual members that make transition out of the nursing facility. The MFP program had gone away. Their needs hadn't gone away, right? They still needed some way to set up either first month's rent, set up bedding, get pots, pans, whatever it is. And this is exactly what our team sought out to do. So basic needs are covered. Basically, another opportunity that this fund has allowed us to do is not only are you saying to that member, yeah, I've identified your needs, I'm not just sending you to the food pantry. We can do this now, and then we can set up a solution going into the future. That member is actually more likely to engage with our team at this point when they actually can get something tangible at that point from you. So we're also using this fund to improve member wellness. We're preventing unnecessary admissions. I'll tell you a little more about that here in a few. And just put some numbers on the slide here just so you understand where we are. Average spend 2020 was like $115. We got lofty in 2020, with our groups of members, but a lot of those purchases were really needed. 2021, definitely we've increased that spend. You could jump to the next slide, Pam. Are you clicking? Clicker? Thank you. Oh, that's it? Oh, no. All right. I thought I had a slide in here about our successes with this fund. So think of a 14-year-old who has aggressive behaviors. Again, a lot of violence in the home, is beating up mom, has been inpatient BH several times, and our care coordinator partnering with this family. So what we discovered about this youngster was they actually really liked boxing. And you would think, well, wait a minute. Okay, so the first thought for the care coordinator was, well, maybe we should send them to a boxing club or some type of club. Well, mom wasn't interested in that. This is mid-COVID and so forth. Simple, boxing bag in the garage. This individual literally spends quite a bit of time in this garage, boxing on that bag, and have actually reduced their inpatient visits by like 50% in a 3-month span, just because of a simple boxing bag. And now there's this interest in what else can I do, right? This was like a $100 purchase. However, it was something that was tangible and important for that mother. Another one, I had a gentleman who came out of alcohol treatment center and really needed to go to a sobriety house. Sobriety house needed payment for the first 30 days. Well, he didn't have it. Now, we can all think of, well, if he doesn't have it and you don't pay it, where is he going? Right? Well, we paid the first 30 days. In that 30 days, he was supported by our care coordination team, was able to get a part-time job. Guess who paid the next month's rent? He did, and has stayed sober for the last 6 months. So we're starting to see that with this fund, while it may be painful to work at the individual level, it's pushing our care coordinators to think outside the box and really figure out solutions to help members. But it now goes past the point of sending a referral somewhere, right, and a general community service, a social services resource, and hoping that works. We're now looking at members individually. So thank you. I guess, Sherry, I'll hand over to you.
Okay, awesome. Hello, and it's great to be here this morning. I am in the IT area, so I work closely with V and Tiffany. We are arm in arm, working on initiatives to address the strategic goals of HCSC. So it's a great partnership. I'm here to talk about an innovative grassroots idea that took off to address health equity. And it started in the IT area, but we partnered with our business partners here, V and Tiffany and their teams. Like Tiffany said, in our markets, and I'm sure the same is true for you, it's really personal in that we live in these communities. We have relatives, we have friends, we have history in these communities. So the experiences that our members are going through are personal. We can relate to them. Sometimes we are even familiar with the causes of the experiences. And so we particularly were interested in how to address health equity. And that's one of our corporate strategic goals, of course. In the IT area, our leadership was asked to conduct health equity training among the leaders so that they understood in IT what our business partners were trying to achieve. And so our leader in our IT area took the training and then cascaded it down to all of her team in IT. And so we took the training, health equity training. We learned a lot from it. One of the things that stood out to me, being someone who grew up in Chicago, was a statistic about heart disease being the #1 cause of death for the west side of Chicago. In that community, the expected life span is on average 20 years less than the lifespan of those individuals in the zip codes to the east and the west of the west side of Chicago, the east being downtown, the west being Oak Park, Illinois. So health equity, is particularly impactful in that community, or health inequity, health equity imbalances. And so our leadership, once we took this training, we had a follow-up formal brainstorming session where everybody in our IT group was encouraged to bring forward ideas. How would you address health equity? And so it was an opportunity for us to use our experience and knowledge of our communities to generate ideas that could address health equity imbalances in our communities, and to provide ideas that we could champion personally or bring forward to the organization to champion. And so one of the ideas that rose to the top of our brainstorming session was a health equity make a difference-a-thon. We're used to doing hackathons in the IT area, and typically a prototype or a technical solution is required in order to participate in a hackathon. Not everybody in IT knows how to develop or code, but everybody there had ideas. So we wanted to make sure that we created an opportunity for people to bring forward concepts and not necessarily have to have a technical solution, because there are other people who could carry out the technical solution. And so we moved forward with the Health Equity Make a Difference-a-thon, and it was an opportunity for anyone in the IT area to form a team to develop an idea and present it in a friendly competition within our division. And so the challenge statement for that is, it was, how might we create concepts of products and services, for example, partnerships to address health inequity in HCSC markets. And so this could mean something different by state. It could mean something different by community, within a state, within a city. So that was the beauty of it, that individuals could bring forward ideas that would impact their communities. This was the first time an event like this was held. We had 13 teams come forward. So there were approximately 55 people who participated across 13 teams to develop a winning solution for this challenge. And so we used Bright Idea Bank to capture these ideas. It remains a repository for future use, and it is the crowdsourcing tool that we use for our hackathons also. And so the competing teams brought a range of ideas across the organization, and we're at the point now where we're taking those ideas, and I'll just give you the highlights, or like what types of ideas came forward on our, when I get to the next slide. But we're in the process now of vetting those ideas and like having a lot of sort of meetings. We prioritize which ones are going to move forward. And so these ideas continue to be stored in our Bright Idea repository. We brought our business partners in as judges. Tiffany Davis was a judge, and we had a range of business partners, medical directors, health equity experts to be the judge of this Make a Difference-a-thon. Four ideas have been prioritized by the business. 9 additional ideas are now being evaluated, vetted, and potentially moved forward by IT directly. And our judging cohort continues to meet, which is awesome because they're meeting as a team, and the energy is kind of bouncing off one another in terms of all of their expertise. And so this is where we're moving. And then Tiffany, do you? Okay, there we go. So this is where we landed. And I don't have a lot of specifics about the ideas. We're actually still in the process of determining, kind of how they're going to move forward. But we had a range of ideas, including veterans wellness. We had a couple for remote patient monitoring, predictive modeling, and so like proactive intervention for SDOH as opposed to reactive once we see an experience or get a claim, but proactive modeling, empowerment of domestic violence victims. Some of these solutions did include a technical solution, some perhaps not. Health insurance literacy, maternal and infant health, access to nutritious foods, awareness of the wellness programs that are there. Parental mental health, so specifically collaborating with parents, making sure that they're strong enough to help support their families. Teen wellness, vendor mentoring, and remote monitoring. I got that twice there. So these are our great grassroots ideas, a testament to what can happen when everybody can contribute to helping improve health equity. And so we all have a role and we all have ideas. So this was a grassroots idea and a testament to what happens when you can bring everybody in and share their ideas and experience. Okay. Mm-hmm.
Okay. Thank you. We are needing to wrap up because we've gone a little bit over. Ladies, will you be at the break?
Yes, we will.
Okay,
Yep.
so if you have any questions, please, can you tap them at the break because we have to keep moving. I apologize. All right, thank you so much.
Okay, that was great. Thank you for our friends from HCSC for doing that. Next up, we've got our next session. We're running a little behind here, so we're going to push. The session is titled, Yes, We're Serious, the Path Forward to Reversing Food Insecurity. And with us, we're going to have Jared Sharon, who's Vice President of Marketing at FoodSmart. Jared's responsible for FoodSmart's international marketing agency and a group that takes innovative approaches to Medicaid member enrollment, engagement to maximize the number of members, helping improve their health outcomes. We also have Sharita Quintano, Head of Nutrition and Operations at FoodSmart, and Sharita serves in this role to develop and execute the growth and operations strategy for FoodSmart's telenutrition network while expanding FoodSmart's capabilities to assess, identify, and address patient social determinants health needs. I'm happy to see that we may be passing out food. I'm not really sure, but we're going to let you guys take it away here in the next session. So welcome.
All right. Thank you all. We are excited to be here. I have to tell you all something. I got to be very honest with you. I don't know what's going to happen over the next 30 minutes. I don't. There's people in avocado costumes running around. I didn't know anything about it, so it's all out of my control. But I promise you it will be an entertaining 30 minutes. I have two goals for this session. One is arguably the most important, which is to tell you all about the importance of not just food, but nutrition insecurity. And my second goal is for those couple folks in the back who are crushing candies hard right now to get a couple laughs of this session. So, my name is Jared Sharon. I'm our Vice President of Marketing. And my background, I spent my life mostly at McKinsey. Some of you may have had the pleasure, or I should say displeasure, of working with us before, where we made some really nice PowerPoints and some nice graphs, like the one Tim from Mama's Meals. Thank you, Tim, and the Mama's Meals team for showing that great data. I produced those things, and they made my eyes bleed, and I realized at some point it's really easy to tell someone else what to do, but doing it is a lot harder. So I wanted to get my hands dirty and show the power of food as medicine. I'll turn it over to Shrita here.
Thanks, Jared. Good morning, everyone. I am thrilled to be here. I'm Sharita Quintano, Head of Telenutrition Operations with FoodSmart, also leading our network expansion strategy. Really excited about being here today. Transparently, I'm sure I'm not alone here, but one of the first times getting back on the road since the pandemic. So it is awesome to see folks in person. Really empowered about being here. My personal story, I grew up in New York City, grew up as a Medicaid recipient, was on Medicaid my entire childhood through my early adulthood. And so not only is it empowering to be here today, but I am very grateful of our collective efforts of just really working towards very complex issues for needy populations. And so I send my thanks to you all, and excited to jump into the conversation around food and nutrition insecurity. Just like Jared mentioned, we're gonna get you up out of your seats in a few minutes. We're gonna start by just talking through very quickly the state of the issue, some of the complexities with food and nutrition insecurity. My heart is just bursting knowing that there was alignment through a lot of presentations, including what my colleagues just before me, Tiffany and V and Sherry had just shared. So I'm gonna go through a couple of highlights really quickly on some statistics and then get into the meat and potatoes here. What Jared and I really want to hone into is our lessons learned from a FoodSmart perspective around a comprehensive approach for addressing food insecurity coupled with telenutrition and digital solutions for really also driving education, awareness, and sustainability for impacted populations. A couple of quick hits right now. My colleagues in the room, we are going to be passing around, if we haven't already, some surveys because we would like to get some feedback from you around what you're doing today to address food and nutrition insecurity with your populations. From just a time sensitivity perspective, those surveys are passed out. We'll collect them at the end of the session. We will share feedback post-conference via email. And for those who are streaming today, you'll also have an opportunity to fill out those surveys via email as well. So I won't belabor the points here. We have heard them a couple of times throughout the conference. Food and nutrition insecurity is a very, very complex issue, one that has become even more pervasive throughout the pandemic. In 2020, 1 in 8 Americans were reported to be experiencing food insecurity. That translated to 38 million Americans, and in just a year, that number rose to 42 million Americans. In addition to just the challenges that food insecure individuals experience with access to food, they're also limited in their options, relying very heavily on highly processed, high sugar content, low nutrition density foods when they do have access, also highlighting the issue of nutrition insecurity. We know that there are subsets of our population that are at greater risk for experiencing food insecurity from a health plan view. Medicare, elder age, DSNP, Medicaid patient member populations show higher prevalence of food insecurity in comparison to the broader plan membership. And additionally, food insecure members are more costly in comparison to broader plan memberships, on average at $1,800 per member per year for those who are showing food insecurity in comparison to their food secure counterparts. Not surprisingly, we also know that there is an intersection with food security or food insecurity and chronic disease. Food insecure members are 3 to 6 times higher prevalence with chronic disease conditions, hypertension, asthma, COPD, diabetes, and arthritis in comparison to their food secure counterparts. So now we're going to get you out of your seats. The key takeaways there, key takeaways there, food and nutrition insecurity is prevalent. It impacts a large subset of American population. It impacts specific communities more disproportionately than others. It is more costly, and it leads to poor health outcomes. We want to test your knowledge or awareness of some of the nutrition insecurity aspects. So we're going to ask for 2 volunteers.
Yes, we are in Florida here, right? And more people watch Price is Right in Florida than the rest of the world combined. That's not a real stat. That's not a real stat. But we know there's a lot of people in Florida watching Price is Right now. So we figured it's only right that we have our own Price is Right game here.
Right.
So Shrita, you're going to go ahead and introduce the game here.
That's right. So we're going to get 2 contestants to come right on down. We're going to,
So if we could get 2 contestants to join here, our friends in the avocado costumes, they're going to choose 2 individuals to come on up with the chance to win $200 for a food bank of their choice.
Oh, I love my girl in the pink. And James, that's right. That's right.
All right, come on down.
Come on down. Come on down, James. All right, here. So I'm going to, we need one more.
Why don't you introduce yourself, James, to the group here?
Hi, I'm James Haskins from HealthMind. I'm actually after, and fun fact, Shrita and actually went to public health school together, and we learned this last night at the network, and I was like, I swear I know you, and she's like, oh yeah, I graduated from U of M in 2008. Okay, well clearly I've been like sleeping because I just did not connect that, but it's good for us to connect, so I'm happy to come down here and help you out.
Thank you, and go blue.
Go blue. Go blue.
All right, and our second contestant here, can you introduce yourself?
Hello, Michael Chowning, CSG Government Solutions.
Awesome.
Excellent. Thanks, Michael. All right, so can you all head to your respective tables here? And Shrita is going to give the rules. Yes, one table right here, one table over here.
So really quick, we have 20 common grocery items on the table here. Our contestants are, the goal here is that you are going to select top 10 items that are most purchased with SNAP dollars, right? The contestant who picks the greatest number of correct items like Jared mentioned, is going to win a $200 donation to your food bank of choice. You'll have a minute to make your selection.
Can we get the items on the screen? Just separate them on the table, right?
Yep, just separate them out.
Are we putting them in order of?
Nope, just
No,
top 10.
just grab top 10.
Yep. All right. You're going to have 1 minute.
And for our audience in the room, you can see what they're choosing from. I'll leave it to Jared to tell you when you're
All
starting.
right. 1 minute to choose 10 items for a $200 donation to the food bank of your choice. Ready? Go. All right. We have James taking the soda pretty quickly here. We got 40 seconds left. We see Michael taking the cutout of the ground beef. We didn't want this room to smell. We got 8 here. 28 seconds left, folks. James, can't tell if he's confident or nervous. I don't know if he knows either. We're getting a lot of shouts for the cereal here. We got 15 seconds.
Love it.
Michael is done. And James is done. All right. 5 seconds to go. Let's give it up for our contestants.
All righty. So let's see what the correct list of items is.
All right. So, soda. Who's got soda here? All right. They both got soda. Great job, guys. All right. The next one. Milk. All right. So Michael has 2. James has 1 right now. How about the ground beef? Oh, we got 3-1. Look at Michael, huh? Making snap decisions. Love that. The bag sacks the chips. All right. 1 for James here. And Michael. Perfect 4 for 4. We've never seen this. No one has ever seen this. How about the cheese? All right, we got a comeback here. So we now have 4-3. And they both got the baked breads. Great job, guys. All right, 5-4. Box cereal. Oh, they listen to the audience. You got to love that. 6-5. This is coming down to the wire. The fresh chicken. Neither got the fresh chicken. All right. We got the frozen handheld food and snacks. They both got that. And it's coming down to the last one here. Lunch meat. Oh, we got a tie. We got a tie. All right. Well, gentlemen, thank you both for playing. We'll do a donation on both of your behalfs here. So please find. Thank you both for playing. Thank you. Let's give it up for both of them, huh? They did a great job. Please make sure to find your local avocado to tell them where you would like your donation made.
Yes. Yep. So just a couple of more slides here before I pass the baton. Great interactive activity. Thank you guys again for participating. What we wanted to illustrate here, though, food security and nutrition insecurity are very interrelated issues. Cannot be decoupled, but there are some distinctions here to be made. So just to walk through a couple of illustrations, we have 2 members, Mr. Tom who lives proximal to some convenience stores and fast food options. Mr. Tom does have a car and access to food options, but doesn't have consistent access to the financial resources to purchase those food options. Mr. Tom does enjoy cooking meals for the household, but oftentimes experiences challenges with affording adequate ingredients to cook those foods. So from a summary perspective, Mr. Tom has limited or uncertain access to adequate amounts of food, so Mr. Tom falls into the category of food insecure. We also have Miss P, who has proximity in terms of availability to corner bodegas and fast food options. Ms. P can afford nearby food options, does have some inconsistent access to transportation. Ms. P, like many of our members, does work multiple jobs, inconsistent hours, so it's really difficult for Ms. P to do any effective meal planning. Also, Ms. P is not the best of a cook, doesn't have all of the right equipment to do that, so Ms. P, frankly, relies heavily on fast food, processed food options. Ms. P has limited or uncertain access to nutritious foods or non-processed foods, and therefore Ms. P is food secure but nutrition insecure. Key point is both are relevant and significant issues when we talk about the greater complexities of food insecurity. Both issues need to be assessed and addressed, and they require some comprehensive solutions for mitigating those. Lastly, I just wanted to talk through what we know today in current state in terms of solutions that have been tested, continuing to be tested with these populations, and the challenges experienced by those. Again, I think back to colleagues before us who were presenting, and they highlighted some of these points. A lot of what's being tested today are short-term solutions that are hard to drive sustainability because they're also high cost, not yet showing long-term ROI. There are a lot of options out for providing food insecurity meal kits, food boxes, food cards, and subsidies, along with a lot of investment in food banks to provide access to food, and even SNAP enrollment programs. All of these options are meaningful starts for addressing food insecurity and nutrition insecurity, but they're limited in getting to other root issues in terms of increasing member knowledge and awareness, changing the skill set and competency dynamic so that you're really driving at more sustainability and hardwiring of long-term reversing food insecurity. And that's really what we want to hone in with our recommendations around comprehensive approach. And with that, I'm going to pass it off to Jared.
I wasn't sure if she was going to give me the mic back, but I appreciate it. I guess I haven't done anything too offensive yet. I also want to remind you all we need your help controlling the pet population, so please have your pets spayed and neutered. All right, we are going to send out the poll results to you all after the fact here. So Shrita talked about some bad news. We've talked about some bad news today, but there is some good news, right? I'm sure many of you know this. Some of you might be Star Wars fans, maybe you're nerds like me and like A New Hope, and if not, that's fine too. But, right, there is some hope on the horizon here. There was a record increase in SNAP in October of last year, right, which is exciting. We have to make sure those SNAP dollars are not being spent on soda and many of the items you learned today, right, but at least we're starting to address the food insecurity part of the food and nutrition insecurity. We have to make sure those folks are enrolled in SNAP in the first place, but that's a whole other story that we'll get to here. Second, right, we now have the opportunity, thanks to the SNAP online purchasing pilot in 48 states, for members to use SNAP dollars on online grocery ordering. That's helping to address some of those access problems, right, or time restriction problems that folks have had previously. And we're seeing record amount of money and transactions being spent on online grocery ordering. So huge opportunity here that did not exist before the pandemic. All right, I hope you all don't start having too much PTSD from 8th grade here, thinking about sines and cosines and trigonometry in your cheat sheets here, but this is our cheat sheet for food insecurity. It's not perfect, I get it, right? There's probably some things missing. There's some folks here who have been doing this a lot longer than I am, who are probably there and they're like, you're missing kitchen readiness. We know, we get it, right? We're working with some folks in this audience on pilots, working with CBOs on some of those items that we know aren't quite there today. But this, to the best of our knowledge and the data that we have today, is the formula, right? So let's start with what that is. Number one, as our colleagues before us noted, we need the data. We need to know who is food insecure so we can actually provide the solutions to those people and we can target them today. And don't tell me that you're getting the Z codes from your providers, right? I know they're doing their best, they are, right? But we all know they're not putting much of that information in their EHR. We know that. So we need to first identify who is food insecure today. Second, we need to get those folks enrolled in SNAP, right? There's that record amount of funding that they have today. We need to actually get them enrolled. For many of the members, this is a really hard, laborious process. I know that we're all trying to improve our technology at a state level to make it better, but it's tough today. We know 56% of people who are food insecure are not enrolled in SNAP and EBT from our data. 56%, the majority, right? Come on, we gotta get those folks that money. That's money in their pockets. That's coming from the federal government here. Let's get it going. Next, food access is continuing to be an issue, right? Online grocery ordering can work really well. Between Walmart, Instacart, other online grocery ordering, you can deliver to almost every zip code in the country today. However, grocery delivery fees are still very high, right? This is where we're working with a lot of plans, ILSs, to actually subsidize grocery delivery fees for their members to remove that barrier. And that is important because if we take those SNAP dollars and we can remove that access problem and guide people away from the soda, the deli meats, right, things like that, towards healthy food, we're not talking about using SNAP dollars on nutritious food that people can afford. And once we do that, right, anything beyond, we know SNAP won't cover everything. It can't cover all of their meals for most folks. So that's where savings from the retailers comes into play, right? And using some of those short-term solutions that Shrita mentioned, could be food insecurity meal kits, food cards, things of that nature, to help supplement that. You bring that all together, and you have someone who's actually helping your members out, providing that personalized solution, right? A clinician who's saying, hey, these are the chronic conditions you're working with today, or your family's working with today, and someone who can help them with the SNAP enrollment that's laborious, with some of the IT issues, like getting them signed up for grocery delivery, things like that might seem tricky to them. You have someone that guides them through that process and brings this all together, and that's how we address food insecurity here and create food and nutrition insecurity. So our vision, very simply here, right? Empower people across the country to eat well, simply, easily, cost-effectively, so that they may live their lives free of chronic disease and not just food, but nutrition insecurity, right? We believe that is a human right. So what do we do here? We have the largest network of registered dietitians in the country, right? Telenutrition, telehealth with registered dietitians. For those of you who don't use the word telenutrition every single day, you all are smart folks. I'm sure you could have put that together. But we have RDs licensed in every single state in the country here. We combine that with a digital platform. I'm sure you all go and see your PCP, and your PCP tells you there's 8 things you got to do, and you're like, yep, got it, doc, and maybe you do one of those things. Our digital platform, we have an app and web version, make sure that people outside of their appointments with their dietitians are actually creating behavior change. So how do we actually address food insecurity? First thing we do, we have something called the NutriQuiz. I know, very clever, right? A nutrition quiz. This is why we get paid the big bucks in marketing. And what we do during the NutriQuiz is think of it like a combination between a food and nutrition assessment to understand where there are gaps in individuals' food and their eating today, and an HRA that includes social determinants questions, right? Love what our folks from HCSC were saying. Let's get that data going, right? This is where we use USDA questions around food insecurity to assess who is food insecure today, do they have a SNAP EBT card, et cetera. At that point, our dietitians will identify those folks who are food insecure, who are not enrolled in SNAP, do an eligibility check, and get them enrolled if they're eligible. We then, the dietitians will create meal plans for folks from our thousands of recipes that we can filter, right? We've actually filtered the recipes for those based on the average allotment for SNAP so that they can actually create meals and meal plans based on SNAP budgets. We also can filter by time that they have to create meals, things they like and don't like. Don't worry, our dietitians don't make people eat kale. they encourage it, right? But they don't make people eat kale. It's about meeting members where they are today and what they know, don't know, and continuing to move them towards healthier solutions. That then, those meal plans can get automatically created to a grocery list, which get integrated with Walmart, Instacart. So if you think about it, we're taking someone who may not even be enrolled in SNAP, we're identifying who they are, if they're food insecure, getting them enrolled, showing them items or recipes that they can afford on a SNAP budget, and having that integrate directly with Walmart, Instacart, so they can pick those groceries up for pickup or for delivery, and they can use their SNAP dollars on that. So there's no processed foods on our platform like the ones you saw today. And then outside of those SNAP dollars, this is where we use online grocery couponing based on the zip codes folks live in, and we use grocery price comparison, right? Think of it like GoodRx for healthy food, or for those of you not familiar with GoodRx, who are planning your next vacations away from Florida, Kayak or Priceline or something like that, right? We take the same grocery list and through our integrations with Instacart, with Walmart, right? You can compare nearly instantly the same grocery list to see what's going to be the cheapest options. So those savings are coming out of the retailers, right? They're not coming out of your all's pockets. So you can take the same basket of goods, depending on what's on sale, where you're shopping at, it could be 30, 40% less on a given week. Our dietitians play the quarterback for all the other solutions that you all are implementing today, right? What that means is, whether it's meal kits, they're saying, okay, who's food insecure today? Let's get those folks, right, meal kits to help them in the short term. Let's get them signed up for grocery delivery subsidies. Let's get them enrolled in SNAP, right? We only use dietitians because they are trained to work with folks with specific chronic conditions. I'm a health coach. I have no business telling someone who has diabetes or has ESRD how they should be eating, right? Let's just be honest about it. Our dietitians, they're trained to actually do that. So our folks pass around some papers here. We put out some fantastic clinical data. This is the data point I'm most proud of here. We have shown that over 6 months, 42% of folks who are food insecure become food secure. That's why we named this title of the session what we did, right? Because we are addressing that. Yeah. How about some clapping, huh? Love that. Because we are showing that by actually addressing the underlying issues and teaching people how to fish here, right? Pun intended, that we can actually solve this issue. And what do you know? As part of this, we're seeing a 20% increase in fruits and vegetables intake, not soda intake. And by solving food insecurity here, right, we're solving a lot of the other chronic conditions that are associated with that. Obesity, hypertension, diabetes, right? These are all peer-reviewed journals that we've put out there because we know that starting with food insecurity and nutrition insecurity is the way to address these chronic conditions. And by creating a program that is really personalized, right? Our Net Promoter Score is 86, which beats Netflix for those of you streaming in the back of the room here. And the reason how we do that is because we have such a personalized solution by having the dietitians really create something personalized with their members. And with that, I'm going to turn it over to Jamie. Keep passing the mic? Thank you. One of our lovely clients with Children's Community Health Plan.
Hi, I'm Jamie Heber, Director of Case Management and Health Promotion at Children's Community Health Plan. We have been very fortunate to work with FoodSmart, and to be honest, we've launched other mobile apps and kind of technology solutions and didn't see great uptake with our Medicaid members, so we were a little hesitant. But they have been phenomenal to work with, and we've had really good success with members not only downloading the app, but meeting with the dietitians. Seen great uptake in telenutrition visits. Our care management team has been longing for this solution. Many of the members they're working with diabetes, they're looking for options other than medication to help control their condition and manage their condition, and so have been so excited to partner with the dietitians, work with them, help understand how to make those referrals both directions, been incredibly collaborative. So we've just been really excited about the success seen 2019, the SNAP enrollment has been huge. They took time to learn how to enroll members in the SNAP program in Wisconsin and are helping our members do that. So we're really excited. It's a new partnership for us, but really hope to continue to make it grow.
Shrita, can you hit the last slide there? Thank you. All right, so look, I hope you all learned something today, whether it's working with us, someone else. I honestly do not really care. Let's just do something about it together here. If you do think we might be helpful, there's my email address, or I don't have to tell you who the avocado folks are. You know, you've seen them. We are also doing we're using the term hackathon. I don't know. There's probably a better term for it. We'll find a marketing person for that. But we're bringing together stakeholders at regional levels, providers, payers, policy folks, right, people from the food ecosystems, to say, let's do some brainstorming together here as a community to figure out, for your specific states or communities, what can we do around food and nutrition and security. So we're starting that in North Carolina this summer. If you think your state or region might be interesting to do something like that, we're happy to talk about hosting that in your state or region. We are also, I'm going to tease and preview a food insecurity conference that we're going to be running later this year with some very entertaining speakers. I promise I will not be allowed to speak again. So please let us know if you are interested in attending that as well. Thank you all very much. Hope this was fun.
Thanks so much for inserting some fun into our morning. I have time for one quick question, if there are any. Okay, thanks.
That was awesome and fun, and I have two thoughts on that. One is, at HealthMind we see, in terms of rewards and incentives, overwhelmingly members leveraging gift cards to go to the grocery stores, right? So food insecurity is real. People are supplementing their grocery bills with these types of things. So this is very poignant, very appropriate, very awesome to have the data and the outcomes that we're able to see there. Second thought is, how the hell do I introduce James after that debacle that just, no, not debacle. That was fun. It is my pleasure for our next session that is around effective member engagement for prenatal and postpartum care to introduce my friend and colleague, James Haskins, who you all just met. James is our Senior Director of Government Programs at HealthMind. He has 13 years of experience working at health plans focusing on healthcare effectiveness data information sets, otherwise known as HEDIS, otherwise known as Hell Every Day in Spring, for Medicare Star Ratings, medical record review, and data analytics. Previously led a STARS program team that raised a plan from 2.5 to 3.5 stars. James is passionate about leveraging technology and advanced analytics to engage members in healthcare, resulting in improved quality performance. Graduate from the University of Michigan, go blue, with a master's in public health in 2008 and focusing on health and management policy. So James, take us away.
Thank you so much, Ken.
My pleasure.
Again, what a pleasure to be here. I gotta say, one of my goals always growing up was I wanted to be on The Price is Right, especially when Bob Barker was on. So this is kind of a nice thing. I got to do win a demo of that, so really excited about that. And then I'd say the other thing, even at my age, I get text messages from my parents, and they're so funny and they're so cute. And my mom was like, "I'm so excited for you today," and then she goes, "And you got dressed," and I was like, "Oh, so you mean track pants and hoodies? Does it actually count? Okay, good to know." Apparently we just been all working at home and my mom's eye just not getting dressed. Good to know. So I'm from HealthMind, which I think you guys have heard about. We're really a digital-first member engagement solution focused on improving gaps in care and clinical quality, and really thinking about the member experience and the member opportunity and how you really drive things into being better for it. Now, I know we've heard a previous presentation today on Medicaid and maternity yesterday. Luckily, not the exact same presentation, so not glad I'm giving you the same information twice, but I do think you'll see some common themes amongst things that we're talking about from the previous presentation, as well as even things that we just heard from our friends here at FoodSmart. So I'm gonna really talk a little bit more about why is there such a focus on maternity, pre and postpartum care, As we all know, COVID-19 and the vaccines has created a whole lot of, confusion. And then really talking about, how are we innovative in solving this and going forward with everything that's going out. So I know a lot of people who work in health plans, and everyone knows what, the quality metrics are. It's pre and postpartum care. But, I really want to go, okay, well, why is this such a thing? And I think what was shocking to me, and I know it was actually shocking to my mom, was that she learned that 42% of births in this country are actually covered in Medicaid. They are the second largest payer of births in this country behind private insurance. The other thing that is important to think about is when those babies are either low birth weight or really low birth weight, they cost 25 times more. And what's even more scary to me is that actually can be preventable, right? So people or women who are pregnant who don't have a prenatal visit are 3 times as likely. So when we really think about what we're trying to do as a country and as a society, we're thinking about bending that cost curve. Well, prevention is the way to bend this cost curve. These things are being paid out of tax dollars. So let's think about ways that we really can help not only control costs in this country in terms of healthcare costs, but also think about making a better future for our citizens that are being born through Medicaid. Now, I think we all know COVID-19, we're like a Fast and Furious movie, right? Like, we're in version 9 of this thing. I don't even know anymore where we are. Like, people are like, oh, when the pandemic first started, I'm like, yeah, that was 2 years ago, but it feels like 6 years ago. The reality is, from a science standpoint, we're still learning, and we're learning all the time. This is a study that just came out from Scotland, and what they're finding is women who have a birth right within 28 days and they had a COVID-19 diagnosis, those children have a 4 times higher rate of infant death. And what we're also seeing is vaccination rates in the pregnant population is much lower than the generic female population. And I'm going to really talk about probably why that is and what we can do to solve that. I want to also talk about things that we've talked about in terms of social determinants of health and really understanding your population. So this is some data that's publicly available from Medicaid services talking about really the breakdown of ethnicity within this population. And you'll kind of see there are definitely disparities in this population. And so when you think about knowing that, it's really important to understand what is your membership that you are talking about and what is going on with them. The other thing I also note here too is age, right? So typically what they consider as a high-risk pregnancy is, people who are really under the age of, I think it's 23 is technically considered high risk. So you have a fair amount of people who are in this 19 to 20 to 24-year-old race pregnant. And so they have high risk of concerns right here. And so when you think about all of these things together, it's in my mind, it creates a perfect storm. And so here is what things would look like for prenatal care normally, right? So again, the HEDIS measure, which I know a lot of plans focus on, except I learned from Colorado, they don't. Very fascinating to learn. Probably aligns with this answer, right? A true prenatal care timeline in a normal situation can be anywhere from 10 to 12 visits. So you'll see that there's a variety of visits that you really should happen. It's not just that first visit within the first 12 weeks of pregnancy. So when we think about what are we doing to help solve that, yes, we want to definitely raise our HEDIS rates, but we also really want to create a way to tell members that they need to do more. And HealthMind really has a solution that can do that. We can make health actions that will help you get to the goal of raising your prenatal care by offering them a reward for that first visit, but also giving them a pathway of the visits they need to have to really put them on track for good prenatal care. I will say, I've never been pregnant, so, But thinking about what it is, well, why is there so many visits? Because I definitely was like, this is an opportunity for me to learn. There's a lot of things that typically go on during a true prenatal care. So if you think about what needs to happen, well, I look at all these screens of tests and I'm like, wow, this is a lot. And no wonder these visits occur over 10 to 12 visits over the entire time of the pregnancy because, quite frankly, you really need to cover a lot during that time to really understand the healthy behaviors of what should be going on for a pregnant woman. Now, let's also think about after you have birth, right? So we focus about, okay, what happens during the birth? Well, what happens after the birth? Well, there's still a lot of opportunity here. So similarly, we also know about 40% of women do not attend a postpartum visit. And really, why is that important? Well, unfortunately, I hate to say this, we're going in the wrong direction right now in terms of pregnancy-related deaths. So in 1987, we were at 7.2 deaths per 100,000 lives births. In 2014, we were up to 16. So we're not going in the right way. And that's not a good thing, but is an opportunity. Because the data and the science that comes out of these institutions tells us this is something that is absolutely reversible. It is absolutely something that is preventable. So we know that women who have that postpartum care have a lower chance of getting depression. Depression not only affects the mother, right, but it affects the family. It affects their ability to serve if they have a significant other, but it also can limit their ability to take care of their child. And so what they have seen is that when you have a postpartum care visit, it really helps them do a lot of things. It helps them reduce the number of live birth deaths. It also helps them decrease the symptoms of depression. And it also talks about increased breastfeeding duration. I know that earlier one of our plans from New Mexico talked about the ability to talk to lactation and how to bring that in and why it's so important. This is the connection of how all of these pieces work together to create a really strong path forward for pregnant women. But I'd be amiss to think about pregnancy without talking about COVID-19. It's still here. And a lot has really changed about it. So when you think about something that's already complex, and then you throw in something about COVID-19 that's new, that's different, and there's just been still a lot of research, that's a lot of information out there. And what we're getting is we're seeing things that say, okay, there's an increased risk of preterm birth. If you have COVID-19, there's a chance that you can actually pass through the pregnancy. Again, we're still learning things here. We are also seeing that babies born to women who had pregnancy are more likely to get into the neonatal institute. And, if they're there, you can also think about them getting exposed. Most recently, one of the things we all have learned, though, is that COVID-19 vaccine looks like it actually may be able to pass benefits to the mother through breast care feeding, right? So if you think about that connectivity between the importance of a postpartum visit, encouraging women to, have that breastfeeding, being vaccinated, you can start making this trends that you can start to help pass along, the benefits of a vaccine so that we can finally move on from COVID-19 into a different situation. And I know I would definitely like to be into that next phase. I don't know about the rest of you. And I wanted to talk about probably earlier why there has been a lower rate of vaccination rates if COVID-19 in women. And the reality is, unfortunately, I love the CDC. They do great things in terms of research, but from someone who studies health management and policy, they did a very bad job of communicating this. So I will say on the right, there is a phone screen, and you'll see that this is a conversation, and this isn't a fake conversation, this is a real conversation. We protected the names of the people, but one of our other people that work in HealthMine in our product area, she's an epidemiologist, and this is a text message with her other epidemiologist colleagues from the University of Michigan. And what concerns me here is this bottom thing that's put on highlights. When the epidemiologists are confused, we have a problem, right? So if you're thinking that someone who's got a master's level degree is reading through CDC guidelines and doesn't know what to do, what are people who are Medicaid doing? What are people who have lower health literacy doing? This is confusing information to them. And think about the trend line of where we went. We start out in 2020 not having vaccines, started out the first part of 2021 saying, yeah, maybe you should have a conversation with your doctor, maybe you should talk to your OBGYN, until now where it's like, no, please go get this thing and please go get it now. Okay, so if you're thinking about in a year, we've done a 180 in education, how are we communicating that to our members? How are we taking something so incredibly complex and breaking it into a message that really resonates with people? Well, and I think that's where HealthMind comes in, and that's really where we see one of our value propositions. And how we do this is really through a lot of the themes that we've been talking about here at this conference, right? Data aggregation, member engagement and stratification, performance measurement and reporting, rewards and incentives. You know, one of the things that's probably different for us at HealthMind is we were born out of a health plan. And when you are born out of a health plan, right, our data is structured from the member level up. Everything is built that way. And we like to be an aggregator of all of the data together. Since we're here and Disney's real close, hopefully everyone knows what a Star Wars Jedi Master is, like Yoda. Well, our CTO wants to be an API master. And if you don't think that we're serious about this, we have a conference room named Dagobah. And I wish Jared was here because he's probably the one person that actually gets that reference. But the point there is it's our ability to really pull in all of your data, right? It's your self-reported data, it's your EMR data, it's your medical and claims data, and pulling in that social determinants of health data. You know, I think, we just talked from FoodSmart, yeah, they do a lot of questions in the doctor's office screening for SDOH, but it doesn't typically make it into the EMR. So you have to get that as a way into your system. Or if they have it in the EMR, how is a health plan bringing that into you? Well, that's one of the things that we surface back so that you can see in you of how we bring together this member-centric behavior. Then thinking about marketing engagement, right? So once you have all of your data together and you have all of your population, really it's about segmentation, right? Because when you think about, the previous slides talking about the ethnic breakup, the needs of things, you need to communicate to different populations in ways that they understand. And more importantly, you need to be able to do it in the modality that you understand. I think one of the greatest things to understand about how you really leverage SDOH is around language, right? So it's very common for people who have English as a second language to be able to speak it, but not be able to read it. So when you think about, oh yeah, I talked to this member, they talked to me in English, I'm gonna send them a pamphlet in English. No, they don't necessarily know how to read. That is a different skill set. So the answer may be yes, they can talk to your call center in English, but the reality is they actually need something in Vietnamese because that's actually what they can read. And that's really one of the things that we can do is be able to provide language, provide education pieces in a multitude of languages so that the member understands. The other thing is, thinking about text messaging, the ability to collect as part of our registration process, opt-in for both email and text, and as well as the ability for them to always have opt-out capabilities so that you're staying in the guidance of what your regulators say. And, I definitely appreciate Medicaid in lots of ways. It's like a snowflake. Every single state program is different. Every single state program is unique. But there's still a way to leverage with the power of technology to support all of those things by using core principles. Then thinking about, again, that communication piece. So we have communication pieces now. We're really talking about what's new, right? So what's new is you got to get things about COVID-19 in front of your pregnant members. They definitely have an opportunity here. We need to get them vaccinated because, it's not only causing challenges as we continue to draw the pandemic out, but it also represents a significant risk to these babies. So let's get that messaging out there so that they really understand what's out there. And then I think the other thing is, how do you make this program more than just visits, right? We've heard a lot of great ideas. So let's talk about having maternity classes, right? Let's talk about having, virtual baby showers. These are things that can be pulled in and provided events. And then again, you can communicate to them, hey, by the way, there's a text message. There's a virtual baby shower coming up. Let's send you a message about that. Call in. Let's provide you a link and thing. Obviously, I would say the fact that the pandemic has probably pushed this technology forward is really a good thing. Now we have opportunities for members to attend maternity classes both in person as well as virtually, right? And that's probably a really good thing because, I think about, someone who, yes, I'm pregnant, but I got a lot going on. They don't always maybe have transportation to get in person to a maternity class, right? So that's why the virtual is so important, is it gives members the opportunity to really get them to where they are. And then let's also talk about rewards and incentives, right? So you can pair really all kinds of things with incentives. And I would definitely encourage people to think about, well, how do you do it? I mean, I have always been a big proponent. We did this when I worked at a health plan. Diapers, very popular, right? Diapers, diaper bags, car seats. Those are all really opportunities to lead to members, to get them engaged for things, as well as gift cards. And really, what we offer is the ability to make a program that works for you. We obviously have recommendations, but it's things that we've been talking about. Thinking about how do you have a day per program, thinking about how you get food in front of people. These are all options that we can connect together to create this one comprehensive experience in a platform where the member is seeing all the things. The other thing that's really important is, remember, because we are member-centric, we're talking about longitudinal records, right? So if you're with us and we know you're pregnant once, when you're pregnant again, we can see that the member was pregnant before, and then guess back. We can go back and look at your past history, so we know what you chose in terms of incentives. We know what you engaged with, so it makes you a smarter in terms of your operations, because we understand what happened with your member, and they understand what is going on with that entire family. When I think about how a lot of things work, it's typically one member, one view, one member, one view. Well, when you're thinking about a Medicaid population, it's not uncommon for there to be a couple of kids that are close in age, right? Our solution is really set up to give a household view. So when the mother clicks into our application, they're going to see what they need for them, but then they're going to see their dependents, right, that are underneath them, and then they can go and see the other things that they need to do, because it's only common for them to be like, yeah, I'm pregnant, second child coming along. I also have an existing child that needs to get W15, that needs to be working on immunization combos. And so that ability to do household view and see everything in a platform, really useful. And again, the ability to really kind of do a double take here, right? The mom can get rewards for getting her own care, but then she will also get rewards on behalf of her kid for making sure they're getting the care. And so that's a really strong value proposition to someone who has suffering a lot of issues, and these rewards and incentives and even opportunities to food really help and drive behavior. As Kent said, we continue to see incredible use of food in our platform. So even if you don't offer food and you choose a gift card, our biggest selection of gift card goes to Walmart, because they're using it to address that issue. I will also say that we see members who are engaged in our platform 4 times more. They do 4 times the amount of health actions that are not registered. And I know there was a conversation earlier about, well, we've launched a lot of digital platforms and we saw success in other things. Well, we see the same success, and I think the answer is it's the value add. So if you're just texting a member to text them and it doesn't bring a value add to them, they're not going to do it. We bring a value to the member, and that value is what drives the behavior, not just the engagement. So this is an example really about our ability to curate things. And regionally tailor, right? Like, this is a giant country. I will tell you, I live in Michigan, I live in Detroit. My money will be going to gleaners in Detroit for winning Price is Right. But if you come to me in Detroit and say, I'm going to give you a Walmart gift card, let me go, where's that? Because there is none. I'm not a Walmart state. I'm a Meijer state. So if you can't get a Meijer gift card into my population, they're not going to do it. They don't care. You've given them something that they can't access. Who wants something they can't access? Nobody. And then how do you think about success? So, I have to say, it gave me goosebumps when I listened to Colorado Access Care. This is how you know I'm a data geek. I was like, ooh, you did an analysis and did a chi-squared result. Like, music to my ears, right? Because the answer is measure everything. It's how you make things better. And we measure everything. We always partner with our health plans to make sure that you are measuring the success that you want to have. Now, again, I know there are common things that are out there, so HEDIS is the thing that's out there that's popular, so we can track where you're going in terms of your PPC rates. But, you know, let's also think about how you think about other ways to measure a population health approach, right? So let's look at your low birth weights, you know, pre and post intervention. Let's talk about what your engagement rates are. Let's leverage things that are out there. The nice thing that's about Medicaid in certain ways is there are data sets and value sets, because the federal government does this, that will tell you, here's what I did. Great, thank you. I love it when you tell me how the research study, because now I don't have to go invent it. I just go take it, apply it, and then we can do the same sort of analytics with you so that you can think a little bit deeper beyond just HEDIS, but really think about what are you driving in terms of like population health improvement. And I think that, you know, going into that level of looking more about low term rates, risk adjusting for values, and really being able to replicate those studies is really how you show the value, into your organization. And then, of course, the money, right? We always got to bring in the money because there's an ROI here. To really say, okay, yes, I understand that, you know, we had lower costs, had lower birth weights this year, but what did that mean? So then take a look, okay, well, what was my spend around birth in 2020? What was my spend in 2021? What's that differential? Because that differential is a combination of really what you're trying to achieve, right? Improved outcomes, better cost spending. And with that, I know I'm preventing you from getting to break, but I think we have some time left. James Haskins, you're welcome to come talk to me, and if you want to talk to me about maternity or Star Wars or Disney, I'm more than welcome to have any of those conversations with you.
Awesome. Any questions for James? Cam? Sorry. I couldn't resist. Was there any? Okay. All right. Thank you so much,
Thank you.
James. All right, so we're gonna take a 30-minute break. It's an odd time to come back, but I'm trying to like make up time, right? So let's come back at 10:55 for our panel discussion. And this is probably your last chance to visit with a lot of our sponsors. So if there's somebody you've been wanting to see, you know, make sure that you make that connection during this break. And we'll see you at 5 to 11. Thank you.
I'm great. How are you? Doing good.
Did you have, oh shoot, step back.
You're all good.
Is there anything in particular? I know we did the prep, but we were just going to talk about those things.
Yeah.
Just kind of.
You will be fine.
All right, cool.
I'm going to have you
Just
guys
wanna check.
kind of introduce yourselves, which is always the best because then you can do your sales pitch.
I love it.
We're not going to be as interactive as Food Smart was. They had like a The Price is Right.
Oh, because you're a panel, right? Yeah. So she'll pull it up and I'll just do, okay, got it.
So
Yeah,
you're a
just-
moderator, or?
I'm after you as a presenter.
Oh, you're a presenter too?
Not for this,
Oh,
after
for the next
you.
one. Oh,
Yeah,
I
for
see.
the next
Okay.
one, 11:30.
Hi. I'm Adamika.
Yes,
We
I-
met
yes,
when I was
we
on the
did. I was
like
just
on
gonna
the
say,
fifth
you're not
grade or
outside
the
running around the
OCD.
playground.
OCD. So I just press that arrow button down to.
This one's actually mine.
Yes.
Nope.
So I told her, I said,
These are mine.
I
We
didn't
have-
want to start pressing buttons and screw it up for you.
No worries. Here.
just gonna say,
So
exactly.
we're going to go right to go forward, left to go back,
Now, where
and
do you-
that's like a little laser. She's
Right
just
to
trying to
go
be ready
forward.
for
Yeah,
after
right
the
to go
panel.
forward. Right to go forward, left to go back.
Yep. And I'll just pull that up on here.
Same. Yeah.
And then there's a, which one is the,
Although we get started
Right to
now,
go
so-
forward, left to go back.
okay. And then this is the laser.
Yeah. Yeah, I didn't know if I was
I
gonna
will
be
pull it
done.
up right now, and that way you
That's
can.
okay. That's okay. I didn't want to mess this gentleman up. I just wanted to.
Good.
So funny. I live in California. That I'm, cold
And then I can also get the arrow.
Well, he's in Medicaid.
You can, yeah.
Okay. All right.
But you're
Thank
used
you.
to it.
I
So,
didn't
like,
wanna-
there's a difference between.
You have enough stress.
I did my time.
no.
I lived in Boston for 5 years.
Fair enough. I would rather have it up and ready to go. It's one less thing.
Yeah.
So,
So I grew up
cool.
in Seattle.
So
We had,
it'll
like-
be ready. We'll
like,
scoot it down.
Like every
and
February.
You'll do that. You want her to
for
scoot
2
it
weeks
down.
kind of thing.
No, I'll come up
Oh
here.
yeah, same thing. Yeah.
Are you doing the introduction, Pamela?
Yeah,
Ken,
and that's
That's okay. It doesn't matter.
Oh, it's a
yeah.
different
matter.
Kent will be doing it.
When are we starting?
Favorites. I mean,
55.
Oh, 55? So
Yeah.
we got 5
We're
minutes?
5 minutes.
All right, I can still go to the restroom here.
lots and lots of time.
Sorry, guys.
More time than.
Okay. So, hi. Are we all here?
We are.
Pam.
We are missing.
He's gonna
Real
take a
quick.
quick
I'll be right back.
I'll go first. Is this okay here?
It's great.
Okay.
It doesn't bother me.
Can I scoot?
You can scoot.
So we're good. Yeah, this is my life. Look at all the snow. It's nothing. Although our puppy was like, all right, this is not working.
Yes.
When I started here, it was warm. How much snow you guys got around?
I don't know how much is on the ground.
Oh, for him? Forget about it. I mean, that's like.
I'll show you this. Oops.
One of my sister still lives in California. I don't know if again, I went to visit July.
It's a pretty narrow window. I mean, like, I have godchildren in Chicago. My window is like June to October.
Yeah.
So, damn. July is a very narrow window.
That's what I do for a hobby is camping in the winter. Go up to the Canadian border and the Boundary Waters, and that's a tent. Yeah, so it's an 8-second long exposure. Those are sparks from the chimney with a little bit of stove. So you cook on it.
Okay.
It doesn't provide a whole lot of heat, but it gives you a heat source.
One of those 50 below sleeping.
It is. We actually use two. You put one inside the other, and then usually I was just out there 3 weeks ago, and we had 2 nights of 25 below.
But I think it's just beautiful.
It's and you never see that.
It's probably perfectly quiet.
Well, you know, it's shocking. I live in the Bay Area.
Yeah.
And I do a lot of hiking. And we have national park.
It's beautiful.
But I go a lot of times where there's no. And you think the Bay Area is so beautiful. But a lot of people don't. Well, you grew up in the Pacific Northwest too. Like, so me, like, it's in my bones. Like, I have to get outside. No matter where I've ever lived, like, people thought I was crazy when I lived in Boston. I had one friend on, like, go around with why? But I need to have fresh air.
Where you are, you like the hike up Mount Tam.
Oh, yeah.
They're just
Very easy. Right there.
It's like we were a kid. We grew up on 10 acres of land. Everybody that walked were on 10 acres. So my dad would be like, there was 3 of us boys. The guys get up in the morning, there was 3 empty bowls of cereal, and you're gone. Disappear into the woods, maybe come out from lunch.
Hey, how are you? Sounds good. And Juan Pablo's coming, or should be here.
I am moving forward. I mean, it's great.
Yeah, I'm ready whenever you are.
You have to. You just have to get out.
I do.
Sorry.
Hey, it's cereal. It's cereal.
Yes, we are food
I was excited because at least they don't conference we went to, they did. They had hardwood carrots, they had like granola if you wanted to jack, so they had these things like that. Well, they had a bag of peanuts. They only had like 4.
Okay, that's
Exactly.
4.
Yeah.
That was somebody who didn't like peanuts.
When I got there, I was down to 2.
Speaking of like cold, I mean, it's. I'm not going back till Sunday. Smart. I don't care.
It's like the only conference I'm looking forward to because they know how to do it.
Yes, they do. Yes, I'll be there.
You'll be there?
Of course.
I want to do a dinner with like a few of the Miami people, like Christian Seal. I don't know if you've seen him in a while. Christian's kind of like disappeared. I don't know. He's like out of the mix. Oh, seriously?
Yeah, it's like, where have you been?
Yeah.
I want to talk to you about Love is America stuff. When you guys are talking larger business stuff.
Yeah, absolutely.
Because,
a lot of.
well, because United Way is pressuring me, and I was like, what?
I would love for you to do that. If you're interested, there's 100%.
Yeah, I would be.
But you and Karen need to get together.
Okay.
So that we can have a conversation.
In DC.
That needs to happen.
Yeah. Yeah, that's fine.
Oh, we
Okay.
can see Karen 25.
Let me get my spectacles out.
Just knowing kind of her, she's very like DC.
Yeah.
Like it's not in DC. It's like she's DC.
Well, then let's do it in DC.
Yeah, let's do it.
Give you guys a brief intro. Let them introduce themselves.
You guys are
My
far
part's
smarter
easy.
than I am.
Oh, all right. I
Did
don't
you like
believe
that?
for a
Sounds
second.
good to me.
I mean, if you want to say that
Okay,
during
gang.
the panel now, go
Welcome
for it.
back, everybody. We're going to get rolling this morning.
As I tell people, I'm a pamphlet of information.
My own panel is just making a ruckus up here. Yeah.
Here you go. Here.
All right, so next up, gang, we've got a panel discussion. We love these. The title is Using a Wide Variety of Digital Tools and Apps to Engage Members, Improve Member Satisfaction, and Support Better Health. And so our moderator is going to be Adamika Arthur, who's our Executive Director from Health Tech for Medicaid HT4M, and she's going to introduce our esteemed panelists or let them introduce themselves. So I will hand it off to you to go forth with that.
Sounds good.
Awesome.
Good morning, everyone. So Food Smart kind of started this morning out with a Price is Right. And if you know me, I don't like being like one-upped. So this panel is going to be loud and proud, even if I just make you guys clap at the end. There we go.
Okay, we can go.
It was great, though. I mean, if anything, we need to be focusing on food insecurity, and so it was really good panel earlier today. I'm going to kick off this topic using a wide variety of digital tools and apps to engage members, improve member satisfaction, and support better health. It's a whole lot in a very short panel, but we're going to get to it. I'm going to have each of the panelists introduce themselves, and then we're going to have them say who they are, what they do in this space, and
and then we'll dive into some conversation. All right? So I'm Adamika Arthur. I run a nonprofit called Health Tech for Medicaid. We are a convening body and a think tank specifically looking at improving the lives, the equity, quality, and dignity of life for Medicaid members across the country. And that's all 76 million in 56 different states, districts, and territories. And we do that through Medicaid Insights, building an ecosystem and infrastructure development, and also doing policy and advocacy work. I'm going to kick it off to you.
Thank you. Kurt Waltenbaugh. I'm at Unitas, Senior Vice President of Insights and Growth. And I founded a company called Carrot Health, which sold to Unitas in August. And our focus at Unitas is integrating health with social care. So stitching together all of the community benefit organizations nationwide and sharing data about the people that we're serving with all of the relevant parties in the community ecosystem. From an insights perspective, my focus is on understanding each person as an individual consumer and using data to do that at a 360-degree level. So you'll hear me talk about a lot of anecdotes of things we know about people based on how they behave in the communities in which they live.
Awesome. Hey everyone, my name is Juan Pablo Segura. I'm one of the founders of a company called Baby Scripts. At Baby Scripts, we create virtual maternity care experiences. So it's a combination of an app experience for education, and then we actually ship these kits to moms' homes, or their providers give them kits with internet-enabled medical devices, blood pressure cuffs, weight scales, blood glucometers for remote patient monitoring. And a big part and a big focus of what we do that makes us pretty unique is we'll partner with plans to not necessarily go direct to member, but we'll actually go to providers in network, have them install Baby Scripts, and work with both the provider and the payer together to engage a member/patient. And so a lot of kind of what we talk about and what I'll probably be bringing up is the power of leveraging providers in network. I think it's a step that's often ignored because a lot of people just say, oh, providers are really hard to work with, so let's just try to go around them. I think in Medicaid, and particularly in maternity, providers are a crucial part of the equation and conversation. And so I'm really excited to be here. And we work with like 80 different health systems in 31 different states and a lot of the large national plans. So we do have a good amount of experience doing it.
Thank you. So David Duhame, I'm the regional manager for Thomson Reuters. Our solution is where we combine, everybody's probably heard of Thomson Reuters, the news agency. They have a lot of information, but we're also one of the largest data aggregators in the country. And what we've recently done through an acquisition is we brought in data analytics to incorporate to that third-party data where we're looking for fraud, waste, and abuse in the programs. And again, as the panel here, they have a lot of information, and you heard the term 360-degree view. That's one of the things that we offer is we're able to look at your providers and ensure that those providers are providing the care that they're supposed to, but also not creating a risk for your particular plan, and really to ensure that we minimize the provider abrasion, but also protect your plan. So what you'll hear, I think, will fit well with a lot of what we have. We're a little different because of what we're looking at, but again, all this does come down to trust, and you need to be able to trust the people that are providing the services.
Pam Tropiano, VP of Healthcare Services for Molina Healthcare in Ohio, and I work you obviously, I attended yesterday, so you understand what I do in the scope, but for this particular panel, I work every day with our teams trying to leverage the technology and trying to get what's optimal and the easiest solution for our members to engage.
Great. So now we're going to get to a little bit of the nitty-gritty. What are you guys seeing as barriers to member engagement? And when I think of that, what are some challenges you're facing when trying to build trust in the communities that you serve? And you may want to talk about demographics as you're discussing that.
Yeah, from the perspective that we look at, engagement is something that's really personal, right? And you have to get down to the individual person level to better understand how to reach that person, that member, where they're at with the specific need that they are willing to engage in. So often we're trying to push things that are relevant to us, the plan, right? and say, here, I have these quality measures, I have these gaps in care that I need closed, I have this total cost of care issue, I need to reduce ED visits. But that's not necessarily where the member is at and not necessarily what the member is willing to work on. And so that, from an ideal world perspective, right, we would know each of our members personally and we'd be able to understand that within that relationship how to engage them. But of course, whether it's 10,000 or 100,000 or 500,000 lives, we can't do that. That's too expensive to get down to that personal level conversation. So we have to use a proxy, and that proxy is data, to be able to collect it at the individual person level, use it to understand the variations in behavior and the inflection points of where someone is at so that you understand what they are willing and able to work on in that moment, and then capitalize on that. And so we can tell you very interesting things when you look across the community. For example, to food insecurity from the discussion we had prior to break, members who live closer to a fast food restaurant than to a fresh food grocery store, just that one data point, have a 22% elevated risk of obesity, right? And then you combine that with other pieces of information getting to time-poor members who are challenged to, not only to buy fresh food, but to make it for their families, right? Someone who might be working 2 jobs and struggling to catch food in between. Understanding where those opportunities are and how to capture and engage them is really the key to boosting that engagement, to putting offers in front of them that are relevant at that time.
Yeah, I think, maternity is kind of a vertical in care delivery. I feel like most plans that have presented the last 2 days have had like a piece of their strategy talk about maternity, because there are obviously a lot of challenges. I think one of the things that we've seen, it's really about the trust and the messenger. And I say that because what ends up happening, at least what we've seen in maternity, is a lot of care management is very reactive, right? So they don't have the relationship, or they haven't really interacted a lot with a member. All of a sudden they file a claim, and then it's kind of this fly-in approach where it's like, whoa, okay, something's happening to you. I need to kind of come in and call you. 1-800 number, someone they've never met before. And there's a big question as to whether they'll pick up or even engage in the first place. And so for us, what we started with, and this was kind of on purpose, but we didn't understand all the challenges that plans had originally, is we really thought about the provider as a trusted channel. Now, are there limits and are there issues with how providers engage with their patients? Absolutely, right? Implicit bias, all kinds of issues. But at the same time, the relationship that a patient has with their provider during the pregnancy is a very special one. They're seeing them 14, 15, 20 times, maybe 30 times if they're high risk. And so there's a very unique relationship there. And so when we looked at the maternity experience, we were like, well, how can't you leverage that trusted channel in both onboarding a member onto a program, but also monitoring a high-risk condition and even making interventions based off of those conditions. And so, what we've seen is looking at like stakeholders and trying to understand who has maybe a better relationship with the member in the first place is incredibly important to starting to kind of narrow that gap. And yeah, it takes time. You gotta do a lot of technology things like use case, member stories, journey mapping. But I think we've really, and the users of Baby Scripts have really benefited from kind of this joint provider-payer partnership.
And one of the common themes, obviously, you're hearing is trust. You want to be able to trust those people and get the members to trust who they're going to. And one of the advantages of layering on your analytics when you're looking at your data is finding those providers and ensuring that they are providing that service. One of the things when we look at potentially underserved areas or areas where you have socioeconomic issues and things is oftentimes the providers are incentivized to go to those areas. You want them to render the service. You want them to be there. Unfortunately, it does create a situation at times where they capitalize on that. And what that does when people see things like that is that erodes that trust. They tend to think, well, this provider is going to capitalize. Is that what they're going to do? Are they going to commit some type of fraud, waste, and abuse? So by being able to look at that and identify those, you can mitigate those things earlier, continue to get the trust, but also by looking at your claims data, kind of what you were talking about is, is the service matching the outcome? Is the service equaling what we have set up in our policies? And is what we create, or what we have for services or what we're doing for policies, are we creating the vulnerability and the lack of trust? So by looking at all this and identifying that within your analytics, you help drive policy, you help drive outcomes, and you also mitigate the risk and ensure the trust that people want to go to see a provider.
And from the healthcare services standpoint, you know, our team is really very community-based, community-driven, even now, you know, even with the public health emergency. So we're out there working with the hubs, working with all the community agencies. So, you know, obviously the personal touch or the, you know, having that presence out there and that connection with those teams is really vitally important. But before any of that can happen, as we're discussing, is that you've got to be able to sort the population to know, you know, we have 300,000 members, you know, how, you know, who do we need to engage first and prioritize that? I know I touched on that yesterday, but we have members from, you know, birth to end of life, and, you know, being able to sort those and have some semblance of where the teams need to engage. We do use that data also to look at hotspots throughout the state, knowing that as well. And then we have health risk screening, health risk assessments that are done on 100% of the population, and then looking at that information as well. The 800 number that someone mentioned has never really worked. IVRs are not the greatest, but we will do any, you know, building and looking at any type of contact. But the trust being making sure we can help that member engage in services within their neighborhood, you know, where they, you know, where they go to school, where they shop, just building that neighborhood concept.
Yeah, you know, it's interesting when we think about data. I'm an epidemiologist by training, and so, you know, I think data is one thing, but how we use data is another, right? And how we collect the data. Because we all know that junk in is junk out, and I think if we're using junk to you know, stratify how we're best engaging with people, but if we're doing risk-adjusted data, we're doing data that really tells us a bit more about the story behind the member. I'd love to start with you, Pamela, to tell us a little bit about what do you see or what do you believe in are tools, right, in better understanding the member experience and hearing members' voices. I mean, a little bit more than just the data, but the person who's behind that data set.
Right. So building the trust is key. We actually, you know, in several of our meetings with the Ohio Department of Medicaid, their medical director, Dr. Applegate, is just passionate about that. She, you know, especially on the maternity side with children, she, you know, every time we meet with her, she, you know, reinforces the importance of, you know, building that trusted relationship with the members. So that is just really key. And then I know we've talked quite a bit about social determinants of health. Well, those have to be part of the data that you're looking at. They have to be part of your health screens. Any contact that we have with an individual member, we cover those questions over and over just to make sure that we're not missing anything, because if the top social determinants of health are not being met, or those are an issue, nothing else is going to happen in that member's journey or in their life. So trying to close some of those gaps. One of the newest things that we did add to our clinical documentation system is a link and an attribute in there so that anybody who is contacting that member, they ask the question, what is your preferred method of communicating with us? Would you prefer texting? Would you prefer email, you know, live contact? So that has really helped too, to try to get that right away so that we can engage that member in the way that they feel most comfortable.
Great. Anyone else want to comment specifically on what tools you're seeing to understand, or like what's on the horizon to ensure that members' voices are heard?
I think part of that is what isn't working, right? And some of the tools are aggregating information to make it more digestible, but in doing so, you're losing fidelity down at the individual level. So if you look at things like the Social Vulnerability Index or area deprivation index or the neighborhood stress score, they're rolling social determinants of health up to a higher level, whether that's zip code or census block or tract. And by doing that, you miss the richness of what happens on a person-to-person level. One thing that you miss is you miss the demographics about gender and race and ethnicity and language, and it masks disparities by aggregating and averaging people within a community. And so you're not able to get to the real why. A good example, we had a group that I worked with that was working with an intervention around opioid use disorder, right? Alternative pain management strategies to keep people off of opioids. And they weren't getting the engagement rates that they'd like to see because they were looking at the data from purely a clinical perspective, using clinical risk scores to say who is likely to have this condition and then reaching out. But by overlaying information at the individual person level and better understanding context, you can pull out a more rich understanding of those individuals. We found a cohort that happened to be mothers with young children at home, subset of the overall population, but by messaging to that cohort instead of a generic message about how to manage your pain, the message was, in this case, a visual of a child sitting on the sidelines of a soccer field, and the message was the child is missing out due to mom's pain. 400% higher engagement rate, right? It jumped from 8% to almost a third of that population engaged in the program and became, use those tools to prevent the backsliding into opioid abuse. That's the sort of thing that you miss if you're looking at averages. And so, for me, the biggest advantage we have in data and tools today is to get down to the individual person level.
Yeah, I was just going to add to that. So I think technologists have a responsibility to first start at the member, and so this might sound very obvious, right? It's like, okay, of course you need to start at the member level. You need to start at the patient level. But I think what happens is you have a lot of biases in the technology industry, and the work that Adamika is doing in this space is incredible because she's creating consortiums of tech companies that are specifically focused on Medicaid, and that's very rare. A lot of investors, for example, don't fund companies that do work in Medicaid. They try to push you away from Medicaid because it's too hard. So while some of these things are like super simple, it's like, of course, why don't you think about social determinants of health? And like, we're all talking about social determinants of health, right? But there is kind of that challenge initially, and I'll be kind of very vulnerable. I'm a man that started a pregnancy company, okay? So there's a lot of irony in there too, right? So I think that's the first piece. And I'll use an example of how we made mistakes when we started Baby Scripts and what we've learned from. So when we started, we actually did not focus on Medicaid. We focused on only commercial patients, helping commercial, like upper income mothers have more convenient pregnancy experiences. And so we kind of had a product that like eliminated the need to do 50% of your prenatal care. And so that's great for a mom that's super healthy, super engaged, obviously has a lot of resources, but that doesn't work for a patient population where they're probably not showing up for half of their prenatal visits to start with, right? Or 75% of their visits. So we did a lot of these patient interviews as we like kind of had this epiphany, and we were like, we need to go to where all the challenges are, which is in Medicaid. And we realized that, okay, well, what if we just changed our product so that it isn't about reducing visits, but it's about allowing moms that are working 2 jobs and have to make decisions between whether they put food on the table or go and see their doctor for 15 minutes. We were like, well, what if we just change the emphasis or the point of the product to not reducing visits, but making it easy for moms to do their prenatal care at home, instead of having to take 4 buses, 2 trains, spend 5 hours paying for parking to go see their doctor for 5 minutes. And just that change in focus of a product by listening to your patient and focusing on this patient population is transformative. And that's actually what allowed us to start partnering with managed care, because there's like, finally, you have a product that actually helps our member population. And so I think it's that kind of responsibility. Like, no one's going to just hand you that as a technologist. You have to go into the communities that you're working with to solve those issues.
And And even though a lot of what we talk about, or at least from our space, it is the fraud, waste, and abuse side of it. Now, the one advantage we do have is we actually review and analyze about 34% of all the Medicaid data in the country. So we have a wide berth of information that we're taking a look at, no pun intended, that we have to take a look at. But one of the things we can do is we talk about these, and I think Kurt said it great, which is we do a lot of, we roll that up. And then we look across and we say, here's a trend, here's this, here's an outlier. But the thing you can do with a solution too is you can also turn it on its head, because we can incorporate things like geospatial, we can look at number of visits. And part of that, you can now look at the provider level and say, well, why is everybody going to this provider? Why are they going that distance? Well, it's because they're getting the outcomes. They're getting that experience that they're looking for. So you can use the data in multiple ways. You want to help to identify risk, but you can get, as everybody says, get granular. We do tend to roll up. That is the way we look. We kind of look at everybody and evaluate them and determine who's at risk. But you can use the data to really identify why are people doing some of the things, because the trend may not be that it's fraud. It's maybe they're getting a better experience.
And just to add really quickly,
Sure.
one of the biggest eye openers for us too, and for all of us, is that we realized over the last several years very quickly that our healthcare reimbursement system, our health system is just, it's been the same for many, many years. And I think it's evolving, but the best lesson is go to the federally qualified health centers and the community clinics and talk with the physicians and talk with the practitioners there, and they will tell you right out of the gate that many of the things that we think will work, or many of the things that we do, will not work. And they'll give you all the reasons why. So you can, we learned quite a bit by going to the providers and asking them, here's all of our programs, where do you see us having to change?
Yeah, it's really important. I mean, one of the things I will say as being a convening body, specifically in Medicaid, is when you bring together payers, providers, policymakers, entrepreneurs, investors, people on Medicaid, their caregivers, families, and ultimately the community, you do have 57,000 different languages. You have just as many languages as you have, we split Medicaid 56 different ways, right? One of the things, and this is like a public health adage, but I try to think when we look at the crosswalk, literally, to digital tools and apps to member engagement and satisfaction. And engagement and satisfaction are two different things, but is the public health analogy I always think of as it's very easy for all of us to cross the street, right? See a crosswalk, pretty much can cross the street. 99% of America, you can cross the street, unless you're on private land or and part of that is if you have a young child, you can still cross the street. If you have a cane, you can still cross the street. You have visual impairments, you can still cross the street. So how do we create that sort of crosswalk, a digital crosswalk that allows for everyone, to be able to cross the road? And that way, even though we have disaggregated data and we can look and slice and dice, and we've really creating a solution, I think, Juan Pablo, you really spoke to this, where we're not thinking about we use this for our commercial pay customers and we use something completely different for our Medicaid members. So I'd love to, as we're kind of getting close to closing here, think about what is your crosswalk moment? Either what does your product do that creates that digital crosswalk for patient engagement or member engagement or people engagement, and satisfaction. What would you see as being that moment, or what are you seeing in the ecosystem that is giving that moment? Anyone can jump in.
I'll just start. I love the crosswalk analogy, and the first thing that leaps to mind to me is think about the benefits that we get in middle class and upper middle class households. Think about the mortgage tax credit, right? You don't have to apply for that. You don't have to re-up it every month or every year to make sure that you get it. You just have to file your taxes, and it magically takes, puts money back in your pocket. For the benefits for our Medicaid members, many of them have to reapply on a monthly basis, right? And to be able to stitch together all of the different programs, this is how we're making the crosswalk hard, right? For healthcare, for social services, for community benefits, some provided by nonprofits, some provided by local governments, state governments, federal governments. It takes a long time. And just to be vulnerable on my own. So as an entrepreneur over the last decade, right, building Carrot Health, I was in a point for 2 years with not enough income to qualify, and my kids were put on Medicaid. And trying to manage their Medicaid benefits, I probably spent 80 hours in the first year just trying to make sure that we got applied and we got reapplied, and all of a sudden our doctors weren't in network, our dentists fired us because we didn't have commercial insurance. It was really, really hard. So when I look at Unite Us and what we're doing to stitch together all of the different benefits that are available to people across this country, those in most need of social care and health care, and trying to create a seamless way for them to navigate that process and to make it easy, right? To press the easy button so that we can get people the benefits that they need to survive. That's the real crosswalk issue for me. Let's make the benefits that are available as easy to get for everyone in the country as we do for the wealthy.
Yeah, I kind of talked about this when we started. So yeah, we think the provider's a crucial part of that maternity experience. And so I'd use an example, what we do with postpartum hypertension. If you know kind of the postpartum space, postpartum hypertension, #1 reason for maternal readmission, postpartum, #1 reason for maternal death, postpartum. And so one of our most powerful products is postpartum hypertension monitoring. And so at the hospital, as a mom's discharged, they not only get our kit with a blood pressure cuff that's Bluetooth enabled and pairs with our app, but the team, the nurse team, actually has the patient always take their first measurement in the hospital before they check out. And they explain to them, this is why we're monitoring your blood pressure, because there's something called preeclampsia that could kill you. And so it's that kind of handoff, that warm handoff, where it's not something that just comes out of the mail randomly, and it's like, do this because I tell you to do it. It's like, no, and I'm going to teach you how to do it. I think that's really powerful in how we get engagement. And that's a pretty intense protocol. It's like 16 days, take your blood pressure 2 times a day, and we have more than 85% compliance on that program. So, I think as we look at just like, the channel, and I love the crosswalk analogy. Yeah, you've got to have someone kind of sometimes guiding you through that crosswalk as well.
For us, let's face it, getting providers, as you talked about access to care, being able to understand the benefit, even getting a provider to participate in a Medicaid network can be a challenge. So one of the things that you do, if we're able to minimize that risk, we're able to get rid of the providers, or at least minimize those that potentially create a risk to the program, you prevent the losses, because everything that's taken through either waste or abuse takes away benefits from somebody else, takes away the ability of the program to potentially expand and offer more. If we're able to minimize that and properly incentivize the providers, because you're monitoring the system to keep those people out that create the risk, 1, you reduce your losses, but 2, you potentially increase the ability to expand benefits, to offer benefits more effectively, and then the providers feel more comfortable being part of that network because they're potentially not considered to be something where they're vulnerable or these are the people who are taking advantage of the systems, which also goes back to what we started with, trust by the members that the people that are there are going to give them the service, and then you're able to ensure that maybe we can even expand the benefits because we're not losing money.
And I really like the analogy of the crosswalk, and I definitely use that. It's great. I love it, and I think that in our in our company, on the healthcare service, actually across the entire any member-facing area, let's put it that way. If I think about that crosswalk, and if anyone's having trouble crossing the street or getting across, there should be we have automatic triggers that. It's automatically to a queue, or, we get an immediate referral to the appropriate team that can help them across the street. And I think that's the way we handle that. And if you don't have that, it's never going to be a good situation.
Yeah. I know we're kind of wrapping here in a few minutes, but I want to implore the audience. Oftentimes we go to these conferences, we get out of our snowy environment, for those of you guys who are painfully in places not like mine, in California. I'm kidding. But we spend a few days but we've left here with this tag that says something about, Medicaid innovation. And I really want you to go back and think not just about the business cards you collected or the 3 or 4 new contacts that are amazing or the 5 or 6 products you've thought about, but to really think about how are you advancing Medicaid innovation? How are you making a difference for the over 75 million people, the 1 in 5 Americans, that are really trying to just, manage and understand their health insurance program? And that doesn't include, the folks that don't have insurance in this country, right? And so we have an obligation, I think, to, when we go to these conferences, to figure out how can I better engage members? What is an interesting and new app or technology that I've heard about that I can share with my team? What was a really interesting program that we don't do here, but I heard about they did in Mississippi or something of that nature. So I think as we close today, one of the things I'd like to implore all of you to do is think about not just being here, but what are you doing to advance Medicaid innovation, and how can you go further to stretch that crosswalk? Thank you for your time.
Thank you, Adamika and panel. Do we have questions for the panel? Okay, we do have one back here.
Great panel. Just a question for anyone on the stage. Sometimes not engaging the member leads to high satisfaction because they're a non-utilizer, they're healthy, and they're like, please stop texting me. So I'm just curious to know on your approach for those types of members, how do you not engage members or something like that?
Well, not engaging is engagement, right? Because engagement is understanding the needs of those individuals that you're trying to reach. So that's where I said satisfaction and engagement are 2 different things, but I'm curious to hear what you guys think.
Yeah, 100%. Errol, I think the key is to understand who needs engagement and what type of nudge do they need, if any, right? And so one of the things you can do by looking at data, if you just think about something like gap in care closure, cancer screenings, and other elements, if you look at the population on January 1st, you can determine using predictive algorithms who's likely to close those gaps on their own and who's not. And now you've instantly got a pool of people not to reach out to and not to waste your touches, your abrasion on, because they're going to do it anyway. You've also got a pool of people that instead of waiting until Q4 and doing chart chasing to try to get those closed, you can start reaching out on January 1st to begin putting information in front of them in a gentle way so it's not a mad panic in Q4. And so from my perspective, it's overlaying kind of like a Venn diagram, different models to understand propensity and how those members like to be engaged. And one thing I'll caution is it's very clear that self-reported how I like to be contacted is not necessarily how I respond best, right? Almost everyone will say something like, well, just send me an email, but maybe that's not how we respond best. So understanding those 2 overlapping components, we can get to the right answer without wasting satisfaction points.
So just on the pregnancy side, I think this is a really interesting use case because most pregnant women have at least 5 pregnancy apps on their phone at any given time. That's like a real stat. So one of the things that we've seen is that while there's like a ton of consumer apps that will tell you the size of your baby in relation to like if it's like a watermelon or like a kumquat, right, or whatever, but I think the more confusing part of the pregnancy experience is when the actual clinical stakeholders try to then engage the member. So you've got the public health department has an app, the payer has an app, the provider has an app. And so I think what we've tried to do is consolidate that. So like, what if the payer and the provider are on the same app instead of them each individually offering an app? And so I think that's what confuses the member most because they can deal with the consumer ads like on Baby Center, but they can't deal with a doula from someone, a care manager from someone else, and then a nurse from another group trying to tell them something, and sometimes it's not the same information. And it's like, well, then what do you do then? So for us, it's like, hey, let's try to bring it together.
And I agree with you, certainly on the, the engagement, and I say this more because we look more from the provider level. One of the things you want to do is properly screen your providers, properly monitor them, because there's a lot of reporting. Let's face it, Medicaid wants the reporting. You have to do this thing. There's things that you need to engage. But engaging the right provider, just running kind of a blanket review and then going after a provider who you don't need to, you create provider abrasion. We already said Medicaid's hard to get into. If you upset the provider community inappropriately, they're going to leave. What's that going to do to the member engagement? They no longer have that provider available. So I think you're right. When you're reaching out and you're making that contact, address the issue. Don't be so broad in your approach, because you potentially create more of a negative impact on your population.
Right. And we, I think that at Molina, we have a really solid mechanism of not contacting members. If they say no, they're on a list, and we've got that built in so that it's pretty flawless. Because the opposite is not a good situation.
But it's also important to make sure you do the other part of that loop, which is that when you need to engage with us, we're here for you.
Exactly.
Oftentimes when we hear no, we think that means no forever. That means no for right now, because I don't understand this email, or I don't need this, or my life is too complicated. But I think that other piece around, this is care, not telemarketing. Nothing wrong with telemarketing. And so how is it that I come back if I need something at all? Does that answer your question, Errol? Any other thoughts? Do we have time?
2 minutes.
It's 2 minutes or a Nutri-Grain bar. Come on, y'all. All right, Nutri-Grain for all of us.
Thank you, panel.
Very short, but also very varied.
Yes. Oh, this one.
Thank you.
Okay, friends, thanks for that great panel. Next up, we have a session that is entitled Leveraging a Connected Care Platform, Driving Value-Based Outcomes with Technology. And with us today, we have Rosemary Kennedy, who is a doctor of nursing, RN, MBA, and also a fellow with the American Academy of Nursing. As the Chief Health Chief Health Informatics Officer at Connect America, she leads development of analytics to assess and impact the health of information technology and outcomes. Rosemary's career is focused on developing, implementing, and value creation of digital technology, workflows, algorithms, and population analytics. Prior to her position here, she was Vice President, Chief Nursing Officer at Sotera Wireless, focused on body-worn sensors, really cool, measuring ROI and performance improvement. Rosemary was Vice President of the National Quality Forum and QF, leading a team in developing electronic quality measures for value-based purchasing. So you were the right person to talk to us about technology. So Rosemary, take us away.
This is somewhat embarrassing. It would make my mother proud, but it's difficult to listen to. Thank you. I'm honored to be here because prior to getting my PhD, I spent many years as a home care nurse, caring for those that were Medicaid, the Medicaid population, in a city that was struggling with social determinants of health, et cetera. I just wish back then we had the technology that we have today to support the needs of those patients and subscribers. So as Ken said, I am the Chief Health Informatics Officer for Connect America. First and foremost, I'm a nurse trying to move the needle forward in this national agenda to provide care for the vulnerable and the elderly. Our mission is focused on, very specifically, enabling the elderly to live in their homes independently with the optimal level of care. How many of us want to be told by somebody that we have to move out of our home? Probably nobody. How many of us want to stay in our homes? 85%, based on statistics of the elderly, want to stay in their home. It's probably lower cost, more efficient. So we achieve our mission in doing this through a connected health platform in the home. And as we move forward with the technology, and you've heard a lot of this the past couple days, that technology platform has 3 major pillars. One is to enable individuals to live in their home in a safe fashion. So if they need something, they can press a button and they can get a response. So it's safety. Number 2, to enable them to stay connected with their family and caregivers. And with COVID, it's even more important, staying connected. Some of them don't have family and friends. Maybe their connection is a social worker. And then number 3, enabling the ability to detect early deterioration in their condition. So it's safety, connection with the world around them, and detecting deterioration in their condition. So we're going to walk through a pilot study, IRB approved study. I fundamentally believe that data should drive all of our science, and a lot of what's being presented now is what we need as we move forward. As long as I can move the slides forward. So we'll go over drivers, and with all due respect, you folks are living this every day, and discuss some of the drivers that really impact the vulnerable populations. We'll provide an overview of the connected digital platform that's needed to care for seniors in their homes, and then a case study, totally data-driven IRB study that's been published in the literature, and discuss the results and some of the challenges, quite frankly, as we move forward. And when I say we, I mean the collective we. So some of the drivers. We've seen a lot of converging forces in terms of factors that are impacting particularly the elderly and vulnerable populations. 75% of seniors have 2 or more chronic conditions. 1 in 4 adults will fall over the age of 65. Poor care coordination, and you folks are living this every day, results in $25 to $45 billion in health care costs. And 58% of patients are leaving facilities without monitoring or care coordination follow-up. And the problem is more than what statistics are telling us, because there's a financial impact. $27 billion in annual readmissions, $77 million in Medicaid readmission cost each year, and Medicaid accounts for the 2nd largest share of all hospital readmissions. I say this with all due respect because you folks are living this every day. But behind these statistics is an elderly person that's in their home that is trying to make their way each day and has a story to tell. Yesterday we heard about the crisis and the psychological impact that these individuals have as they're trying to live independently in their homes. They have no option. So as a home care nurse, I heard the stories. So the numbers were on one end and the stories were on the other end, and how do we reconcile the 2 of them? Because there's a lot of crisis in the stories and the lives that they're living each day. If we look, the collective we, at the connected health platform that's needed in the home, it has 4 major components. One is personal emergency response services. No individual should be in a home by themselves without a connection to somebody to help them. When I would leave a home as a home care nurse, I think, what are they going to do? I'm not there. They don't, at the time, 100 years ago, they didn't have a button to press. They had nobody to say, I have a symptom, I'm short of breath, etc. So personal emergency response services is key as part of the platform. You know, there's the age-old that you press a button, I'm falling down, I can't get up. We're beyond that in terms of healthcare. It's actually a service, it's part of the care delivery model. Because the data, and I'll show you, that I've analyzed, they're pressing the button not because they're falling down, because they're short of breath, because they don't have meds, because they have pain, and because their legs can't move, etc. So you want to talk about member engagement? That's the first step in member engagement, because the minute they have that and they're engaged and a human voice responds within seconds to their problem, you can't get much more closer to member engagement than that, because it's a patient-reported symptom. Second, remote patient monitoring, early detection of deterioration, blood pressure, diabetes. Monitoring their condition, sending that to the practitioners is the next level in terms of this connected care platform. And then medication management, over 50% of patients, the research shows us that they don't adhere to their medications. Quite frankly, I think sometimes they're so overwhelmed with other factors and social determinants of health that medications fall on the bottom of the list. And then AI and predictive analytics. We have so much data that we can analyze. Just within Connect America, and I've only been with Connect America about 10 months now, over 900,000 subscribers with reported conditions. Things they're struggling with, and analyzing that data gives us so much insight. And we're turning that data around, feeding that back to case managers, and that data will help us move the needle forward, because then it'll be data-driven. What are their needs? What are the fall trend rates? What are the button presses? What are the conditions that they're trying to struggle with? And I think as an industry, analyzing that data will help us move the needle forward. So this is a case study, research-driven, based under an IRB. Published, the first publication was in June, the second publication was in July. I learned early in my career that the need didn't justify somebody investing in supporting it financially. The drivers, we all know the drivers, we all know the needs, and then you have a limited amount of dollars that you have to spread across to support this population. So as we look at the impact of technology and care delivery models across the quadruple aim, the triple aim, quality, satisfaction, cost, et cetera. Two of the key drivers, I think, as we look at where we spend our dollars, has to do with utilization, right? And cost reduction. And if we can provide quantifiable data, I use the term we, collective we, then we can move the needle forward in terms of how we're providing care. So this case study focused on those areas of utilization and cost. The study objectives was to evaluate personal emergency response services, reported conditions, and the impact that it had on utilization, and the impact of predictive analytics in terms of identifying a risk for a subscriber of entering an emergency room or an ED visit. There's a lot of work underway in this space. Yesterday we heard about social determinants of health in terms of identifying risk. So it's about using the data to turn it into information so we can identify risk for a subscriber. The study population was 370 adult seniors over the age of 65. The intervention group, there were two groups, an intervention group with personal emergency response and tailored interventions, and a control group that received care as usual. The study timeline was 3 months, followed by 6 months looking at utilization and looking at cost. And the group was pretty much divided across control and the study group. The study interventions, personal emergency response services. So that's where somebody's in their home, they're alone, they press a button, they have the technology, they say, I have a need. And looking at that need and the impact that that has on utilization and cost. The second was a predictive analytics that identified and predicted their risk for emergency department transport. Early identification. If you think about it, we're all drowning in data, and if there's a risk score that could be presented to a case manager, a home care nurse, it gives them an idea of who on a list of 50 that they should look at. And then triage and intervention, and I think triage and intervention is the next area where we need to explore, because that was statistically significant in terms of triage and intervention. So the study results. This is a little unrelated to the study. When I first joined Connect America, I was wondering what are the needs that people have? Why do they press their button? What kinds of help do they need in the home? So here you can see the top 9 reasons that account for almost 92% of all events. So this gives us tremendous insight. The prior panel talked about going to the source of truth, going to the subscriber needs. What do they need? How can we engage them? If I have a fall or chest pain and I press a button and somebody shows up, that plan is providing care in a gap that we currently have. So no surprise, number 1 relates to falls. And number 2 is respiratory-related, pain, GI-related, police, fire, cardiac-related. This gives us insight into the conditions that they are experiencing in their home environment. This data came from over 900,000 subscribers that we have, a wealth of data to mine. And that's where this analysis came from, because if we're going to move forward, data and analysis like this will help us move forward. So, and these are subscriber reported conditions. These are events that are occurring in the home. And for each event, there's probably a plan, an action plan that can be developed around these events. So the top 9 account for 91, almost 92% of all events. Utilization and cost. Think about 2 populations. One population with intervention, personal emergency response, and a case manager, care manager looking at the risk score for transport to the emergency room. So the utilization and cost, there was a 68% decrease in 90-day readmissions, a 53% decrease in 180-day readmissions, a 49% decrease in 180-day EMS encounters, and a 31% decrease in cost. Across the population, statistically significant in terms of the intervention. And I'll say it again, what's the intervention? It's not just technology by itself. It's the personal emergency response. It's the algorithm to say this individual is at risk. Think about a case manager, care manager, or home care nurse that may have 50 patients. That's the second lever. And the third lever that is so critical is taking action upon the data. And you may wonder, what were the interventions that were statistically significant? So just think about it. Somebody falls, somebody has chest pain. Home care visit, consult with their primary care physician. PT, OT, let's call them and see what's going on. So underlying that intervention, those, I think there were 6, maybe 7 interventions that were statistically significant. Common interventions between case manager, care manager, home care nurse that could be implemented to shorten that cycle between getting data and moving into an action plan for the subscriber. So opportunities and challenges as we move forward. Just a hypothesis, and I'm open to feedback from the audience. I think maybe even 5, 10 years ago, it was a technology problem. The technology is moving faster than our ability to integrate it into practice in some respects. It's a care delivery challenge, I think, that we have now. Yesterday, we heard about non-traditional caregivers. When I was a home care nurse, it was the guy in the pizza shop that had a key to the individual's apartment, and we go get their prescriptions. So how do we engage and develop a care delivery model around this? It's a challenge I think we have. There's a national effort underway, funded in part by CMS, to look at emerging care technologies in the home for seniors, and a tremendous focus on what's the care delivery model. Maybe the model of it being a physician and a nurse and a home care nurse, we're beyond that now. We need to engage greater stakeholders into that care delivery model. So that's number 1. Number 2, from a data perspective, exchanging all of this information across the stakeholders is technically feasible. I think it's not a challenge. I think it was a challenge, years ago. Now it's not so much a challenge in terms of using health information exchanges to exchange this data. Right now, we're working on a project where if a subscriber goes to the emergency room, the next of kin, a family member, a case manager is notified that they went to the emergency room and the hospital that they went to, so we can ship that data around. So that's, I'd say, a challenge, or maybe it's more a work in progress. Capturing social determinants of health data is something I think all of us are working on. As I look at the, over 1 million postings from seniors in their home in terms of what they need. As they report things, you get tremendous sources of social determinants of health data. I don't have my meds. My son was supposed to come today, he didn't come. The heat's not working, and so we need to capture those sources of social determinants of health data and analyze them to turn them back into what we can do moving forward. So the value is there. You saw the reduction in ED visits, utilization of care, and I bet you're thinking, if I have to invest in this technology and I have $100, what's the return I'm going to get on that investment? And that's the bottom line question that we're all struggling with. Even 100 years ago, when I was a home care nurse, and I said I couldn't leave this patient, I needed to go back in. What's the return on that investment in terms of you going back in to care for that individual? So, thought about that. I don't want you to think utilization of cost is a total driver, but it drives a lot of decisions. So, I'm going to move forward, and you'll have all this information. It's been peer-reviewed. It's published June and July. So if you think about it, it's not brain surgery. You plug in goals that you want to achieve, right? You want to have a 25% reduction in readmissions, et cetera. You plug in the cost of the technology. And for this research study, it was a $2.2 million savings based on the outcomes. So there is a sense of urgency. I think the technology is giving us a lot of opportunities. Americans with 5 or more chronic conditions make up 12% of the population, but account for 41% of total healthcare spending. Going back to just personal emergency response, the median time that somebody spends incapacitated without some sort of technology solution is 15 hours. If the response is within the first hour, the mortality rate is 12%. Unfortunately, many people spend more than 12 hours and the mortality rate goes up to 45%. So that creates a sense of urgency. And as I said before, we need a new model of care delivery. The tech is there. We need to figure out how we're going to integrate it into our care delivery models, leveraging all stakeholders in care delivery, family, friends, neighbors, and the guy at the pizza shop that has the key to the patient that I used to take care of. So with that, oh, goodness, I'm over for time. We have 4 minutes for questions.
Oh, that was a 10-minute warning. I'm sorry.
Oh, 10 minutes. Okay, we have 10 minutes for questions and welcome feedback.
Does anybody have any questions for Rosemary? No? Okay.
Oh, there is a question
we do
back
have
there.
One. Thank you. Hang on.
Hi. Yeah. At the beginning, you were discussing an elderly population. Is that what it was? I saw the photographs, and you were talking about people prefer to stay at home.
Yeah, 85% of seniors prefer to stay at home, and.
But my question is the data that you showed for engagement also for people who are older, particularly if there are people who are in need of long-term care support?
Yeah, the population is those age 65 and older. So that's the whole database for the study, individuals 65 and older. The majority of individuals were between the ages of 75 and 89 in this study. More than happy to share the study with you.
Hi, a great presentation. Just a quick question on the types of devices, particularly in elderly individuals. You know, I've seen like things that are around the neck, but wondering if it's watches or phones, and just kind of the education used to lead to better adoption. So just wondering a little bit more about the technology that was used behind the study.
From a technology perspective, we can't have education, right? Who can absorb education? So it's a matter of a box in your home that is either through your landline, you know, that they just press a button. And the challenge we have is that, you know, family members, everybody presses that button. It's very easy. I spent about 8 years in human factor testing with body-worn sensors, and it's challenging. It can't be that complicated. Think about it. You fell, you have chest pain, you just need to be able to press a button, and you need to have two-way communication, right? Somebody talking to you. My mother had a device, and she said this voice came out of nowhere. I was so scared I fell, and a voice came out of nowhere and said, "What's going on?" That's the second thing. It can't require wireless, it can't require technology about what phone service you have, etc. And the third thing is a human voice needs to respond within 30 seconds. So we monitor that closely to say, I am here, what's wrong? So think about it. You fall, I don't know, I just thought about it a couple months ago. I had food poisoning, and I said, could somebody come help me? That human voice that can respond, that's trained. And then from that, in terms of the call center and that human voice, it can go multiple paths. Maybe it's EMS, maybe it's a son and daughter. It can go multiple avenues for reach out. So that's important. And what's even more important is somebody following up to say, what happened? Did EMS take you to the emergency room? And 42% of some of the urgent situations are resolved on site. That's cost reduction. You avoid an ED visit, you avoid an inpatient utilization, they resolved it on site, whether it's EMS or a family member. And I think that's member engagement, right? You know, you get phone calls. I guess because I'm a nurse, I get all these phone calls saying, somebody showed up, they took care of it, I was okay. So that's cost and utilization. Did I answer your question? And just real quick, in terms of digital technology, if that individual ended up in an emergency room, the emergency contact would get notified that your mother or father was sent to an emergency room. This is the emergency room they're in. They're okay. And the case manager would get that same notification. So it's a whole closed loop process that's far cheaper than ending up in the emergency room.
Rosemary, great presentation. Question about the graph of the number one reason for using the product button, you know, the fall, right? Is there bias, and how do you remove bias from that? So if we're selling this product to them so that in case you fall, hit this button and we'll be responding to you, more people are buying that product for falls, therefore the number one reason will be falls. But somebody who's lonely and wants to push the button because they want to talk to somebody, that may not be on that list because it wasn't on the list, I was looking for it. How do you account for those kind of biases or for those kind of things?
It starts out with press the button, whatever you need. And we get everything from I'm lonely, you know, to could someone, I saw one bring me a 6-pack. So in analyzing the data, it is what it is. It's the population. And a 6-pack may mean I'm really lonely, I want someone to talk to. As I spent time in the call centers, There are frequent flyers that call because they're lonely. And what we're doing currently is expanding the social factors as we're becoming more aware of the individual needs of patients. So when I went to the call center, they'd say, oh, that's Joe. He calls every Sunday night around 9 o'clock. And then they said he didn't call this past Sunday at 9, and we found that he passed. So when I talked about the opportunities and challenges, we have 9 data fields that the operators will collect. But every call, as every call comes from the subscriber, they're all treated in the same way. Whether they need a conversation, Joe needs a conversation, or somebody needs EMS, they're all treated the same way. They're all in the database. I don't know why they're not in the top 9. Maybe it's because how we're structuring the data, but they do get the calls, so. Every call is treated the same way. My mother had it, and she would call just to talk to somebody. She'd say, oh, they're so nice, I just had a conversation, so. Okay.
I might be the guy calling for the six-pack. Thank you, Rosemary. Next up, we've got a session, one more session right before our luncheon, and the title of the session is Harnessing Data to Drive Member Engagement Through Better Targeted Digital Outreach, Telehealth, and Text Messaging Technology. And with us, we have Carlene Haynes, MPS Chief of Community Relations with Partners Health Plan. Carlene is a nonprofit executive with 23 years of experience in the field of human services. Prior to joining PHP in December of 2014, she was Director of Vocational and Employment Services at a large nonprofit serving individuals with intellectual and developmental disabilities, supporting over 500 adults through programs such as day habilitation, supported employment, and pre-vocational. She was instrumental in developing and growing affirming business models that support gainful work for adults with disabilities. Carlene's participated in the Education and Workforce Development Committee for various disability advocacy groups, served as a diversity in the workplace facilitator, and worked as an adjunct facility at Nassau Community College teaching IDD study courses. So please join me in welcoming Carlene. Thank you, Carlene.
Thank you. Hi, I feel I'm challenged in my height, so can you see me? Okay, that was my fear, but I do have heels on, so there you go. So thank you for being with us today. I'm excited. So I'm going to focus on, that's a very long title, to just talk about member engagement. And the plan that I'm with, and my history, as the gentleman just shared, is with special needs. So that's really what I'm going to focus on, special needs and engagement, member engagement. So the topics today, again, the use of technology, how we talk to how our care managers are aware of what's going on with our members, their health status, of course, engagement with members to get their feedback, utilizing social media, newsletters, virtual interactive education sessions, and other virtual events. So those are some of the things we're going to be talking about. But I wanted to give you an overview first of Partners Health Plan. It is a FIDA IDD, which is a fully integrated duals advantage. So it's a duals plan for Medicaid and Medicare members. And it's unique in that CMS gave us the go-ahead a couple years back to go live, that it has that IDD distinction. So every member has a developmental disability. And we cover our members for everything. So vision, dental, medical, pharmacy, everything, anything Medicaid and Medicare related. We also cover them for their HCBS waiver services. So their rehabilitation, if they live in a group home, if they have supported employment job coaching, these types of things, we cover all of that as well. Any self-direction budgets, things like that. And the uniqueness of this, of course, is the intensive care management that comes along with that, and writing of life plans and or AKA care plans from a care management perspective for these special members. So who we serve, I think it's important to kind of see the makeup of who the folks are. And these are adults over age 21. In other words, for them to enroll in our plan, they need to meet these categories. They have active Medicaid and Medicare. They're eligible for, like we said, the intellectual and developmental disabilities waiver services. And we cover right now, as the FIDA demonstration, the most populous area of New York State, which is Brooklyn, Bronx, Queens, Manhattan, Staten Island, Long Island, and the Lower Hudson Valley. So 9 counties, very large group of folks there. So the other thing that's important to note is our makeup, our sort of member mix. And as a health plan, you need to kind of look at your member mix. We do get a PMPM, so a per member per month. So looking at our mix is very important, and we'll talk about, of course, keeping folks healthy. But the bulk of our members are over the age of 50, but only about 35% of them live in the community. And what that means is they live on their own, or they live with mom, dad, sister, someone like that family, or roommates. And then the others live in what we call congregate or certified settings, right? So group homes or high-need facilities. And then the location is, again, most of those folks are living in the New York City 5-borough region, and then the rest are in the outer suburb metro area. I thought that's important, again, to kind of see as I go through, who we're supporting. So think about, and I'm thinking of what Dr. Kennedy just talked about in regard to, connecting with, elderly folks and keeping them connected with their care managers and healthy. Most of our members do not read. Most of our members they're not their own proxy. They cannot read materials that are coming to the house. I know, think about your health plan, you probably get mail. This is not a bill, right? And you get all these sort of pieces of mail. They're not reading those things, most of our folks. The point is, they need a caregiver or someone, bless you, in their life to provide them with that support. And so the thought is, how do we use technology to get to these folks? Do they have computers at home? Do they have smart devices? If the mean, or most of our members are in, let's say, 60 plus, and some of them live with moms and dads, those folks are 80 plus, right? So how tech savvy are some of these folks, and how do we get to them? What's the way that we use to support? So it's important to note that that plus the COVID-19 pandemic, it really hindered our ability for face-to-face meetings. And as we know, we talked in other presentations about staffing shortages and things like that. So the ability to have care managers go in and check in on folks was pretty tough. So just using the public health emergency, I just thought this snippet here was great to sort of put in perspective the IDD population during the pandemic. A study across 547 U.S. healthcare organizations finds that IDD individuals are substantially increased risk of dying from COVID-19. And so to add to that, disability or ID was the strongest independent risk factor for presenting with a COVID-19 diagnosis and the strongest independent risk factor for, other than age, for COVID-19 mortality. So it put us in a very unique position because all of our plan members are in this category. Most of them are over 50 years old. Most of our living, I showed you, in a congregate setting, which means what? They've got staff who are coming in and out in rotation. They have a roommate or housemates. And at the time, New York was in a very odd state where, you had We had Governor Cuomo at the time, so there was things coming sort of in and out of, okay, caregivers cannot go in to visit their loved one because of the pandemic. Masks are mandatory, now they're not. Vaccines are not mandatory for caregivers or DSP workers in the group homes, now they are. So there's a lot of fluctuation in what was going on, and of course, true concern on our part on the health of our members. So, just again, we looked at, we've over 60% of our members over 50, most of those living in congregate settings, and people coming in and out. I'm kind of talking ahead of my slides, but, and so we really needed to look at what our strategies were going to be. So one of the things we did was we did a lot of mailing, because there's some of our population, they like to have a piece of mail in their hand, meaning the parents. They're not, some of them not pro-technology, and so they like to have mailers, that type of thing, so we did that. We, put a lot of emphasis on vaccination, so we partnered with community-based organizations to provide pop-up vaccine clinics. And during those pop-up vaccine clinics, we probably did 3 or 4 per region, in the Bronx and Queens, and did that all over, specifically for our members themselves and their caregivers and staff. And it was extremely successful. And what we saw is at the beginning, as you see, this is a crazy looking slide, but it basically is showing that orange piece is, and those orange bars are folks who have completed their vaccine. And you can see we start back in the start 2020, early, all the way to now. And when you see the orange start to go up, it was basically right after our pop-up vaccine clinics. So we kind of took it into our own hands and said, we've got to get this information out there. We're going to tweet, we're going to use social media, we're going to, as much as we can. Facebook, and we did a lot of trending, but we found that Facebook for the IDD population is used more than Twitter or Instagram or some of the others. And so we every day we would sort of put something out there utilizing Facebook, knowing that these family groups, advocacy groups, self-advocates, those kinds of things, lots of activity on Facebook, so we would utilize that to, to advertise, come join us at this vaccine clinic. And so we saw the numbers kind of go up. And that, just showing that to say that there was a direct correlation in success with getting our members vaccinated. And overall, to date, at least 92% of our membership have started the vaccination process. So technology, how do we use it, and how do we support our members in general? As members of the FIDA IDD plan, they do get a 2-person care team. So they have a care manager who's at least a bachelor's level, and trained in the special needs space. And then they also get a clinical team leader who is either a social worker or a nurse, so a licensed clinical person to support them directly on the caseload. We do, in the Northeast, use the Rio alerts. So we have an electronic health record system. We're actually using Medicaid. We utilize that system, and that is the sort of the Bible, if you will, the tool that our care managers are using daily. It's a moving, live file, if you will, of what's going on with the member. So if I'm the care manager, I know if my member hit the ER, right, because the alert is coming in. I could say, I'm really worried about Johnny because he's had some issues with his MH, he's got a dual diagnosis, he's got mental health issues, and I asked to run claims data, and I see that he has not filled his medication. So he hasn't been to pharmacy to fill his meds. Danger, right? Something might go wrong. So what do I need to do as a care manager to either visit Johnny or call him up or FaceTime him or do what we need to do to reach him? So that's some use there, of course, of the claims data. The other piece is internal conversations, making sure that our chief medical officer, our nurses, our care managers, even finance, everybody, member relations, everybody's talking to one another to make sure that, there's a great level of communication and that care managers feel supported. Prior to the pandemic, we started a telemedicine program, telehealth, utilizing a company called Station MD. And this was huge from a tech perspective. We have, at this point, since we kicked that off, 89% of the telehealth visits have resulted in a member not having to go to the ED. In other words, being treated in place. And this was either at their group home setting or with mom and dad, wherever it is that they may live. So this particular vendor, Station MD, can do this either by landline phone, because not everybody has a smartphone, right? Landline phone, smartphone, and laptops and things like that. For the group homes that we partnered with, the IDD nonprofits, they could purchase almost like a mini kiosk that had a laptop, that had blood pressure cuff, and different types of tech to use within this kiosk that they could use for any member in that house to and have a doctor see them and talk to them directly. All the doctors through this particular vendor are trained in, again, special needs, and the wonderful thing is that it integrates with our EHR. So for our members, if you call and use telemedicine, you activate that process, the doctor who's answering the call on our member can go into our electronic health record, and they don't have to ask these questions. For example, okay, 70-year-old female, diabetes, that type of thing. They can read it right there because they're connecting to the EHR. So really, that's why the percentage of success is so high, at 89%, because we haven't had folks need to go to the ER. The other piece of that, and again, I am just shouting out a lot of statistics, but at this point, from the stats that we see, that a person with a developmental disability is almost 4 times more likely to be admitted than you or I when we go into the ER, because because they don't speak, they can't talk about what they feel, and if there's not an advocate there to sort of to speak for them, they're a lot of times admitted for unnecessary reasons. As the payer, that's not great for us, right? So not great for them. And think about it: a person with an IDD, we're talking folks, for example, with autism. If I am autistic and I'm in a strange place, and then I have to move to another bed, and I've got strange nurses and people coming in and out, I might have behaviors, I might self-injure. So it's not great for our members, for their well-being, and again, it's unnecessary. Having unnecessary tests run, these things like that. So telemedicine, from a tech perspective, has been tremendous. We do have a text message reminder program, and I'm thinking about the panel presentation with the gentleman from Baby Scripts who was talking, in that group we're talking about, like, sometimes don't talk to me, don't bother me, stop sending me text. So we did have a text messaging program where folks could opt in, and it could be for the member themselves or for their caregiver or both. And we used GoMo Health for that. And we did a pilot for our members just with diabetes and/or high blood pressure. And it was, again, very successful, so we're looking to expand that as well. And it would do, and the great thing, and I've met a few folks from the vendors that are here who do some similar things, where you could just, if you like puppies and you say puppies are your favorite, every morning you get a sort of a little picture of a puppy that comes up. So again, feel-good things, holistic approach to caring for our members. Things like remember to take your medication, check your blood pressure today, et cetera. So lots of connection there, so utilizing text messaging services. We also have a 24/7 nurse advice hotline, which is a phone call, and of course, similar to what Dr. Kennedy presented, wearables. Unfortunately, at this time, We don't have a lot of usage, although we offer the wearables, sort of life alert, quote unquote, type of things. I think because, again, 60% or more of our members live in a certified setting, in a congregate setting. So they have staff with them kind of 24/7, and they didn't sort of see the need for that. But we do offer it and have several of our members taking part in that. So care managers did virtual interdisciplinary team meetings if need be. We do also go into the home if need be, but we're, again, looking at ways to develop. At this time, we're looking into in-home tablets and other adaptive tech, video, audio capabilities, things like that, smart homes, smart home settings, so that we can ensure, because again, I'm piggybacking on something Dr. Kennedy said, but just like the senior population, there's many individuals with developmental disabilities who are in their 20s and 30s who they want to live on their own, and why shouldn't they be able to? And so having that smart tech within their home environment is very helpful for them to maintain their independence. So staying connected, we talked about technology, but staying connected as a health plan, I think about myself sometimes as a health plan. I only use it when I need it, right? I have my card in my wallet when I'm taking my son to an appointment, or I use the card. I don't necessarily go on the website for my health insurance coverage that much. But for this, again, we've taken the health plan in your life sort of to the next level as much as we can to create a sense of community. Because this is a very special population, there is already a sense of community, parents speaking to parents, folks leaning on one another, that type of thing. So we have an advisory council. I'm sure most plans have that or must have that, where you have stakeholders serving on your advisory committee. So we make sure that we have parents. Our board actually is 50% made of family members or someone who's connected to a person with a disability. And town hall meetings, at least 3 per year. With pandemic, it's been monthly, actually. So making sure that we hear from our stakeholders, focus groups. So whatever topic they may want to hear about, whether it's should I get my son vaccinated, or I need to learn more about education opportunities or housing, that type of thing. We have email subscriber lists, newsletters, informational blasts, these types of things, and we've used social media and our website a lot. And we've found in the 2 years since the pandemic, or is it more, guys? I can't remember. But in that time frame, we've really helped families who felt super uncomfortable, and we actually did trainings with our care managers right during the start of the pandemic and helped the care managers who were going inside the home to do a little bit of tech training with families and linking them, families who did not have any connection. So getting the Medicaid phones, Obama phones, making sure, seeing if we can get local grants to get laptops in the homes, things like that, because this might be lasting a while, Mom, and we want to make sure that we have a way to get in touch with you. Your care manager can do virtual visits. You have a camera on the laptop, things like that. So a lot of connection there, and making sure, care managers who, again, might have a nursing background to say, I don't know much about tech, but I can try and be a trainer on that, because, we didn't want extra people going in the home. You didn't want that either, right, during the pandemic. Only people who were necessary. So very important with that. The other piece, and staying connected to our membership, was education. Anything that the advisory boards or stakeholders said they needed to hear more about, whether it was benefits and entitlement, how do I fill out this Medicaid application again, these types of things. So making sure that they had access, their care managers could support them, but we would do virtual education sessions on everything, emotional wellness during the holiday season, things like that, and also sessions just for caregivers. Because the pandemic was very tough. And what we found, at least in New York, is that a lot of because of the shortage of staffing for DSPs in some of the group homes, some of the group homes had to consolidate, which was tough. And families were nervous about what would happen to their loved one with staff coming in and out, so they took their family member back home. And so let's say their loved one had been living in a group home for 15 years, right? And they themselves have now aged, and now my son's back in the house with me after 15 years. And this pandemic, how long is it? They're thinking it's going to be a couple months, and here it is. It's a year and a half later, and I'm burnt out. That type of thing. I'm 80. I don't know if I can do this. Help me. So, lots of really putting the support on how do we ensure that there's self-care there for caregivers. We did some recreational events, holistic events. We did a lot of virtual, what we called PAL program or PAL meetups. We did chair yoga, painting classes. We had individuals with developmental disabilities actually be the teachers. So we would ask them, well, what do you like to do, Michael? Oh, I love to paint. Okay, so you're going to be our teacher. Next Tuesday, we're going to have this class. We're going to advertise it out, put it out on social, and you're going to be, use your camera to teach the class. So lots of connections and all this goes back to the activities and all of this. Again, creating a sense of community so that our members and our families know that if they need something, if they don't feel well, if they're confused, if they need to connect with their provider or their doctor, that they know exactly who to reach out to. There's a high level of member satisfaction, a very low turnover rate by way of member retention. We have our member disenrollment, voluntary disenrollment is around 2%. So it's meaning they come to us and stay. And even though in New York this is a very most people with disabilities in the IDD space in New York are served by a fee-for-service model and in health homes. So this is unique, and the members that we have, like I said, fortunately, we show statistics that folks enroll in our plan and then stay. And then advocacy. In a lot of things that we've heard over the last 2 days, I think advocacy is a big deal. For folks with developmental disabilities, we found things, and I was speaking to someone last night that I met about, let's say, HEDIS measures. And currently, the HEDIS measure, I believe, for breast health is 1 mammogram for females over 50. I think it's somewhere between 50 and 79. 1 mammogram in the last 2 years. So it's a sort of simple language that NCQA has. And for us, we actually scored pretty low in, I think it was 2019, for that measure. And we were like, what? We know that we're running statistics through our EHR. We know we're showing 98% of compliance with breast health. But HEDIS, basically, if we have a person who's quadriplegic or is bedbound, how are they having a mammogram? For the men in the room, you may not understand, but for the females, you get it. It's a tough thing to go through, autism, things like that, or if you physically can't. But our folks were getting sonograms or physical exams. So they were still getting their breast health looked after. It's just it didn't meet that measure. And so advocacy with government to say, your measure is kind of discriminatory, doesn't really match this population. You need to kind of look at that again. The other thing is in large New York health systems like New York Presbyterian, LIJ, Montefiore, these types of big hospital systems, where we would find the length of stay, inpatient stay for our members was on average 4 days, whereas for others it was only 1 or 2 for the same exact issue. So, and then we would see, for example, folks going into a step down, like a rehab, before being able to go home, simply because they had a developmental disability. So again, utilizing our technology, looking at our claims, looking at our trends, making sure that we're advocating for our members, whether it's the hospital system or with government, because this is the FIDA demonstration, which is exactly what government wants us to do, is to kind of take a look at it. So I know, clearly I'm a geek for this information and for advocating for the special needs population. So I might have gone a little bit long. So I don't know, Pam. No? Okay.
Good.
So I really do urge you to check us out on our social, and of course you're welcome to email me. My email is here. And like I said, we really truly feel that with this special needs population, which could transfer to seniors or others, really trying to see the health plan also as a community has been very successful.
Carlene, we do have a question.
Okay.
Hi, thank you for your presentation. I wrote down that you called it the moving live file for your care managers. Will you tell us again what that is, who the vendor is?
Yeah, sure. It's Medicaid. I think I see Doug. There you are. Doug's over there. She didn't see you, Doug. Raise again. Okay. So it's Medicaid, and the platform is called Medicaid Coordinate. And they have several, so you'd have to ask Doug about that. Clearly, I'm a psych person, not a psych background and not an IT. But the great thing about it is the ability for that, the care manager to either with the Chromebook or even on the phone or with their laptop to really see this live file that has all of the information in it. So, for example, if the care manager talks to the mom on the phone, there's a note function. So, spoke to mom Monday, 7 p.m. She's worried about, saying that Michael's not feeling well. I advised her to call the nurse hotline, or this particular issue is coming up, that type of thing. And that's important because you want this record of information. We also can upload scripts. The Rio information alerts are coming in there. That particular system also gives us with health profiles, medical profiles, because we pay for home care, so PCA level 1, PCA level 2 nursing care. We also have care managers and nurses who are doing assessments similar to UAS, right, to determine the number of hours that the member's going to need in nursing care in the home. So all that information is in there too. So because we're providing authorizations, we're authorizing everything, MRIs, home care, job coaching, everything. Because we're the authorizer and the payer source, we need that file to be super tight, all the information to be in there, not just for best practice and to ensure that the member gets the best care, but that we have a history.
Carlene, excellent presentation. I'm equally intrigued in terms of this live file that the care managers have access to. What information do they need that they may not currently have? Like, even though they have to go to different sources to get it, where are the gaps in information?
Well, I think, with data and a platform, it's, it's junk in, junk out, right? So if the care manager or the care management team in some way is not vigilant, ensuring that we've filled the gaps, I think an important way to do that is we have minimum monthly check-ins. Even if they don't want to hear from us, they're going to. And then 6-month meetings. And so that's a way to update. I know Sister's your proxy. Sister, what's your phone number? This is the phone number that we've got, these types of things, right? And because we're the payer source, we have access to the claims data, we know how many times that you've hit the ED, that type of thing. So the care manager's going into the life plan meeting every 6 months with all of that information at their fingertips. We see that that Mike was in the ER 3 times in March. Last month, we see that he was admitted for, we even know the reason for the admission. What was going on there? What do we need to do different? That type of thing. And the flexibilities of, let's say, durable medical equipment. One of our main issues is, let's say, folks with autism, they have a hearing aid, but they have a behavior, and then they break the hearing aid. What do we need to do to make sure that that person has what they need, and not just get them a new hearing aid? Right? Proactive, holistic, going backwards and saying, well, in the end, we found out that he just doesn't like his roommate. And so when he acts out, he's breaking his hearing aid. So it's not about the hearing aid or the fact that he can't hear. It's about his roommate and his living situation. So what do we need to do and go back? And that's, again, the file, that living file, and that data helps us to provide the best level of care to the member from that technology perspective. Yeah.
Okay. Thank you so much, Carleen.
Excellent, thank you.
Okay, well, we do have some great stuff this afternoon if you're able to stay. We have 2 in-person presenters, and we do have 3 recordings. I kind of shifted them to the back because I wanted to give the in-person presenters the highest priority. So if you can, if your flight situation allows you to stay, we hope you do. Lunch is going to be inside today because it was a little hot, and I didn't want to melt you guys. So. So we're still going to go up the escalator and down the escalator, but then we're going to go straight and walk a ways because, you haven't gotten many steps today sitting here. And Conway is on your left-hand side, and they will be waiting for us. It's a pesto pasta with chicken, and we are going to start. We're going to give it exactly an hour, so 1:35, and we're just going to keep rolling. Evaluation forms on your table. If you wouldn't mind filling those out, we're always looking to improve. Appreciate your feedback, good, bad, ugly. And just leave it on the table or out on the registration desk. And I'm going to have some sodas in the back of the room for anybody who stays for the afternoon because we don't have a formal break, but just to keep us all awake. Okay, enjoy lunch, and hopefully we'll see you later. And if I don't, safe travels home. I know crazy weather, and be careful.
Was there a lot of pause between what? No. Okay, but. All right, she could have just hung up. Maybe not. There's nothing you can do. I mean, you weren't directing it towards her. You didn't, right? So I think you'll be fine. Sure. Well, I wouldn't be upset unless it hasn't a reaction to it. Kind of like you got caught what? Oh. Oh. Okay. Oh, shit. Yeah, that's quite a few things. I mean, if I got that, I wouldn't go to the, like, I wouldn't, I don't, yeah. Okay. I mean, nothing you can do. I mean, you can hope she never listens to her voicemail. Maybe send her an email instead and just say, you can delete my voicemail. Yeah, but if I would do that. Why don't you do that? Send her an email. Because I wouldn't listen. Say everything's in here, you can just delete my voicemail. Why? Yeah, say all this is on the voicemail. Yeah, but you want her to know that she doesn't need to listen to the voicemail. Say, hey, I left your voicemail, but I'll figure it out. Just put it all here instead. Okay? All right, and then maybe she won't listen to it. If she doesn't think she has to, most people won't.
doing? Good, how are you? Good. So, I know it's a tough spot right after lunch, you know? I promise you, I remember people that I put in tough spots, and next time I put them in better spots. So if you do work with us again, I'll remember. No worries. But yeah, and you were part of the panel, and then the panel. It's been an interesting ride this year, but I think people
actually showed up.
I know, I'm thrilled, honestly, when I saw the weather. I'm like, really? We're going to add weather into this now? So I told them 135. It'll probably be 140 by the time people start filtering.
And then, and if I went till 2:10,
Yeah.
it's okay.
It's fine. Yep, because the recordings aren't going to be a full half hour. The lady after you, Cynthia, I swear she always ends up, I say I remember people, but I think because she's a hospital, not a health plan, and she talks about opioids, like she always ends up toward the end, and I don't mean to do it to her, but she's so nice, and she's one of those people, she's happy if she's talking to 5 people if they're interested, you know, she's just such a great lady. Okay, so this is right to go forward, left to go back, and your pointer.
And then we can just check some people there.
Yep.
If you don't mind.
Not at
Yeah,
all.
I'm good. Don't worry about me. Yes.
last live speakers of the day. So we'll show up and see that. I've just been kind of whittling down some bios in terms of introductions. Anything you want me to hit on specifically?
Whatever you can. We don't have to.
Make sure we give everybody a fair shot.
Oh, yeah, she said it would be like 1:40.
Yeah. I just saw I just passed her on the hall going down there. So, yeah. So where's home for you?
New Jersey.
Okay. Where in New Jersey?
What do you know?
Well, I lived in West Hartford, and I used to travel up and down there. So, I mean, primarily going to hospitals like Robert Wood Johnson and Hackensack and that area.
Leonard Medical? Probably not.
Where are you?
Hunterdon County.
Okay.
So,
Where is it? That's down?
it's a little further, so if you went to like Morristown,
Yeah.
it would be probably about 45 minutes
Was
west.
it St. Martha's that's at the Royal Hospital down there?
I think some of them, St. Barnabas, and I mean, Rattle we have a lot too.
Yeah.
But yeah,
I've
that's more
lost
like-
track after
Yeah.
years. So.
Yeah, we're like 45 minutes from Morristown.
Okay.
West. That's south.
I had an employee that used to live in like Forkin River.
Yep, yeah, that's on the east.
Okay. Okay. Yeah. And then I had a chance to go down to Delaware at one point. I was like, wow, South Jersey looks like Ohio. It's like cornfields
Very
and
rural.
flat. It's
Yeah.
like, this is pretty. You know?
Yeah, parts
Very
of it.
different from
Yeah.
the north part.
Yes, yes, I live in a very rural area.
Okay.
Yeah, it is different. But I used to live in Jersey City.
Okay.
Very diametrically
Looking out
opposed.
at, yeah, then you're just looking out at New York and,
Yeah,
yeah. Path train?
Path train,
Yeah.
Used to live in West Hartford.
West Hartford, Connecticut, yeah, for about 4 years.
Yeah, we go there a lot. We used to go there a lot for clients.
Yeah, I've lost track of all that, but we've been in Tennessee now for 13 years, so, yeah. Distance. My youngest doesn't remember being, born and living in Connecticut, 15 months when we moved.
Connecticut's nice.
Yeah, I mean, it's okay. We're no long-term solution, of course. But they did a bunch of, coming down to West Hartford, like Lubeck Square and all that sort of stuff. So it was
Yeah,
nice.
that's cute if you, especially in the summer, walk around or something. You see lots of military in Hartford area, so.
Who's up there? Oh, well, of course, like downtown is insurance capital, right?
Yeah.
So. Is United's a big building downtown Hartford?
Which one?
United.
Oh, yeah, they do have one in Hartford, yeah.
And Aetna's Castle, that's off of 84 or whatever.
Big campus.
Yeah.
Yeah.
And Cigna's on
Bloomfield,
Bloomfield.
yeah.
Of course, the Travelers Building. Yeah.
Wow. Hasn't changed that much.
And then there's, the Connecticut portion of Emblem is out in Farmington, Avon area.
I'm not sure about that one. I'm not really good.
Yeah. It's
they can hear you. I think this one's on.
Hello? Oh, wait, I got it.
There you
Okay,
go.
good news. Well, we're in the home stretch, gang. We are in the home stretch, my friends. So appreciate everybody being back from lunch at a mostly appropriate time. Pam's corralling people. So we're going to kick off the afternoon with our next session, Impacts of Telemedicine Expansion and COVID-19 in Behavioral Health. And Karen Weintraub, who's our Executive Vice President from Healthcare Fraud Shield, is going to give our first session. Karen is EVP at Healthcare Fraud Shield, easy for me to say after lunch. Ms. Weintraub is responsible for the design and development of the company's healthcare fraud detection software, products, and services. She provides subject matter expertise on system design and workflow, business rule development, data mining, and fraud outlier algorithms, as well as SIU policies and procedures. Prior to joining Healthcare Fraud Shield, Ms. Weintraub was the Senior Manager of SIU Services at GDIT and the Supervisor of Investigations for HealthNet Incorporated. Everybody remember that health plan? And manage all the Northeast healthcare investigations for all commercial, Medicaid, Medicare business, and claims of fraudulent activity. So without further ado, I'll let you take it over.
Safe travels to you.
Same to you. Thank you.
Well, give yourselves a round of applause for still being here. For you, not for me. We're all braving the sun. I have to go back to New Jersey, literally right after here, so I'm going to go back to some cold weather. So I don't really mind that I was here, but I know he said after lunch, people are, travel schedules, flights are canceled, so just happy that there's some people here. It's nice to get to know sometimes who is actually speaking in front of you, so he did a very nice job of talking about kind of some of my professional career. So I'm going to fill in some of the gaps. I actually grew up in Long Island, and he aptly pointed out that my Long Island accent is not very strong. It wasn't purposeful, not that I'm not grateful, I just don't know why. So I grew up on Long Island. I went to school in Delaware, and I got a master's in criminal justice, and I just kind of always enjoyed just the field of trying to find the bad guys. On the side, when we're not all working so hard, I like to play with my pets. You can see I've got a couple of birds and some dogs. They're my pride and joy, although that big Bernese Mountain Dog, I could have totally taken that dog home. I just wanted to lay down next to him on the floor and used him as a pillow. I also sing in a cover band on the side for fun. And I do love what I do. I love fraud. I'm going to give a little fraud story in a little bit. And when I need to wind down, for those of you who are familiar with the East Coast, I go up to the Adirondacks in upstate New York, just a beautiful, nice, relaxing place to be. And that is an actual picture from the deck of where I go. We have a little cabin up there. So that's a little bit about me. My company, I'm not going to go too much into this. You can read this on your own, but we've been around for a while. We are a fraud, waste, and abuse software solution. We offer all different kinds of things that to do with if you're working for an MCO, your claims data. We also incorporate some external data as well. We run analytics, both rules-based as well as AI, and it's kind of fun to, again, use data to capture fraud, waste, and abuse, and to do things that are, I think, positive for this industry. So a little bit of a story. When I was working at HealthNet on the East Coast, when it still existed, we did have Medicaid business, and people always say, why do you do what you do? And when you think about the fraud, waste, and abuse units, a lot of times people just think that, well, we're just trying to save money, recoup money, save money, but it really is more to it than that. And I remember, and I'll give the Medicaid specific story, I have a ton of fraud stories, but there was one provider in particular, it was a dermatologist in New Jersey, in a county where he was one of 2 participating dermatologists. So for Medicaid, we had to make sure we had enough participating, particularly dermatologists. They were hard to come by, so they didn't want me to piss him off. But this man was not a good man. So I was pretty tenacious, and I was much younger at the time, and I audited his office, I interviewed his staff, I talked to members, I got medical records. And what this person was doing was basically convincing people that they had cancer, skin cancer, making them get additional tests, removing skin that didn't need to be removed, and it was just terrible. So I made sure everybody was on board, bless you, and we not only finally got approval to kick him out of our network, we got our money back. But it wasn't enough for him. He was really, really mad. He was so mad that he lied to our patients and told him that we technically didn't terminate his contract. We non-renewed it. We waited till it was ready for renewal. So that saves you some headaches sometimes with contracts. So we non-renewed it. He told everybody that we kicked him out, but not just we, HealthNet. He said Karen Weintraub at HealthNet is the one responsible for me being kicked out of the network, and I can't see you today, even though he was supposed to see them for an additional 60 days after the non-renewal. I can't see you today. Here's her number, and you need to call her. So for 6 months, 4, 5, 6 patients a day, that he would actually make appointments to have them come to the office to purposely tell them that he couldn't see them, and my phone would ring with patients calling every single day. So I don't regret it because we were able to at least get him out of the network. What I do regret is that we couldn't do more because back then, people were not as aggressive in going after those that are doing bad things. Nowadays, and it doesn't happen all the time, we've been involved with folks that not only do recoup a lot of money, which we did recoup from this provider, but some of them are actually going to prison for healthcare fraud, and some of them really deserve it. So just my little story into Medicaid. So we're going to talk a little bit about telemedicine and how it relates to COVID and behavioral health, and I might sprinkle in some other things, but just real quick, the terminology, sometimes it's used interchangeably, but there is actually a difference between telemedicine and telehealth. Telemedicine is the actual kind of care that the provider's giving, and telehealth is kind of a broader, the bigger parent word for telemedicine, and it's just more about the electronics and not just the actual care. So just something to keep in mind. So why is it important to talk about telehealth and COVID-19? And I'm sure by this point we're all tired of talking about COVID-19, but it's still an issue as we all know, still happening. But there really was an increased need for people to have access to mental health services, especially during the time, again, although it varied by state, but people that were stuck at home, there's a lot of additional depression. There's just a lot of things. Not able to go to work. Some people, lost their jobs. So having access to the care via telemedicine was really key. Of course, that also opens it up to fraud, waste, and abuse, which if anyone is involved in those or areas or work with people that investigate fraud in your companies, then you'll know that it's been pretty prevalent. We also saw that it reduced cancellations of appointments, reduced no-shows, so there really was a value in offering additional telemedicine services. We're going to get into some of the coding pieces of it and the services that people actually billed for in a little bit, because not everything was allowed to be done via telemedicine prior to COVID-19. But there were some things to consider. So those who are having, maybe psychotherapy sessions and needed one and then didn't have it before, trying to develop a personal relationship with your therapist can be a little bit more challenging for some. Trying to have a location that you could actually do things on the computer without other people listening in, feeling you have a safe space. So there are pros and there are cons. So just something to, keep in mind. If you're not watching the OIG or the Office of Inspector General work plan, they keep updating and putting out things out there regarding COVID-19 and behavioral health. So here's just an example, the one highlighted, 3 from the bottom. Just keep that one in mind and keep an eye on it for what their results are as they keep monitoring this topic. So how do we, from a fraud, waste, and abuse perspective, how do we look at things to help identify potential fraud, waste, and abuse? So we have to look at the data. I mean, you might have some phone calls or hotline calls. You might hear things from your members, so you might have that, but you really got to look at your claims data. And if you're not into the kind of the nitty-gritty of what goes into claims data, and I don't know if anyone is familiar with code, so I'm going to give you a couple of granular details as it comes to claims data. But there are things such as modifiers. Modifier 95 has actually been around for a while. It's being used for telemedicine. But when we talk about what services are allowed to be done via telemedicine now that were not allowed to be done before due to the public health emergency. If you have any analytics around modifier 95, you could actually be producing false negatives. So it used to be service A could only be billed with a modifier 95 and service B couldn't. Well, now maybe service B can as part of the public health emergency. So modifier 95 analytics can be a little off if you haven't adjusted it. You have a number of other modifiers, depending on what your plans allow to pay, GT, GQ, G0, and just for fun, they came out with a brand new modifier, modifier 93, that isn't even in the coding books and won't be published until January 1st, 2023, but is effective now. So a lot of people aren't even aware that modifier 93 exists, it's brand new. And this one represents synchronous, or what's known as real-time telemedicine services through either the phone or some kind of audio communication. And they can only bill modifier 93 if it's the same type of service that could have been done in person. So you're going to probably see a lot more billing under this new modifier. But again, it kind of quietly came out, and it's not even in the books yet. So how they can do that and make it effective, I'm not really sure, but they did. A couple of other things. Place of service. So CMS has a lot of policies out there related to COVID and billing for services done in the home with place of service too. I didn't put it on here when I started to do these. Some other information came about, and I just didn't get a chance to put it on here, but there actually is another brand new place of service 10. So there are now 2 places of service, 2 and 10. And they even updated the description of 2. So this is actually, place of service 2 was used just kind of across the board for home services. Now place of service 2, effective January, but for Medicare, it's April 1st. Place of service 2 is meant to be just for services that are considered telemedicine, but not performed in the patient's home. Place of service 10 is performed in the patient's home. So there's a big distinction. So I would imagine there's going to be some confusion around that as well. So now we've talked about some modifiers in place of service. There are a ton of procedure codes. I'm not even going to go into all of them. I'm going to go into some. So what do we look for in the data? You want to look for multiple members who have a data service with a provider who is an excessive distance. Now, if they're doing psychotherapy, it is possible that is legitimate. Maybe they really are truly far apart. But when you start to see a pattern increasing in the distance, then that's something that you're going to want to take a look at. You're going to want to look at those distances again, but then start to look at the prior relationship between the provider or the referring provider. Always, always, I know it's kind of cliche for those who understand fraud, waste, and abuse, but DME services is always a hotbed for fraud. So look for the referring provider for the DME and look for the relationship, especially if the DME company is far away. Look for providers who are performing outside their scope of specialty. This happened a lot over COVID, and I have one example at the end of a scenario that applies to this statement here. Again, look at the referring providers, look at the relationships, and just look for anyone in general who has just an increase in telemedicine services. And also compare that to what your state kind of laws were during COVID. Some states, had more times when people were just more locked down and everything was remote versus others. So compare that to that provider's billing. Another thing to keep in mind for CMS, they have the COVID-19 expansion with the CMS 1135 waiver. And this is still going on because the public health emergency has still been extended. So what this just did is, there's a whole bunch more that's part of it, but Medicare basically has to pay the same rate, whether it's telehealth or not. The patients can be in their home. There's more services that can be allowed to be done in the home. So just be mindful and keep an eye on the public health emergency. It keeps getting extended. I'm sure it's going to get extended at least one more time. That's just my guess, but just keep an eye on that. Another thing that's really interesting is a company called Fair Health, if anyone's familiar with them. They do a lot of tracking of the data. They actually said, this may have even been updated in the last couple of weeks, but they compare each month, and they also compare months to the prior month of the prior year. Telehealth services actually started to decrease just a little bit. about 4%, which may not seem like a huge amount, but it actually is. So we are starting to see less people using telehealth services, but still more overall than it was happening 2 years ago. In fact, in October and September of 2021, the top 5 services, 3 out of the top 5 were related to psychotherapy. So people are still taking, I don't want to use the word advantage, I think it's just a different lifestyle now, but people are still using telehealth to get their services in the behavioral health arena. If you're not familiar with the services that are now allowed to be done via telehealth, telemedicine, then you can go right to CMS's website and you can pull the list. And in the list, you will see the date in which that code became allowable to be performed at home. And I know probably in the back it's probably a little hard to see here, but you can pull the spreadsheet. So for example, there are codes on here that were actually added last year, March of 21, not even just added when COVID really started hitting in 2020. So tympanometry, acoustic threshold testing, these are ear tests. So I know there is equipment out there where you can kind of do things over the phone, but I bet people are taking advantage of some of these. So let's talk about a couple of specific examples. And we've seen this a lot. We work with a lot of different MCOs, and there's a couple of areas that people are taking advantage of. One is autism and ABA. So this is just one example of one provider who posed as a provider. They weren't even a provider. So they stole someone else's credentials, stole their NPI information and started billing, and they claimed to be performing therapy for autistic children. So having people, again, being at home makes it a little bit more of a challenge sometimes. You're not going to someone's office. You maybe not be seeing all of their credentials on the wall, although people can fake that too. So seeing increased unlicensed or lack of specialty in an area is something that we've seen a lot, and this is just one example. But in addition to that, what we saw with autism is a lot of upcoding of time spent and just not billing for things that didn't happen. So I won't go into all the details of the codes. There's actually a ton of different codes, some that require one-on-one, some that are group, some that have to be done by a physician, some that can be done by more of a technician. But a lot of these codes do have a time component to them, so you can verify if you have records or interview patients how much time has been spent. So in addition to that, these codes, we're talking about that list from CMS, became allowable to be billed while the patient is at home effective April 30th, 2020. So they were not allowed to perform these services for autistic services at home prior to COVID. In addition, there were some code changes, and again, I won't get into all the weeds. This will be here for you, but there were 2 codes that end in the letter T. That means that they're considered to be temporary codes. They're kind of like wannabe codes, and they haven't really been promoted to a real code yet. So they were actually deleted and replaced with real codes in 2019, but some providers were still billing these. So that was another thing we saw, just as a side note. And you want to look at the diagnoses. These are some examples. So for these children, I'm going to talk about some a specific case with some children. You might see things like autistic disorder, encephalopathy, potential seizure issues, developmental disorder of speech. So you might see some of these. These are some of the diagnoses that we were seeing in the data. In and of itself, this doesn't ring any bells when I'm looking at data or running analytics. But what was kind of a concern is that we had the ABA therapist billing one of the codes, 97155, with the modifier 95, which is that original modifier we talked about, for 2 hours and 45 minutes a day. And then they were also billing another hour of family therapy for the same patient, so almost 4 hours. Now, I've done a lot of research with ABA. I actually have a staff of clinicians as well who who have both personal and professional experiences with ABA, and it's really difficult to have a child of any type of conditions or not have any conditions sit there for 4 to 6 hours plus. So when we see, especially with ABA, they start billing for 4 or 5, 6 hours. In some cases, I've seen people bill 8 hours a day, and really all they're doing is babysitting. These are some red flags. When we actually sent surveys out to the patients, the parents sometimes will respond, not always. You get maybe a 15% response rate, and sometimes you'll call as well. They said it was 2 to 2.5 hours. So they're definitely, padding the time. So you always want to look for that as well. And things that you can do, just anomalies in the data, look for more than 5 days, look for more than 4 hours, and there's just some specific types of analytics that we run. Look for inappropriate ages. Some people have policies or some plans have policies over a certain age, it's not covered, or it's covered under a different benefit or a different plan. So just things that you're going to want to look for. Another case, this is actually, there's still some ongoing things, but during COVID, there was a national telemedicine company. So they were already a telemedicine company, but during COVID, their billing increased just dramatically. So that was also kind of a red flag. They only really did telemedicine before, and then all of a sudden their billing just started rapidly increasing. But they were billing for a code, S0311, Comprehensive Management and Care for Advanced Illness. It's supposed to be billed once a month. So when it says advanced illness, you're going to probably see something that is more severe, like Alzheimer's. That's typically what they're doing. But this particular company, they were billing for every day of the week, lots of time in a given day, more times than once per month. Things just didn't look right. So just, I know we don't have a ton of time left, but just real quick, when we looked through this particular client's data, this particular screen is a snapshot of all codes billed across the entire data set. Most of the highest paid codes were ambulance codes. This provider, this one code stood out across the entire set of data. So as we continued to dig in, I'll just skip ahead a little bit, we saw that they were billing on 100% of their patients, this S0311. They were also the highest for how much it cost per patient and the number of visits per patient as well. And very, very few other providers were even billing this code. So you dig in a little bit more, and they were billing it with the modifier GT. That's one of those modifiers we talked about. And when we started to look at the types of diagnoses, you remember I said it's an advanced illness, probably going to see Alzheimer's, you might see end-stage renal disease. But when we started digging into the actual claims, they were putting diagnoses like this: cardiac murmur, hypertension, GERD, dizziness, giddiness. These would not be indicative of an advanced illness. As it turns out, there were a couple things happening. They were billing for services that they didn't perform, but in addition to that, there were actually, kind of going back to our care conversation, there were actually patients who legitimately needed the care and they weren't providing it and ended up, passing away maybe earlier than they should have. So this particular client has been, going after this provider, and there's a lot of legal things going on with it. But they did, there's a lot of stuff happening with this provider and referring providers and performing providers associated with this company. When we looked at the map, they were based out in San Francisco, but most of the patients that they were doing the telemedicine were in the LA area. And their website is kind of interesting. It actually has some conflicting statements on it, where it talks about how a nurse will come to your home, but then it also talks about how we'll, set you up with equipment to talk to your doctor. So what are they really doing? Because that care management code, which is the only thing they build, there's nothing on their website that described anything related to it. So for those who, again, work with your fraud areas, research the internet, research whatever information you can dig up, because it's not just your claims data, it's all this other piece of information that can provide some context as well. when you looked at the calendar of services, you can see here. Now, a lot of telemedicine companies have a lot of people that work for them, so it's not abnormal necessarily to see this huge volume. And I know it's really tiny, but these dates of service, I'm going to just kind of read some numbers. The one I have highlighted in red, 201 members in a given day that they perform telemedicine services. So they have to have a really huge operation to do that. So you want to make sure you understand how many people allegedly work for them and get proof of that. Again, this company had a lot of issues, and this is just one of many where they were not really performing the services. So things that you need to do, in this fraud world that I'm in, you get records, you interview patients, you do surveys, you just gather as much information as you can, and you just keep going. So for those of you who missed the original story, just got to be tenacious, like I was with that dermatologist, and you just got to keep going because when you know someone's doing something wrong, just don't want to let them get away with it. So still ongoing, still some things being worked on with the legal departments. So just to reiterate how this case came about, things you look for, outliers with codes and modifiers, billing patterns, the distance, how many days a week are they billing for, all of these things in this particular case all stood out. So they were kind of an outlier in every single analytic scenario, and they got caught. Another thing that's also important is just making sure documentation, so when we looked at the medical records, make sure the documentation is in line with what it's supposed to be. Some plans have some slightly different language and terminology as far as what's considered appropriate for documentation, but there are some generic guidelines. This is just a sample from a HEMA, so it's good to follow, but to make sure that the services are supported, they should be documented appropriately. All right. Well, just in time, we have one last little story. I mentioned earlier on of providers who are performing services out of their specialty. So this is not an uncommon scheme, these telemarketing schemes, and this is not behavioral health, but I'm throwing this one in because it's happening a lot, not just in this scenario, but just around COVID in general, and medications and other things. Members' names are being sent out. How they get there, you may not always know, but providers are either calling members based on the list or they're just submitting for services without ever actually seeing the patient, so that's one scenario. This particular provider was an OBGYN, and they had this just sudden increase in members in a given day. The members were male, and there can be some legitimate reasons for that. So it's not always a red flag, but the diagnoses had nothing to do with OBGYN services, whether they were male or female. The diagnoses were knee pain, back pain, wrist pain. And it turns out that they were working, this OBGYN was working closely with a DME supplier and just calling people on her days off and just sending out DME stuff. So that's happening with DME. It's happening with medications, knee pain. If anyone follows things in the news, there's just been a ton of different medications and compound drugs that have followed the same exact scheme. So there was a pharmaceutical manufacturer, Horizon, that got in trouble regarding Pensaid, which has diclofenac in it, which is a pain cream, and a bunch of other drugs as well for knee pain and arthritis pain. So be on the lookout for members calling that say, I never spoke to this doctor, I never saw this doctor, and then they're getting either meds or they're getting DME stuff sent to their house. So lots of stuff. We could talk about fraud all day, and I know you're looking at me, and I know we're already behind from lunch, so if anyone has any questions or ever has anything fraud you want to talk about, as you can see, I'm very passionate about fraud. I still think about that dermatologist to this day, and many others. So please feel free to contact me anytime. Happy to talk about it, and thank you for having me.
Thank you, Karen. And guys, you will be getting copies of these presentations, and they will go out next week in case you didn't hear that. So I am now your chairperson too. And I would like to introduce Cynthia Norm Mulder, who is a frequent speaker of this and other of our events, and we love to have her because she is so passionate about what she does. And I think you're really going to enjoy her talk. And I'm going to keep that introduction simple as I pull up her presentation.
And I'm getting out of your way, I promise.
No worries. All right.
So you're going to right to go forward, left to go back, and there's your laser pointer. Okay, great. Karen's going to be a tough act to follow. All I can say is we're both from New Jersey. We both have parrots. We both love animals. So I guess you saved the best for last, right? That's great. So I'm from Englewood, New Jersey. I work for Englewood Health. I live up in the northern part of New Jersey, up in the mountains, and I have a beautiful drive commute every day on the way in. On the way back, it's a lot of traffic. I work for a 400-bed facility. I am a specialist in pain, palliative, and addiction. We provide those services for the inpatient population at Englewood Health. We also have a 700 provider group that we have outpatient facilities, and we have our own outpatient office in which we see our palliative care patients. I'm real happy to be here, and I'm honored to be here, and I thank Pam for inviting me back. The last time I spoke live for this conference was just the end, I think, of 2019, perhaps in Arizona. And the difference with that was, at that point, we were reporting statistics in 2018. 2018 was very exciting for time because everything seemed to be doing better. The opioid crisis, though it was continuing, it was the first year in 2018 to show a reduction in overdose deaths. And then what happened? The pandemic. We had lockdowns, we had isolation, we had stress, we had loss of support systems, inability for our members to go to meetings. We had relapses, and we had increase in deaths and relapses. Many numbers went up. The most recent reporting that we have is from June 2021. The 12 months prior to that, we're seeing over 100,000 overdose deaths in those 12 months from June. So it's terrible. Before I came here, like I said, I'm a pain specialist, a palliative specialist, and also we get called for all the patients in the hospital with opioid use disorders, addictions. And before I came here, my two specialties overlapped when I got called to the ICU for a 24-year-old that was brain dead, that they were calling in organ transplant on, and we needed to speak to the family regarding end of life. And it's very difficult. All of you know someone who's 24, your children, your grandchildren, your nieces, your nephews, somebody who watches your kids. And the sad part about this case and many of the cases that we have is that at 24, he had been addicted to opioids from having a sports injury, also had depression, and was taking the opioids and became addicted to them, and had absolutely no idea that there was a fentanyl crisis out there. He had no idea that his 2 opioid pills that he took that day were laced with fentanyl. He went into respiratory arrest. He was alone, cardiac arrest, no Narcan. He was placed on a vent, and before I took off in the middle of a snowstorm last week, the sharing network was coming in for organ transplant. So these are the stories that we have now, and today what I hope to do is talk about where we came from. I think a lot of us know that, but I'm going to go over it quickly, where we're headed, and how for our members we can prevent and treat opioid use disorder and prevent overdose. So I'm going to talk about the factors that got us here, identify the opioid abuse morbidities, because not only is there just the crisis, the addiction, there are a lot of other comorbidities that exist with it. And we'll talk a little bit about alternatives, what we've done, and discuss current prevention treatments. I have nothing to disclose. So when we talk about prevention and treatment, it's a huge spectrum. It's that initial day use of someone who goes to the dentist and has a tooth pulled. And it goes into misuse, addiction, relapse. I'm not going to talk a lot about NAS today, but also neonatal abstinence syndrome, disease that's caused by addictions, overdose, and death. So real briefly, I'm going to kind of touch on the opioid crisis. How many people have seen Dope Sick? Okay, good. I would say it's about 50%. So I won't have to go into a lot. I have 2 residents every week that follow me, and their assignments, they're with me for 2 weeks, and their assignment is to make sure that they catch Dope Sick. It's 8 episodes. They tell me that after watching it, even if they're into the 3rd episode, their life, how they practice and how they see healthcare and the opioid crisis is dramatically changed. So I highly ask you to take a look at it. A lot of it is factually based. But we know that it started, there's a pain management movement a while ago. We know that, it's important. I stand up here today to tell you that my palliative patients have difficulty getting their opioids. They're not in stock. They have to wait 72 hours because the pharmacies are afraid to carry them. So we have a lot of issues with that, but pain management is important. When we go into the various times, we look back in 1995 where pain was the 5th vital sign. We focused on that as being important, and the way we focused on that was saying, well, opioids help to take care of that. We need to treat your pain. OxyContin in 2010 was followed by a massive overprescribing of opioids. We looked at Portnoy, who I'm sure many of you have heard that story from that, where he lectured, and I was at lectures with Dr. Portnoy, where we said there was no pharmacology ceiling, you could keep going up. So doctors continued to prescribe. Was that a myth? Yes, of course it was a myth. Patients were being prescribed high doses of oxycodone, OxyContin, and when they didn't get better, they would keep going up higher. So we believed at that time for it to be a legitimate way to dose opioids. In 2016, the CDC recommended ceiling doses. Use caution prescribing any opioids. Assess for evidence of benefits. Was OxyContin the chief driver of the heroin explosion? Well, let's go into that a little bit. In 1996, they marketed it as a powerful 12-hour pain medication. It was 12 hours, but it could be crushed, chewed, snorted, injected, and swallowed. In 2007, Purdue pleaded guilty to misleading consumers about risk of abuse and received $600 million in fines. So you definitely wanted a lot more information on Dope Sick on that. In 2010, it was reformulated, and the FDA approved it an abuse-deterrent opioids, and we've had more since then. How many people here from Florida? Oh, good. Everybody else, so it makes sense, right? You're here. You didn't have to fly out. This probably is a very common photo for you. A lot of the pill mills, they weren't only solely in Florida. We had them in Jersey. We had them in New York, where people would go to get their medications. They would pay money. They would pay cash for it and get their opioids. So when the drive came to close down the facilities and the opioids, 3 out of 4 people started to use heroin. They originally, if you look at it, they originally were using opioids, but they had no access. I'm just going to stop there for a minute. I want to tell you an interesting case. We had an 82-year-old female on Medicaid. She was receiving oxycodone, and then her pain wasn't getting better. She went on to OxyContin. She would come into our hospital system. We did not treat her in our facility. She had an outside physician. And when the whole opioid crisis started up and they started closing down pain clinics and looking into that, her primary doctor, who was prescribing OxyContin 20 twice a day, a lower dose, but still a dose, and some oxycodone 3 times a day, said to her, "I'm not allowed to prescribe anymore." Well, the truth was they're not allowed to prescribe. They didn't want to prescribe. So they would leave these patients on opioids out there. She didn't know what to do. She had some aides in the building that said, "You know what, you can go down the street and get your oxycodone." So she started doing that, and she had COPD. We won't even talk about respiratory and opioids, that's another issue. She took her oxygen tank down to the local dealer, and while she was there, she kept spending $10 per pill. And the dealer said, "Why are you using so much money for this? I can give you heroin." So at 82, she said, "I don't want to inject heroin." He said, "I'll show you another way to take it." So she started doing heroin, ended up coming into our emergency room, our critical care unit. And when we did a urinalysis, we were quite shocked to see an 82-year-old on heroin. But this is how it progressed into that. Okay. Besides, we all know what opioids do, addiction, but there's a lot of morbidities. In those 2 weeks that my residents spend with me, they see other things. Cellulitis, abscesses, cardiac. Our cardiologists are shocked at how much endocarditis they treat now. That's one of their main, while their other things have gone down and their endocarditis has gone up. Pneumonia, PEs have become a problem along with COVID. So we've had multiple. We have patients that are addicted that had pneumonia, that now have COVID, that are in ICUs, along with injuries and falls. So this is the evolution of the opioid crisis and the overdose deaths. As you see, any opioid is high. As you can also see, heroin is going up dramatically. And then there's illicit fentanyl. So what happened? We had an opioid crisis that collided with the pandemic, in which collided with an increase in illicitly made fentanyl. So do I think the numbers were probably going to go up after 2018? Without a doubt. Did they go up quicker? Yes. Will we see them continue to go up? Yes, unless we take care of the fentanyl crisis. Why is fentanyl in it? It's because it increases the potency of low-quality heroin. What's the outcome of that? Well, obviously, overdose, also a rise in children without parents. I was telling someone I was cutting down my lecture, and I took one picture out of 2 parents slumped over the front seat driving with 2 kids in the back, and now those 2 children are orphans. And children accidentally ingesting and overdosing. You see that very often with now with fentanyl especially. So I like to show this because I think it's dramatic if you haven't seen this before. Why is fentanyl deadlier? So if you look on the left, you see the heroin. If you look on the right, you see the fentanyl. It's only a tiny grain. These are the stories that you hear of EMS workers going in and police officers going into cases where someone's down and there's fentanyl out there and it's absorbed through their skin. A penny is there to show you the difference. It's 10,000 times more potent than morphine and extremely potent. There's fentanyl and there's also sufentanil, so it's very, very potent. In those last couple of months, 12 months prior to April 2021, which is our later statistics, we've seen a 28.5% increase, and there's over 100,000 drug overdose deaths. So we have a service to our Medicaid population to prevent and to treat opioid use disorder. So everybody's talking about it. What are we doing, right? And everybody's talking about it because dope sick's out there too, right? Everybody's like shocked. I have nurses that come up to me and say, "Did you see this? This is unbelievable what's happening out there." Well, Medicaid is definitely finding solutions. Increasing coverage and access for medication-assisted treatments, addressing opioid overutilization among enrollees. One of the things that they do is there's letters that go out to the providers and let them know that their amount of prescribing of opioids is higher than their peers. and also for each individual patient that they're at too high of a dose, so that it makes them aware of that. Constantly tracking those that are receiving more than 90 or more of morphine milliequivalents. Providers' prescribing practices are compared to peers, not only by Medicaid, but also in hospital facilities. We developed an opioid task force, and we have everyone on that task force, from IT down to dietary, down to the nursing staff, the emergency room. And this opioid task force has come up with many things that we've implemented. And one of the things is we look at our prescribers. In the state of New Jersey, we're only allowed to prescribe following a surgery 5 days of opioids. And the patients are given a contract, they're given a titration schedule off on how to come off of that. But what we did at our facility is we cut it down to 3. After 3, they need to follow up with their physician or see someone if they're still having pain. Another very important thing to do that you should find that all your providers are doing, if you have a patient that's in the hospital and has had a surgery and they haven't used pain medication in 2 to 3 days, do not prescribe opioids to go home with. We have put into place Altos that we'll talk about in a little bit. Altos are alternatives to opioids. I've been doing pain management for 20 years. I never believed that someone could have knee replacement and not take an opioid. They can. We do Tylenol, we do gabapentin, we do Advil, we do Celebrex. We do things out there that control their pain, and guess what the best friend is? Ice. We forgot to use ice. We've gone away from that, and we were giving opioids instead. We have patients that have hips and knee surgery and take no opioids at all. They're discharged, back surgeries are discharged within 3 days. They maybe for 2 days haven't been using opioids. There's no reason to give them opioids. Why do you think people do give them opioids? Any idea why the physicians give them a prescription to go out the door? Right, it's right, very probable. They want to make sure that their pain's controlled, but also the patient gets discharged. They don't want them calling them to say, hey, I got pain, I don't know what to do. Oh, just take it in case you need it. Just get it filled in case you need it. But without telling them what to do with that medication, if you don't use it, don't fill it. If you do fill it, dispose of it directly. Well, we've gone a step further and said don't prescribe it. If the patient's having a problem with pain, there's a 24-hour call service you call, and maybe something other than that, maybe something for spasms would be ordered, right, if they've had back surgery. So let's go into the spectrum of prevention and treatment. So primary prevention targets our entire population, all of our Medicaid patients, not just those that are at risk, but we look at those that are at risk. We have an opioid risk assessment tool integrated into our EMR. Before we prescribe opioids, we have to fill out that opioid risk tool. And it will give a number to our patients that maybe have had a family history, have had use of risk of opioids in the past, and that at least puts us aware of that. And then we implement a plan to avoid any overuse of medications. We also, before we prescribe, our PMP, which is your prescription monitoring program, is embedded in the EMR. And by being embedded, before you prescribe an opioid, you have to go into there and say that you read it, looked it over. And of course, the PMP is where you see that your members may have multiple providers that are giving them opioids, or one provider that's giving opioids and another provider that's giving them benzos. Any sedatives mixed with opioids are a very big problem, because that's the combination that we see patients overdose with. So we also we control access, safe storage, and disposal. We talk to patients if they're in the office. We have all our primary care providers make sure they have a contract. They do urine testing. You're testing to make sure that the patient is taking the medications that you're prescribing if they have a chronic pain syndrome, and that's even for your oncology patients. One thing I'd like to suggest, and we're trying to work on that, Narcan should be part of the the physician monitoring program. I can see if other doctors are prescribing opioids. I can't see if they gave the patient Narcan, and they should, so that they have it in the house. Alternatives to opioids are targeted at different things that can help with their pain, including trigger points, where your opioids are really reserved for severe traumatic pain. Dental, you should be using Advil. You should be using acetaminophen. Secondary prevention is the addiction screening, referral to treatment programs. MAT works. We found the best thing to do in our emergency room was hire 3 social workers that are there 24 hours a day. They immediately meet with the patient. They get them enrolled into a program. We have navigators and coordinators that follow to make sure that these patients are continuing. We do telehealth just to make sure that they're being followed. We have programs that they can view through telehealth. And the ideal would be mobile MAT, because especially in many areas, we're pretty local and we have hospitals everywhere and programs everywhere. But out in other areas, there's really no access to the MAT programs for these patients. Neonatal abstinence syndrome, you need to make sure that it begins at prenatal screening. So many Medicaid patients have co-occurring problems, and that's the mental health illnesses and conditions have to be treated along with that. Screening programs have to be looked at, they need to be followed, and need to have compliance with the programs. And then there's tertiary prevention, and that's your overdose. Narcan is great if someone else is in the room with you, but if you're alone, that Narcan doesn't help. We have to look at Good Samaritan laws and collecting overdose data, increasing comprehensive and timeliness of surveillance data, and making prescription drug monitoring programs easier to access. Like I said, we actually paid to have ours embedded into the EMR. It really should just be open for everybody so that we all can see that. Work with health systems, insurers, and communities to improve opioid prescribing. And prevention. Education is the key. We're out in the community. We're educating the healthcare providers that many do not know what's actually going on, and seeing that. We're right in the front line. We're out there. We know what's happening. We educate patients and families. I have patients that come in that maybe are using heroin. They come in for cellulitis, and they know nothing about the fentanyl problem that's going on with heroin. And they are happy to hear the education and to know what's going on. And their first thing they say is, I don't want to die accidentally. Educating on side effects for all of your patients on opioids, using navigation systems, whether it be nursing, whether it be care coordinators or social workers, identify inappropriate prescribing, addressing the stigma of opioid use disorder. You still see that out there. You still see, oh, well, that must be a bad person that's using. And that's not what it is. It's a disease process, and we try to make sure we educate everyone on that. Using Altos, Dr. Alexa LaPietra from my area in St. Joseph was the first to utilize that and did a great job from the emergency room on. 10 years ago or 5 years ago in the emergency room, patients used to come in. If they had any type of pain whatsoever, they would get 2 to 4 milligrams of morphine or 2 milligrams of Dilaudid. Many would come in asking for that, and now no opioids are used in emergency rooms, not in the area where we practice or up in northern New Jersey. We use alternatives to opioids. We talked about the 5-day prescription, cutting it down to 3, giving patients titration schedules off, identifying risks. The best thing to do is, starting back at that spectrum, keep the opioid-naive patient opioid-naive. Treatments ensure that there is access to early treatment and prevent gaps in care. Don't have the patient go to the ER, survive an overdose, and discharge. I used to see that years ago at another facility. They would come in and they would just go out. Okay, yeah, you survived it. Now follow up with a behavioral health somewhere. You have to follow that patient and you have to coordinate that. Make sure they're in an MAT program. It's the gold standard. Methadone and buprenorphine prevents the withdrawal and decreases the opioid use. There is excellent clinical evidence of that. Utilize calls to assure follow-up. Promote access to the non-opioid therapies. Support innovation with delivery models. What's working for you? What works in other states? When you come to conferences like this, what is working in their state? Don't reinvent the wheel. Utilize a program that's working well. So qualitative initiatives, we want to develop community-wide consumer education. Healthcare providers and specialists work with health plans to ensure members receive safe pain management, support education, and identify high-risk patients. The patients that need opioids, we want to make sure they get them. We want to utilize CDC's guideline for prescribing at the lowest dose, the shortest duration, with close patient monitoring. Continued goals is public awareness, provider education, PDMP practice, and instituting policy within different institutions so that they follow it. It's a great system, but if you're not using it, it doesn't work. Improve access and availability of Narcan. Increase rates of identifying the addicted population. Improve accessibility coverage for MAT. And overall reduce the overdose deaths moving on. So that next year, when I come here to talk to you, we could go back to below our 2018 statistics. Any questions or comments?
I'm sorry, could you hang on? We're still streaming.
Sure.
I'm sorry about that. What was the name of that video that you referenced
There
earlier?
is a series of 8 episodes called Dope Sick.
Dope Sick.
By Macy, who is an author who did a lot of work with the Appalachian overdose, and it's based on some fact. Of course, it's a drama, but it's based on a lot of fact. Good. Yeah, definitely watch it. Definitely life-changing.
Hello, my name is Michael Oliveira from Cordata Health. I am interested in understanding how you're measuring or effectively assessing your program and the outreach that you're doing today.
That's a good point. We use our EMR system and follow-up to measure what's happening. We have research projects that have been going on with our residents on opioid reduction and also with our doctoral students. So we have quite a few research. We have one that's just being published right now. It's going through. And it shows that our reduction in using Alto for our post-operative patients in the hospital has significantly decreased the length of stay, decreased the patient's usage of opioids. The patients are up and out of bed earlier, and also they have decreased nausea and vomiting because they're not on opioids. So we are looking at that. Yes, we have navigators that follow up, and right now we're just on a 6-month to 1-year study. Collecting the data is important, especially for your facility, to support those social workers in the ER, to support more of the staff coming on board to follow up. Okay, very
Fantastic.
good.
Thank you
All
so
right,
much,
thank
Cynthia.
Everybody have a safe trip home, even if it's just Florida.
All right, so we still do have some virtual sessions, and we do have the speakers available for questions, and we are still streaming, so we're just going to continue playing them. Probably not going to do the big introductions because I don't have a chairperson, and we want to keep it moving along. So at this time, I am going to play the North Carolina presentation, which is behavioral health focused.
And it's trickier than you think to talk to you guys and to open this, so let's bear with me 1 second.
Good afternoon, and thank you for allowing us to participate in this wonderful workshop virtually. My name is Suzanne Thompson. I am the Community Engagement and Empowerment Team Leader with the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And we are going to talk to you today about stakeholder engagement, maintaining and increasing engagement during a pandemic. So the key objectives will be creative ways to engage, meaningful engagement, topic-driven engagement, and how has communication and engagement changed during the pandemic and preparing for a new normal. When we first started looking at different ways to engage people during a pandemic, we didn't think we would be 2+ years into this and still looking at different alternatives. So, since January of 2020, we've had to really look differently at how we engage our stakeholders. And so we've really looked at ways to engage virtually versus in person. So virtually, we've used a lot of conference calls, various different platforms such as Microsoft Teams, GoToMeeting, Zoom, WebEx, and we have partnered with our PBS North Carolina affiliate to do Facebook Live events. Now, the positives to the virtual engagement are we are able to reach more people, that we have little, if any, travel time. We have the ability to add more subject matter experts to the conversation, and we have more opportunities for our stakeholders and decision makers to actually connect. In North Carolina, we have various stakeholder groups, and our leadership engages with them on a regular basis. So we've looked at ways to continue that engagement and to increase that engagement. We also, in addition to meetings, we've looked at different ways to communicate outside of just meetings. Now, when we've done in-person engagement pre-COVID, and we are starting to get back into some of the the in-person events, we did a lot of town halls, we did some focus groups, we did targeted stakeholder meetings. We also we have what's called a State Consumer and Family Advisory Committee meeting monthly, where our department leadership participates in that, and that is actually a statutory mandated consumer advisory group. The advantages to the in-person engagement are they're small groups with direct connections and allow for personal connections between the stakeholders and the decision makers. Some of the disadvantages are scheduling, the travel time, the inability to have large groups. Also, the number of people we reach in a small event versus what we can do virtually. The last town hall meeting we did prior to COVID, we had about 110 people at our town hall meetings that we did virtually. Our average participation in the Facebook Live event, or the viewings either the day of the live event or since, has been about 5,000 people. So the amount of people we reach is very different, but the personal connections are really important. So we strive to get back to those. So with the different things, we want to make sure that any engagement we do is meaningful. And by that, it will be with a purpose. We don't meet just to meet. And so we always strive to answer two questions. What information do our stakeholders need from us? And what information do our decision makers need from the stakeholders. We allow time for questions. We keep the time of the event to a maximum of 2 hours. And we do have a process for receiving and answering questions outside of the meetings. For our topic-driven engagement, we limit the meetings to 1 to 2 topics. We make sure that the topics we're discussing are meaningful both to the stakeholders and the decision makers. We limit the times of the meetings, and we allow questions. For example, we have had meetings related to electronic visit verification. We've had meetings related to specific topics on flexibilities that we've done as far as billing flexibilities and virtual visits versus in-person visits during the pandemic. So when we do schedule the meetings, we do post what the topics are so people can make sure that if it's a topic that's important to them, that they participate. So ways that communication has changed for us during the pandemic is we've moved to more electronic communications rather than in person. We do a lot of emails. We use a lot of social media such as Facebook and Twitter. We have worked on making our websites more stakeholder friendly. We have worked on making our posting of information to our websites more timely. We have designated email addresses to receive questions. We also have web forms where people can submit questions. We have processes for tracking and answering those questions. And then we have engagement through virtual means, such as our Facebook Live events, our different platforms. And in doing that, we have had to work with our stakeholders, specifically our consumer and family populations, to ensure that they understand the technologies that we're using and have access to the technology that we use. So here are the examples of how we get questions in. So we have different email addresses, and these are just a couple examples. And then we have behind the scenes processes. We use the ServiceNow platform to generate tickets from these email addresses, and then we have subject matter experts that go in and work the tickets, answer the questions, and then once the questions are answered, it automatically generates a response back to the person who answers the question. In addition to the email addresses and the web forms and the tracking of questions, we do track the questions that come in through the question and answer features or the chats in our various webinars, and then we get those questions answered after the fact. So, we've done this. We also send out, email information, whether it's about our stakeholder meetings, it's about surveys that we need answers to questions on, it's national trainings that we want to alert people to, it's in-state trainings, trainings that our community engagement and empowerment team staff do. We also have a monthly newsletter that has links to our website, has links to Medicaid's website, links to in-state trainings, national trainings, information. We've done a lot of wellness and stress management and recovery training, not only for DHHS staff, but also for the public over the last year. So last year and a half. So we do have links to all those and links to where people can find the recordings. And so that's all available to people on a regular basis. And as we continue to educate stakeholders and staff on the use of virtual technology, we're also looking at ways that we can do hybrid events. And we have started that with at least the State Consumer and Family Advisory Meeting. We started back in September, where we offered the virtual platform option as well as an in-person option. We do really emphasize that people submit questions either through our web forms or our centralized email addresses to allow us to make sure that we track the answers. We are exploring other options for engaging stakeholders, such as utilizing a YouTube-type channel to post our trainings and town halls so that they can be viewed at future dates. When we do have our stakeholder meetings, here is an example of different resources that we post during every webinar where people can click on the links. They also get these slides so that they have them in an electronic version. They don't have to remember the website addresses. In addition to all of the webinars and the different email blasts we send out and the newsletter, Medicaid has published 222 special bulletins during COVID with changes and directions and things to make it easier for providers and beneficiaries to understand the system to receive services on all those range of topics. And so here is the contact information for Deb Goda and myself, and now we will be able to stop and answer questions for you.
Amy, are we able to pull them in? They're here in the waiting room.
Hi, guys.
Hello, who are we talking with?
This is Deb Goda with NC Medicaid.
Hi, Deb. Great to hear from you. Is Suzanne coming in as well?
Yes, this is Suzanne. So. I'm here as well.
Oh, okay. Awesome. Awesome. Yay. Thank you for taking a few minutes today, and thank you for putting together that great presentation. It's appreciated. So anybody have any questions for Suzanne or Deb? Ladies, to be honest, our crowd has dwindled a bit in person front, as you can imagine. But I don't see any hands, so I guess not. Is there anything you would like to say to the group?
I think the one of the best things that we did was we
Yikes. Ladies, I'm
the
sorry.
stakeholder callers so that
Okay, we had a bad connection, so I appreciate your calling in, but I think our connection isn't good, so we probably should just wrap it up. But we appreciate your presentation, and thank you very much for calling in. My apologies.
No worries. Thank you.
All right, take care, ladies.
Thank you.
That. Okay. Now we are going to move on to the next session, which is Liz McCune, who is with Passport in Kentucky, who was acquired by Molina pretty recently, I think. And Liz put this session together for us. We could not figure out how to get it to advance on its own, so that's going to be my job. All right, and good.
Good afternoon, and welcome to Tweaking Models of Care, Better Meeting the Needs of Individuals with Substance Use Disorder. Hi, I'm Elizabeth McCune.
Avi, can
I'm
you
Associate
bring
Vice
up the
President of
presentation?
Population and Behavioral Health Strategy at Passport Health Plan by Molina Healthcare, located in Louisville, Kentucky. I am so sorry I couldn't be with you in person today. However, I'm joining via phone and will be available to answer questions at the end of our session today. Good afternoon.
Hang on.
As part of our time together this afternoon, I'd like to share some information with you about our model of care for working with individuals with substance use disorder. We've spent a lot of time working on this model over the last year and trying to tweak it so that it better meets the needs of our members. As part of this process, we utilize assessment tools that assist us in stratifying our members. Along with this, we've added new roles to our model, and I'd like to share information with you about the individuals and the roles they play. Lastly, I'd like to share with you information about how we wrap the social determinants of health into the model to better meet the needs of the whole person. During the past couple of years here in the United States, we've spent a lot of time focusing on the COVID-19 pandemic. But another problem that has caused heartache for many across the country has been the steady increase in overdose rates as well. I wanted to share some of the statistics that we reviewed in thinking about our model of care and why we needed to do a better job in order to serve our members better. According to the National Center for Drug Abuse, NCDA, and the Center for Disease Control and Prevention, the CDC, in 2019, nearly 50,000 people in the U.S. died from opioid-involved overdose. That's 70.6% of all drug overdoses. The economic burden of prescription opioid misuse alone in the United States is $78.5 billion per year. This results in about 21 to 29% of patients prescribed opioids for chronic pain misusing them, and between 8 and 12% of people using an opioid for chronic pain developing an opioid use disorder. About 80% of people who use heroin first misused prescription opioids. So when we talk about substance use disorder, it's difficult to not begin by thinking of opioid use disorder. With our model of care, that's what we were thinking of first, were those individuals who had been using opioids. The model is open to individuals who use other substances, but our primary focus began with opioid use disorder. During the past couple of years here in the United States, we've spent a lot of time focusing on the COVID-19 pandemic. But another problem that has caused heartache for many across the country has been the steady increase in overdose rates as well. I wanted to share some of the statistics that we reviewed in thinking about our model of care and why we needed to do a better job in order to serve our members better. According to the National Center for Drug Abuse, NCDA, and the Center for Disease Control and Prevention, the CDC, in 2019, nearly 50,000 people in the U.S. died from opioid-involved overdose. That's 70.6% of all drug overdoses. The economic burden of prescription opioid misuse alone in the United States is $78.5 billion per year. This results in about 21 to 29% of patients prescribed opioids for chronic pain misusing them, and between 8 and 12% of people using an opioid for chronic pain developing an opioid use disorder. About 80% of people who use heroin first misused prescription opioids. So when we talk about substance use disorder, it's difficult to not begin by thinking of opioid use disorder. With our model of care, that's what we were thinking of first, were those individuals who had been using opioids. The model is open to individuals who use other substances, but our primary focus began with opioid use disorder. The Kaiser family. During the past couple of years here in the United States, we've spent a lot of time focusing on the COVID-19 pandemic. But another problem that has caused heartache for many across the country has been the steady increase in overdose rates as well. Providing case management, I wanted to share some of the statistics that we reviewed.
I'm sorry, guys. Hang on. I'm not sure what happened.
In thinking about our model of care and why we needed to do a better job.
Oh my goodness.
In order to serve our members better. According to the National Center for Drug Abuse, NCDA, and the Center for Disease Control and Prevention, the CDC, in 2019, nearly 50,000 people in the U.S. died from opioid-involved overdose. That's 70.6% of all drug overdoses. The economic burden of prescription opioid misuse alone in the United States is $78.5 billion per year. This results in about 21 to 29% of patients prescribed opioids for chronic pain misusing them, and between 8 and 12% of people using an opioid for chronic pain developing an opioid use disorder. About 80% of people who use the specific screening.
You guys.
First misused prescription opioids. So when we talk about substance use disorder, it's
okay. Yeah. Maybe we should do that. I apologize, folks. Hi, Liz. My apologies. Are you with us? I think you're muted. Liz? Oh, dang. Are you with us, Liz? All right, I apologize because I had to advance this myself and the mouse just got kind of wonky. I mixed this up, so I sincerely apologize. Can you hear us? No. Okay, everyone will get a copy of this, so they will get to view it properly. And again, my apologies, everyone. Thank you, Liz.
Hi, I'm sorry.
Oh, there you are. I'm really sorry.
That's okay.
The computer went a bit haywire, and I was just having to advance it myself. It wasn't doing what I was expecting it to do for some reason. So, and the audio wasn't jiving with it. So, my apologies. But we wanted to patch you in and see if there's anything you wanted to say to the group. We will be sharing the presentation with everyone, so at least they'll have that, but I do apologize.
Oh, no problem. I don't know if you want me to speak to any of the slides, if you would want to show them, or if there's any questions based on the limited information. Basically, what I did was I shared how we came together with our new model of care and what our experience has been thus far in implementing it.
Okay, let me see if I can pull up the slide without it playing the audio, then maybe we can do that. What number should I go to?
Oh, shoot, I'm gonna have to leave the screen and go to because I'm in Zoom and I'm in the other format online.
Okay. This may not work despite our valiant effort. I
can't see the slides now when I came back over to Zoom.
Gotcha.
I was trying to be in both formats, so.
Okay. I think people will give us a little bit of grace here. And, and again, I do apologize on my end. I'm not super adept at these things and am learning. So thank you for working on the presentation and for calling in. And we will share this with the group after the fact.
Okay.
Okay. Thank you. Stay well, Liz.
All right. You too. Take care.
Okay. Bye-bye.
Bye-bye.
All right, sorry guys. Okay, so we have one final session, and that session is good to go. I don't have to touch it, so I probably, hopefully, can't screw it up. And I know
Make sure
we have to go to 15 seconds. Okay, and if we
Hi,
could
good
show the
afternoon.
screen.
Today we're talking about implementing CalAIM's Community Supports Program to address social determinants of health, health equity, and long-term well-being. I'm Pooja Mittal, the Medical Director of Population Health Equity here at HealthNet. We're a large Medicaid managed care organization in California.
And good afternoon. I'm Nancy Wangvipeth-Kalev, Senior Director of Systems of Care at HealthNet. So today's focus in terms of CalAIM's Community Supports Program really stems from our regulators' program implementation of an innovative initiative called CalAIM. In California, our regulators for Medicaid, the Department of Healthcare Services, has launched CalAIM, which stands for California Advancing and Innovating Medi-Cal. CalAIM leverages Medicaid as a tool to help address many of the complex challenges facing California's most vulnerable residents. And they include individuals experiencing homelessness, insufficient behavioral health care access, specifically those experiencing serious mental illness and substance use disorder, children with complex medical conditions, the growing number of justice-involved populations who have significant clinical needs, and other vulnerable populations. CalAIM also recognizes the opportunity to provide for non-clinical interventions. So social determinants of health related interventions focused on whole person care approach through Medi-Cal that target SDOH and reduce health disparities and inequities. And so as you can see here, CalAIM presents a unique opportunity for managed care plans to closely collaborate within their counties. And at HealthNet, we are in 31 different Medi-Cal counties. CalAIM is a multi-year initiative, 5 years starting in 2022. We just launched in January of this month to improve the quality of life and health outcomes for our populations. And the key elements include three-pronged. We're gonna focus on community supports today, but essentially all three really support one another and complement one another in the delivery system. So the first being population health management to cohesively address member needs across the continuum of care, enhanced care management or ECM, which is a collaborative and interdisciplinary approach to provide intensive and comprehensive care management services, and then community supports or CS, which previously was called in lieu of services, so really meant to be in lieu of more costly services that are state benefits, such as unnecessary emergency room use or hospitalization. And they are flexible wraparound services integrated with population health strategy, and essentially are SDOH or social determinants of health types of services. Next slide. And before we describe, Dr. Muthal will take us through a case study that wraps around ECM and community support services.
Today we have the Gonzalez family. Mr. Gonzalez has diabetes, which is poorly controlled. He doesn't always take his medications regularly. He's been having a lot of difficulty finding steady work during the pandemic as he works in the food service industry, and his place of work shut down early on. He is part of a family of 4. They have 2 children, and Mrs. Gonzalez has intermittent depression that's been recently worsened by their housing instability due to lack of work, and also food insecurity, again, due to lack of work. So we're going to come back to this family after we talk through what these services look like and talk about how it might affect a family like this.
Great. So to provide an overview, enhanced care management are essentially 6 components. There are 6 components of ECM that is meant to be a wraparound service, but also the role of enhanced care management is to coordinate all primary acute behavioral, developmental, oral health, long-term services, really all of the services together to support the member, including participating in the care planning process regardless of the setting. And so ECM, or Enhanced Care Management core services, include 1 comprehensive assessment and care management plan, which essentially is an ECM assessing and developing a person-centered care plan, incorporating the member's clinical and non-clinical needs, enhanced coordination of care, where there is organizing of the patient care activities according to the care plan, and a continuous and integrated, among all service providers with regular contact with the patient in strengthening their skills. So health promotion is also part of building the skill set for the family and the community supports unit. The fourth area is comprehensive transitional care, which is engagement activities that seek to reduce avoidable admissions and support care transition plan activities. The fifth area, which is key to supporting the member, is the member and family support. So really serving as the primary point of contact for the member and their chosen family support persons, identifying supports for the patient and their support network. And then finally, coordination of referrals to community and social support services, which essentially is integrating with social care needs, housing, food needs, as well as other wraparound services. Next slide, please. This show, and actually, I'm sorry, can you go back to the previous? Thank you. I should note too that for enhanced care management, what's unique about this program is that we're not contracting with traditional providers or medical providers. An ECM provider could be a community-based organization, could be a rural health clinic, it could be a county provider, it could be a behavioral health specialist. So really integrating a provider network that reflects behavioral health, physical health, and social care providers. With community supports, these are the wraparound services that supplement enhanced care management services. And there are 14 Department of Healthcare Services approved, so regulator approved 14 services that are considered community supports that are deemed medically appropriate and cost effective in providing care for our members. And they can be bucketed into 4 different areas: housing support, which includes housing navigation, tenancy, and deposits; transitional support, which is really helping with community or nursing facility transition to the home or to a facility; post-acute support services, which is short-term post-hospitalization housing; recuperative care, sobering center services, respite services, and day habilitation services; and then at-home support, personal care and homemaker services, home modifications, medically tailored meals, as well as asthma remediation. Sorry, the next slide, thank you. This is really shows all the work and integration coordination between the different health, behavioral health, and social care systems that have been integrated to become CalAIM. So ECM and community support serves as an additional layer of support, and really it's intended to complement current county programs. And so you can see sort of the different programs that ECM will be integrating with in terms of the Medi-Cal managed care plans, fee-for-service, Medi-Cal County Behavioral Health Agency, and the County Human Services Agency. Next slide, please. Wanted to share, so you have context in terms of our populations of focus for ECM. We are phasing in the implementation in terms of the first priority implementation being members or patients who are participating in our current state pilots called Health Homes Programs and Whole Person Care Programs. So enhanced care management really transitions over for those members as well as individuals experiencing homelessness, those who are high utilizers, with chronic conditions and behavioral health conditions, and adults with serious mental illness and substance use disorder. And we are phasing by counties as well. So various counties, depending on the programs that are in place. And every 6 months, we are expanding to additional populations of focus, as you can see here. For example, in January, ECM goes live for those transitioning from incarceration, adults and children. And then in July of 2023, really all of our children and youth. Next slide, please. In terms of community supports, we're also phasing in various community supports. It's important to note that ECM became a benefit within the health plan as of January, whereas community supports is optional for health plans to scope in, to really scope in as wraparound services to help manage care. And HealthNet has decided to scope in a significant number on day one. And as you can see here, we scoped in based on our various counties, and they include housing transition navigation services, housing tenancy, so really helping our members find housing or keep their housing, recuperative care, meals, sobering center, asthma remediation. And then every 6 months, we can add additional social determinants of health interventions or community supports interventions. And we'll be adding housing deposits and home modifications. Next slide, please. This really provides some description of what these services are. So in terms of housing deposits, for example, we'll be providing funding for one-time services necessary to establish a household. And the housing deposits are typically provided and assessed through the housing navigation specialist, which we're also offering as a service. So housing transition navigation services, as well as housing tenancy services. Recuperative care, which is really around short-term residential care for members who no longer require hospitalization but still need to recover. They also tend to be individuals facing housing insecurity, and so that becomes a benefit as well as of January of this year for us. Respite care is another benefit, short-term post-hospitalization housing and sobering centers. Next slide, please. And really this provides some descriptions, again, of the other community support services, asthma remediation, which is physical modifications to a home to mitigate environmental asthma triggers. These social care interventions and really addressing environmental health factors has now become a benefit or a service within the health plan where we're integrating social care services to improve health outcomes for long-term well-being. Day habilitation and others are listed here as well. Next slide as well. Back to Dr. Mithal. And we'll share with you some of the outcomes of integrating these services for the Gonzalez family.
Thank you. Mr. Gonzalez qualifies for medically tailored meal supports, and we were able to connect him to culturally tailored and diabetic-friendly meals. And with that, he receives a nutrition assessment, 2 meals a day for 12 weeks delivered to the home, all of which help him get started on having a healthier diet and learning to eat better. His ECM case manager also notes food insecurity for the entire family and provides resources for them to receive supplemental food sources. The ECM case manager also refers Mrs. Gonzalez to a behavioral health provider and helps to coordinate the care between the physical and behavioral health providers. This is part of the enhanced care coordination of care that we see with ECM. And so as you can see, these additional services that are being provided through this new program really do help to create a safety net that is a social safety net on top of the medical and behavioral safety net that we as a plan provide. In addition, we see in terms of the long-term outcomes that Mr. Gonzalez is able to decrease his A1C from 10.2 to 8.5, and he's motivated to continue to eat healthier, exercise, and take his medications regularly. Mrs. Gonzalez had more significant depression than was initially noted, and so is in therapy on an ongoing basis. And her depression is also being managed by her PCP through medication. Because of the management of her depression, she's more motivated to cook healthy meals. She goes to the park with her kids, and so they are all getting more physical activity and are healthier as a family. Family has been able to get CalFresh benefits, which are SNAP benefits, and so have access to more food that is healthier with more variety. And the family is also able to access housing tenancy benefits and have more stable housing support, which decreases the overall stress on this family. I will kick it back over to Nancy to close us out, but we hope that you've had an opportunity to understand a bit better about the new services and supports that will be available through CalAIM.
Thank you, Dr. Mithal. We recently launched, as you know, CalAIM, and so we will be learning from our experience, gaining feedback from our providers, iterating on our program design for the next 5 years. And we look forward to the partnership with our providers or county partners. And if you have any questions, we're happy to share any of our lessons learned along the way as we implement. We'll have our information for you shortly after the session. Thank you.
Thank you.
Do we have Nancy with us? Hey, Nancy. How
Hi
nice
there.
to see you.
Thank you. I'm only able to see a black screen, so
Oh,
not sure if I should be seeing any of the beautiful faces out there.
no, it's kind of one-way communication. I'm sorry about that, but we
No worries.
see you and your lovely background. So, and thank you so much for the presentation. It was great. As I mentioned, we do have just a handful of folks left, being the late hour and everyone trying to catch planes, but we at least wanted to give folks the opportunity to ask any questions. Does anybody have any? Come on, guys. No. Unfortunately, people really haven't been checking in with questions virtually, and I think we're all about done. But we will be sharing your session with everyone, with the wider group as well. Is your email information on the slide? I didn't see.
You know, I don't think so, but I can send information, and I don't know if you're able to see the chat if I put my information. I will send over my information for the group, my email.
Okay. So guys, it's nancy.wongvipat, WONGVIPAT, at healthnet.com. So if you have any questions for Nancy offline, you can reach out to her that way. Thank you so much for your time, Nancy. We greatly appreciate it, and we thank you for putting the presentation together. And we hope to see you in person next year.
Yes, looking forward to it. Thank you, and safe travels home.
Thank
for the
you.
rest of the crew.
Have a great day. Bye. Okay, thanks for hanging in there with us, guys. I hope you enjoyed the event, and I enjoyed meeting all of you. Hope you have a safe trip home. And to those joining virtually, thank you for hanging in there with us, and we'll see you next year. Thanks.